Okay, John, we can start now.
Okay, hold on, Sam. Let me get my screen together. We got a few minutes, right, Sam?
I will welcome all, then Professor Abu Zaid will start.
Okay, Sam, we got a few minutes, right?
Okay.
Does anybody need to get let in? Is everybody in that should be in? The first presenter. Please take your presentation off the screen, please. When you introduce yourself, we want the people to see your face. Okay, Doc? Okay, Doctor? And then, so they see you and you say, you introduce yourself and then you go to the presentation. Because we're all beautiful. Hello, Martin. I'll try to get you in here. Oh, you're on your way. Hello, Martin.
John, hello there.
I think you know Sam, right?
Can you hear me?
Sam, you know Martin, right?
I don't hear anything, but anyhow, you
Okay.
seem to be hearing.
You can hear me, Sam, right?
Yes, yes.
Okay. Well, let me know, Sam, when you want to start. It's no hurry on my part, whatever you want.
Okay, please go ahead.
Go ahead. Okay. Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is right here, beautiful Miami Beach. It's 7 a.m. here in Miami. I'm Dr. John Bennett of Neurosurgical TV. And I'd like to introduce another collaboration between Neurosurgical TV and EWNC, led by the indefatigable Samuel L. Morsi. And I'll let him lead the proceedings from here. Hello, good morning, Sam.
Good morning, John. Good day for every one of you. When I have started EWNC Academy 7 years back, no one believed that we will reach all these heights. No one believed that we are unique. No one believed that we can reach the first small island in this world. No one believed that we can touch every heart of our specialty member in this world. No one believed that we can bond every neurosurgeon and spine surgeon in this world by very strong bonds that are not easy to fade away. No one believed in EWNC. Now reality says we are able to make dreams come true. For past 7 years, we didn't stop learning, everyone in our specialty, for a minute. And here we are to celebrate 7 years of non-stop neurosurgery and spine education, pure neuroscience. And now we will start our brain day celebration by Professor Abuzar. Please start sharing your screen. Thanks a lot for joining us today. Thank you.
I would like to thank for your kind invitation. It's an honor to be here. I'm working in Yeditepe University with Professor Tu and Ashagi. Today I will talk about the supracerebellar approach and its variants. And I don't have any conflict of interest, but I have a big team behind of me. The data used from our articles and our data case and the Roton collection. As you know, supracerebellar approach has variants like median, paramedian, lateral, and extreme lateral. And as you see, the angle and the distance always change if you change the angle which you enter. And mostly used for pineal glands. And also you can use posterior interhemispheric, but today we will talk about the infratemporal surface and the supracerebellar approach. Which structure you can reach via supracerebellar approach? As always, no pineal gland and superior colliculus, inferior colliculus, trochlear nerve. But if you want to reach the structures below the superior colliculus, it is better to use a paramedian or lateral approach to avoid occultation of the vermis. And also you can reach brainstem, third ventricle with suprapineal approach, and upper surface of the cerebellum. And after opening the tentorium, transtentoral approach, you can reach thalamus pulvinar surface and branch of T2 and T3, and also parahippocampal javus and mesial temporal structures. This is an 3D models of this approach, then the structures you can reach. And also you can see the P2 branch and thalamus cisternal part, and also parahippocampal javus. And as you see the galenic venous system, and after opening the tentorium, you can reach the P2 branch and the parahippocampal mesial temporal structures. And as you see, after opening the tentorium, you can reach we are looking from the superior, you can reach the P2 branch and the hippocampus. When we open the craniotomy, you can reach this space and the bridging veins. And because of this, I always use the unilateral craniotomy to preserve the vermian and medial side bridging veins. As you see, after opening the craniotomy, you can reach the bridging veins, and it's better to preserve these bridging veins with dissecting. As I said, I always use unilateral craniotomy and median, paramedian, and lateral approach to reach these structures. And when you go deeper, also you can see bridging veins in both sides. And also you can see their drainage pattern of these bridging veins. When you go deeper, you can see galenic venous system and corpus callosum pineal gland, and also medial posterior choroidal artery. And we are looking a bit from lateral. As you see, without occultation, you can reach the pineal gland and the superior collicle and inferior colliculus. And after opening to tentorium, you can reach mesial temporal structure and P2 branch. And also endoscope can help you, and also pure endoscopic approach described. And another issue is the positioning in neurosurgery. You must think patient safety, surgeon's comfort, optimal trajectory, and using gravity, avoiding attraction and drainage. In supracerebellar approach, prone, sitting, semi-sitting, and lateral position have been described, and mostly used one in semi-sitting and the prone position. This is a prone position and our incision, and this is the semi-sitting position for supracerebellar approach. Because of the using gravity, but also it has a risk of venous embolism. And also we recently described an position for supracerebellar approach, dynamic lateral semi-sitting position. We just had opt and changed the position during the surgery. As you see, this is the drawing from John William. We educate this position. We use this angle while opening the craniotomy and the dura. And after opening the dura, we change the angle and get the same sitting position to use gravity. And while closing, we change the angle again. And I want to show some video of anatomy and my cases. This is our opening. We open the a bit above the sagittal sinus and open the door. And this is the 3D model of this approach. You can see all structures, and I will tell one by one. Opening the tentorium, you can reach parapocampoidus and mesial temporal structures, and directly from median or lateral approach, you can see pineal gland just under the corpus callosum and superior colliculus, under it the inferior colliculus, and ambient system and the brain stem you can reach via this approach. And when we look a bit superior, you can reach suprapineal from suprapineal way. You can reach the third ventricle and the pulvinar. Also, you can reach this structure contralaterally, but it's not needed for most of the cases. For example, you can use this contralateral approach for brainstem or the pulvinar or thalamus tumors. And as you see in this video, a bit lateral approach without attraction, you can reach the midline structure like pineal and superior colliculus. And I will show some illustrative cases. First case, thalamic cavernous malformation. 20-year-old male with headache and right side hemiplegia and hemiparesthesia. As you see, you saw pulvinar thalamic cavernoma. I used lateral semi-sitting position. And our craniotomy, we can use the sagittal sinus and our craniotomy. You can see the sagittal sinus, sorry, transverse sinus. And first we open a small dura to release CSF from cisterna magna, and then open the dura parallel to the transverse sinus. Firstly, we dissect the bridging veins to preserve it from the cerebellar surface and the temporal surface. As we showed before, we want to use this way for rouge to thalamus. If you need, you can cut the tentorium, but in this case, we didn't need to cut the tentorium. Without cutting it, we can reach the lesion and remove it. After removing the cavernous malformation, this is the postoperative MRI. And for midbrain cavernous malformation, 2 years old male with imbalance, she came. As you see, this is a midbrain cavernoma, and we decide to enter lateral. We decide to use lateral mesencephalic sulcus, and after opening the arachnoids, I want to brainstem and midbrain. We describe the lateral mesencephalic sulcus. As you see, we want to enter from there. And after opening the lateral mesencephalic sulcus, we reach the cavernoma. And without any problem, we could remove. As you see, we use the lateral mesencephalic sulcus. And it is mostly used for pineal tumors. The same craniotomy, and we are lucky with this time we don't have rigid veins, only arachnoid attachments. We cut these attachments. And reach the pineal region after opening the arachnoids. But we use a bit lateral approach to without retraction. As you see, the pineal mass reach directly from a bit lateral way. This is the postoperative view. You can see the removal of the tumor. And this is the P2 aneurysm case. As you see, the wide neck P2 aneurysm, we decided to use the supracerebellar transtemporal approach. This is the same with the other cases. Opening the dura, and we open the tentorium here from posteriorly, then goes anteriorly, and we try to reach ambient system and the P2 branch. Firstly, proximal part and the aneurysm. As you see, we see the proximal P2, temporary clip, and put a permanent clip to aneurysm and controls, and put additional clip to remnant of the aneurysms. Most of the people use temporal approach, but we decided to use this approach without any retraction. This is the postoperative digital angiography. And also you can use the lesions located in the superior surface of the cerebellum. Like in this case, I want to show the video, but only show the MRI. And lastly, I want to show a case which use the contralateral approach of the stem carcinoma. As you see, this is the preoperative and postoperative view, and this is the 3D model of our laboratory in Editepur University. As I said, I'm working with Professor Tur and Yaşargil. Whenever you want, you can visit and mail us. I want to thank all my colleagues, and I want to invite you our courses to International Rotom Society meeting and Erdoğan İstanbul Yaşargil Neurosurgery course in August this year. And this is a small video of our laboratory. Working stations, and our medical administrator, Arlene. So we did a good job. And our international fellows. Also, we have an endoscope in our laboratory. Thank you very much for listening. If you have any questions, I can answer.
Thanks a lot, Professor Abuzar, for this excellent presentation. And my question about most common complications that you have faced from your experience and how you manage these complications. Thank you.
The complications is in this position venous embolisms and the pneumocephalus. Because of this, I changed the position while opening and in intradural space. Before the opening dura, I used a lateral position to avoid air embolism. I looked all bleedings and coagulate everything. After control all bleedings, I changed the angle in semi-sitting position, and after before closing, I changed the angle again to avoid pneumocephalus.
Okay, thank you. Is there any question from panelists?
Yes, this looks very, very nice. It reminds me very much of the times with Professor Yaşargil in Zurich. So, but it's much nicer now. So, congratulations. I have one little question regarding maybe also for more junior surgeons. These supracerebellar infratentorial approaches, it is very important to maintain the 45-degree angle towards the midline because the cerebellum is curved like that. When you divide the tentorium, it is not always clear where the sinus starts, and also sometimes you might encounter some bleeding from some bridging vein that is cut off too close to the dura. And so what are your tricks to deal with this kind of situation regarding division of the tentorium?
If are you talking about the tentorial angle?
Yeah, well, first of all, when you divide the tentorium, often you get more bleeding than you want because unfortunately there is a venous channel there.
Yes.
So what do you usually use for that? Just cautery, or just give us some overview of your tricks, technical tricks.
I always use Doppler ultrasound to determine the venous lakes. Because it can bleed if you open the just above the venous lakes. Because of the avoid this, I always use. And also you can see if you have the wide angle, you can see the venous lakes above the tentorium.
And if they happen to bleed, what is your trick? What do you do? I have my tricks, but what are yours?
Bipolar coagulation. I'm doing bipolar coagulation and put some sutures and on it. Change my angle and also again the lateral position to avoid venous embolism. This is my tricks. I want to hear yours.
Are you using some glue to glue some hemostatic material to the duras, or to make sure it sticks there?
Yes, I use also this hemostatic material, also fluid seal, maybe some storage cell. I can put and make some pressure on it and wait.
Wait and maybe put some glue so it really stays there. Okay, thank you very much. Very nice cases you showed us. Thank you very much.
Yes, Martin, could you please introduce yourself?
Yeah, I am a consultant here, program director here in Dubai and in Rashid Hospital, and so I worked with I mean, I was a resident, that is, in Professor Yazagil's clinic at the time, and later on I was fellow in Toronto with Gentili, and I worked in Auckland where I had a lot of my training. So briefly, that's my
Martin,
story.
you're always welcome. And Carlo Bortolatti has a question. Go ahead, Carlo.
Hi, I'm Carlo Bortolatti. I'm vascular neurosurgeon from Bologna, Italy. Compliment for the beautiful presentation. My question is, do you have some experience, or what do you think about the use of esoscope for this kind of approach? Because I think it would be very useful.
I don't have any experience, but as you know, I always talk with Sharon, and here he has this exoscope is a good thing for supracerebellar approach. But I didn't use, but I talk with the IPE. He's saying it's a good for supracerebellar approach. Also, maybe Vladimir can say something.
Thank you.
Yeah. Can I?
Yeah, go ahead, Vlad. Vlad, go ahead.
Abu, excellent lecture with excellent anatomical dissection and very thoughtful. I just would like you to turn a little bit laterally, and suddenly you will find a completely new targets for this excellent approach. You will end up in the lateral CP angle. You will get as far as petroclival region, and you will start doing petroclival meningiomas using this approach. It's beautiful. But I would remind you, this is what I was asking about the exoscope. It's beautiful, but it's pretty difficult because your angle of vision is lateral and your wound is on the opposite side. So it's pretty difficult to get the hands into the wound. It's not automatic as in all the other respects. Abudr, congratulations. Great.
Thank you very much. It's nice to see you. Okay.
Yeah, Vlad is a neurosurgeon from Czechoslovakia. Hello, Vlad. Vlad.
Not anymore Czechoslovakia, John Bennett.
Oh, I'm sorry. I made that
The country was
before.
divided in 1993. This is 30 years ago.
Oh,
Yes,
God.
they are the best.
Gotta go back to school. Okay, any more comments, questions? Okay, Sam, I'm sorry to barge in there, but go ahead, Sam.
Thanks a lot, Professor Abuzar, for this excellent presentation. Thanks all for this nice discussion. And now we will shift to next speaker, Professor Abida Shah. Please start sharing your screen. Thank you.
Hi, Sam. Hi, John. Can you see my screen?
Yes.
Yes.
You can
Good day,
hear me?
Abby. Yes,
Yes.
perfect.
Okay. Hello, everybody, and thank you, Sam, again for this excellent webinar and for this invitation. So today I'm going to be talking about supratentorial ventricular system and anatomy, and I'll just show a few cases, but mainly I'm concentrating on the anatomy. So this is the ventricular system as we know it, the lateral ventricles, which has all the parts, the frontal horn, the body, the temporal horn, the occipital horn. Then that goes on from the foramen of Monro to become the third ventricle, the aqueduct of Cilius, and then going down into the fourth ventricle. So when the initial development started embryologically, so this was the brainstem with the thalamus around it, thalamus sitting as a head on top of the brainstem. And around this structure formed the neocortex. So there was a telencephalic fissure which separated the forebrain from the interbrain. And then as this folding occurred in both the rostral and the caudal directions, the ventricular system took shape and developed this C-shaped cavity, as you can see here. This was in concordance with all the structures that come around this lesion area. All of these structures developed a C-shaped formation, as we will see in later images. So this is how the folding occurred and how the ventricular system developed and how the temporal horn, which was initially in this position posteriorly, was dragged down to come here into the base of the temporal lobe. So the ventricular system basically curves around the thalamus. It goes rostrally, it goes posteriorly, and then it goes inferiorly. So the thalamus forms the key location around which the ventricular system developed. Another interesting thing that we should know is the hippocampus, when it was actually formed, was dorsally located. It was located right above here. But as the corpus callosum invaded into this, and also due to the rostral migration, the hippocampus came down here to obtain its position in the medial wall of the medial base of the temporal horn in this region. And some part of the hippocampal formation remained here as the inducium griseum, and most of it came down here. And this area was invaded by corpus callosal fibers. And as we will see how they form the roof of the ventricular system. So this is just a basic understanding of the embryology. And to show you the other structures that form a C shape because of this rostral curving of the hemisphere. So this is the corpus callosum. This is another fiber tract that we will see. This is the stria terminalis. Similarly, the caudate head also turns around it and comes here all the way to end in the near the amygdala as the tail of the caudate. And the next structure that curves is the hippocampal formation with its fornices. So all these structures are integral to understanding ventricular anatomy. And if you understand this C-shaped curvature, to understand the formation of the ventricle is easy. So now you look at this image. I've cut this specimen into half, and this is the medial half of the other hemisphere. And you see how the ventricular system has curved down here. This is the temporal horn, and this is the atrium. This is the hippocampus that you see here. This in this region is the thalamus. So the whole ventricular system has curved around the thalamus, and that is how it grows. And it actually, there is a choroid fissure here whose anatomy I will explain in later images. But this choroid fissure forms between the fornix and the thalamus. And again, it takes this C-shaped curve and goes around the whole ventricular system. This is the roof of the body and the frontal horn and the occipital horn of the ventricular system. And we will see all these structures one by one. Once you go from here from the frontal horn into the foramen of Monro, you enter into the third ventricle in this region. So let's start with the medial surface of the brain. So once you start dissecting in this, the first structure that when you cut it, you see the corpus callosum. So this is the rostrum, this is the genu, the body, the isthmus, and the splenium of the corpus callosum. So if you see here, the rostrum and a part of the genu forms the floor of the frontal horn of the lateral ventricle. This structure that you see here is the septum pellucidum. The septum pellucidum runs from the anterior part of the frontal horn and goes all the way posteriorly to where the fornix meets the undersurface of the corpus callosum. So this division where the septum pellucidum ends and the fornix meets the corpus callosum, so the part is where the body ends. That is the part where the body ends and then the atrium begins. So looking at this image, once I've removed the septum pellucidum, you see the ependyma of the lateral ventricle. This structure here that you see here is the fornix. This is the thalamus. This region between the fornix and the thalamus is the choroid fissure in which runs the choroid plexus. This structure here is the anterior commissure. Now, mind you, as I was telling you that as the hemisphere rotates and turns forward, it also develops an interhemispheric cleft, and most anteriorly, the depression that is formed there, it forms the anterior wall of the third ventricle, and that is the lamina terminalis. So if you go to see embryologically, the lamina terminalis is actually a telencephalic part, whereas the third ventricle is a diencephalic part. So the name lamina terminalis is an appropriate name because it is the terminal membrane which marks the extent of the forebrain vesicles. So now as I remove the ependyma, I see this structure, that is the caudate head. So that caudate head lies in the floor of the frontal horn and the body of the lateral ventricle. And later on in the temporal horn, it forms the roof, as we will see later. So now I've removed this part and you see the floor of the lateral ventricle. So this is the frontal horn, this is the body, and this is the part that is the occipital horn. So if you see here, in the floor is the caudate head, forming floor and the lateral part of the frontal horn. And here in the medial part of the floor is the thalamus. So this is the region of the thalamus. There is a groove between the thalamus and the caudate in which runs a fiber tract, that is the striate terminalis, and also accompanying it is the thalamostriate vein. Now looking at it from the top, here you can see the thalamostriate vein. Here you can see where the striate terminalis will run. Here, this is the caudate head as it is forming the part of the floor and the lateral part of the frontal horn. And here in the body, it is forming the lateral part of the floor, and the thalamus is forming the medial part of the floor of the body of the lateral ventricle. Going posteriorly, this is the region of the occipital horn. The occipital horn medial wall has two big prominences. So this is the first one. So you see this corpus callosum and you see the forceps major as they are turning posteriorly into the occipital lobe. This forms a bulb, a projection in the medial wall of the occipital horn, and that is the calcaire avus. The one below it is the bulb, is the projection of the collateral sulcus into the occipital horn, and that forms another projection on the medial part of the occipital horn. Anteriorly, the occipital horn is bounded by the thalamus or the pulvinar of the thalamus and the fornix, part of the fornix, and laterally it will turn into the temporal horn. So this is the blood supply of the ventricle, where you see this is the inferior choroidal point at the junction of the head and the body of the hippocampus, and the anterior choroidal artery enters here. The other arteries that enter into the roof of the third ventricle are the medial posterior choroidal arteries, and the ones that enter into the atrium or the lateral part of the occipital horn are branches of the PCA or the lateral posterior choroidal arteries. So these are the three main arteries that form the choroid plexus of the lateral ventricle. Just to show you some structures, this part is the thalamus. This is the striae medullaris thalami as they are going here and connecting to the habenular nuclei. And this upper leaf of the pineal forms the habenular commissure. The lower leaf of the pineal forms the posterior commissure. This is the pineal gland. This is the hypothalamic sulcus that divides the thalamus and the hypothalamus. Looking from the top, as I told you, branches of the posterior cerebral artery enter into the occipital horn and the atrium, and these are branches, the lateral posterior choroidal arteries, and that form part of this tuft of the choroid plexus that you see in the atrium. So this is about the vasculature, and this is how the ventricles are related to the topographic anatomy of the surface. So you see this, when you see the region of the insula, so the anterior insular point corresponds to the caudate head or the frontal horn of the lateral ventricle. The posterior insular point points to the atrium of the lateral ventricle. The subcentral gyrus, so this is the precentral gyrus and the postcentral gyrus. The subcentral gyrus actually sits on this Heschel's gyrus on the opercular surface of the temporal lobe. And here the hippocampus lies in close relation to the middle temporal gyrus. So these are the topographical relations of the ventricular system. Now this is a axial cut to show the other relations. So if you look here, this gray matter nucleus that you see here is the caudate head. Here posteriorly is the thalamus. And this structure that you see here is the fibers of the internal capsule. So in this region and this region, the internal capsule is buffered from the ventricle by these gray matter masses. But in the region of the foramen of Monro, this corresponds to the coronal suture. You see that the genu of the internal capsule is in direct contact with the ependymal surface, and here it is liable to injury during ventricular surgery. And this is the whole tuft of the choroid plexus as it is going from the atrium to the lateral ventricle body and frontal horn, and then curving into the foramen of Monro. So we've seen the roof, we've seen the floor, we've seen the walls of the ventricle. Now what forms the roof? The roof of the ventricles is actually formed by the corpus callosum. So you look at it like this, the corpus callosum actually goes bilaterally into both the hemispheres and then turns downwards and turns upwards. So this downward turn actually envelopes the whole ventricular system within its cavity. So you see this dissection. These are callosal fibers. Some of them are projecting up. These are going anteriorly. That's the forceps minor. These are the forceps major. And you see here, I've removed some part of the fibers, and you can directly see that you are in the atrium of the lateral ventricle. So these curving fibers, as they curve laterally, they are called the fibers of the tapetum, and they separate this ventricle from the optic radiation. If you see this, these are the anterior curving fibers of the callosal radiations, and this is the forceps minor, and they form the anterior part of the wall of the frontal horn of the lateral ventricle. And as we have seen earlier, the forceps major form a bulge in the medial wall of the occipital horn, and that bulge is known as the calca ravis. So this is how the ventricular system is completely enveloped by these callosal fibers, and they are protected by, this whole fiber system. Here, just another image to show you. This is the ventricular system, and these are fibers of the tapetum. Entering here will directly take you into the atrium. So this was our paper on corpus callosum and its radiations, and it is an interesting paper. So this is a tractographic image to show you how the entire ventricular system is enveloped in this red fiber. So you see this silvery thing, whitish thing that you see is the ventricular system, and the corpus callosum fibers are completely enclosing it. Here you can see that these are fibers of the forceps major, as they are forming a bulge in the medial wall of the occipital horn, and this is how it is related. So basically the corpus callosum covers the entire ventricle. So lateral ventricle, there are many approaches to go to the lateral ventricle. Of course, you have the transcortical approach, the interhemispheric anterior approach, the posterior interhemispheric approach, the posterior transcortical approach, then occipital interhemispheric approach, the supracerebellar infratentorial approach, and then you have a subfrontal approach to the caudate head, as I will show you later. Now, when we do all these approaches, what should come in mind? What structures are we transgressing, and which will be the best bet to enter into the ventricle? So now this is just an image to show you the coronal suture. An important landmark is the coronal suture actually corresponds to the foramen of Monro in the and this is an important landmark that you should remember when you are operating. When you come interhemispheric, so when you're coming from an interhemispheric trajectory, you will not transect any of these fibers. You will straight reach the corpus callosum, and you perform a callosotomy, and you will straight enter the ventricle. On the medial aspect, if you come a bit laterally from the corpus callosum, this is the fiber bundle that you will transgress, and this is the fiber of the cingulum. More superior to the cingulum is the medial part of the SLF. So these are the fibers that are in danger when you're coming from an interhemispheric. But of course, if you retract the brain and you're able to reach the corpus callosum, you will not cause any major injury. When doing the callosotomy, an important point to note is, now you look at the direction of these fibers of the corpus callosum. They're transverse fibers that run from one to the other. So do not perform a vertical callosotomy, because by that you are cutting the fibers. All you need to do is split the fibers. So if you perform a callosotomy in this direction, in a transverse direction, you will not be cutting the callosal fibers. You will actually be splitting them and then entering into the ventricle. The safe parts to enter the ventricle are this anterior part and the posterior part here in the isthmus of the corpus callosum. You do not enter in this area, which I have covered with a black circle, because this area of the corpus callosum connects the premotor, motor, and sensory cortexes of both hemispheres to each other. So you either enter here in the anterior part, or you enter here in front of the forceps major to enter via the posterior interhemispheric approach. If you're coming transcortical, now what are the fibers that you will damage? Suppose you're coming from the middle frontal gyrus. The fibers that come in the way will be the fibers of the SLF2 and the SLF3. More laterally, of course, is the arcuate fasciculus. So the degree of damage that you're doing through a transcortical approach to the subcortical anatomy is more with a transcortical approach rather than an interhemispheric approach. So you see, this is the ventricle that I've superimposed on the white fibers. And you see, if you want to enter the frontal horn, the fibers that will come in the way are the fibers of the SLF2 and the SLF3. More laterally you enter, the fibers of the arcuate will also come. But generally, no one enters that way. If you enter from the middle frontal gyrus, these are the white fiber long association fibers that you will transgress. Now, this is a typical case that we have to handle, a colloid cyst. Just I'm showing you some images because I will not have time to show you the video. And this is a typical craniotomy for an interhemispheric approach to a colloid cyst. Now remember the difference between a cingulum and the corpus callosum. So the cingulum, you see this corpus callosum is completely white. Sometimes when the brain is tense, it is difficult to distinguish the cingulum from the corpus callosum. So the color makes the difference. The corpus callosum is whiter in color than any other structure, the corpus callosum here. And both the pericallosal arteries are there to guide you when you're looking for the corpus callosum. When you enter into the ventricle, the choroid plexus and the veins help you identify which ventricle you are in. This is the foramen of Monro, and you can see the colloid cyst. And the foramen of Monro, the boundaries are the column of the fornix anteriorly and the anterior edge of the thalamus posteriorly. And this is the choroid plexus. Now you see how the choroid plexus is draped around the colloid cyst. And this is the picture that you see after I've removed the colloid cyst. And this is the column of fornix. And posteriorly is the thalamus, and straight with this, you can enter into the third ventricle. So this is the most common approach. I've shown you the fibers that come by the transcortical approach. The other dangerous approach that in my estimation is an approach to the ventricle through the left parietal brain. There are so many structures, there are so many subcortical fibers in this region that if you enter from this region, there is a high chance of damage. So you see this is the occipital horn and this is the atrium. Now look at the fibers that come in this region. There are the fibers of the arcuate fasciculus as they are turning, the fibers of the middle longitudinal fasciculus, the fibers of the IFOF, the fibers of the anterior commissure, the fibers of the optic radiations, and the fibers of the tapetum. So to enter into the ventricle, when you're coming from that approach, you're actually transecting all these fibers and entering into the ventricle. So as far as possible, you can avoid this approach and use some other direct trajectory to enter into the ventricle. So these are all the fibers that come in play when you're entering from the left parietal brain into the ventricle. Now, this is another interesting approach that we have devised. Suppose your lesion is in the base of the frontal horn. There are many ways to approach this lesion. You can come interhemispheric ipsilateral, or you can come contralateral interhemispheric. But there is another way that you can go to approach this lesion, and I'll just show you. So this is the orbital cortical approach. Now this is your lesion. There is a tumor in the region of the caudate head. You can of course come from here, but look at the trajectory. It is quite long. Contralateral trajectory is even longer. But there is an approach from here. You can approach the caudate head from the subfrontal region. So this was described first by Professor Goel, transpulsine approach to contralateral hemispheric approach. We don't do this anymore. So this is the trajectory if you have to approach the caudate head when you're coming from an interhemispheric approach. But we have devised this approach where you come from the base of the brain. You can either come from the medial side where you enter into the middle orbital gyrus, or you can enter from the lateral side where you enter into the lateral orbital gyrus and straight reach the frontal horn or the region of the caudate head. What are the structures that come in the way? If you're coming from the medial, the only fibers that you will transect are those of the forceps minor. And if you come from lateral, you have to avoid the fibers of the IFOF, which generally are deeper down and do not come in the way. So this is a very elegant approach for lesions that are particularly in the base of the frontal horn. And this is just the anatomy showing how the IFOF is going from the base of the frontal brain posteriorly. And this is the uncinate fasciculus as it is turning into the temporal lobe. So there's another lesion in the caudate head, which we have used this lateral orbital trajectory and removed the whole tumor without causing any deficit. And this is again another tumor. This is the pre-op and post-operative image showing the resection. This is an AVM in the frontal horn, a small AVM in the frontal horn which had bled. And again, we use this subfrontal trajectory to remove this lesion. And you can see the pre-operative DSA and the post-operative DSA, and the whole AVM was excised. Now we've seen most of the parts of the lateral ventricle. Quickly, let's go to the temporal horn. So the temporal horn, to understand the anatomy, the key structure is the hippocampus and the fornix. So you see, this is the temporal horn. This is the atrium. This is the temporal horn. The hippocampus forms the floor, medial part of the floor of the temporal horn. And the hippocampus continues here as the columns of the fornix. Both the fornices are connected to each other by the hippocampal commissure. So this is how the fornix lies in the base of the temporal horn. Here you see these fibers that are forming on the hippocampus. These are fimbria that go on to form the fornix and the columns of the fornix, which end in the mammillary body. So this is from the medial aspect. If you are looking at the temporal horn, this is the cingulate gyrus. This is the parahippocampal gyrus. So cingulate continues as the parahippocampal gyrus. The lingual gyrus also continues as the parahippocampal gyrus. When you remove the gray matter of the cingulate gyrus and the parahippocampal gyrus, you see this cingulum, which ends here in the temporal horn as the radiation of the cingulum. The other structures that come into picture is, so when the parahippocampus turns, it turns medially to form the hippocampus, which again turns, and this turning forms the dentate gyrus. So you see this dentate gyrus with all its denticulations, which goes above as the subsplenial gyrus and goes above the corpus callosum as the remnants of the hippocampal formation. This is the fimbria forming the fornix. This edge where the hippocampus turns is called the subiculum. And this basically is actually part of the limbic system. And this is the Pappé circuit. So the hippocampus, the fimbria, the fornix ending into the mammillary body, the mammillothalamic tract, the anterior nucleus of thalamus, and then going ahead to form the anterior thalamic radiations. Here you can see here, these anterior thalamic radiations connect with the cingulum, which again comes back down and turns and ends in the hippocampal formation as the radiation of the cingulum, completing the Pappé circuit. And once you remove the whole thing, when you remove the caudate head, when you remove the ependyma of the lateral ventricle, the last fibers that you will see here are the fibers of the thalamic radiations, the anterior thalamic radiations, the superior thalamic radiations, the posterior thalamic radiations, and the inferior thalamic radiations. So this is the medial extent of the dissection. You can also reach the temporal horn when you come from inferiorly, when you come through the fusiform gyrus. And this is the anatomy when you come from inferiorly. So this is the region of the uncus. An interesting anatomical fact is this part, the anterior part of the uncus. So if you think this is a triangle, the anterior part of the uncus corresponds to the amygdala. The posterior part of the uncus corresponds to the hippocampal head. So now removal of the gray matter of the parahippocampal gyrus first shows these fibers here that are ending in this region. These are the radiation of the cingulum. Here you can see the fibers more clearly. Once you reflect the cingulum, you see the ependyma of the temporal horn. Once you reflect the ependyma, you see the hippocampus in all its glory. And here you see the amygdala. So see, this is the region of the uncus. The anterior part corresponds to the amygdala. The posterior part corresponds to the hippocampal head. And this is the fissure, the temporal horn, as it is turning into the atrium. And once you reflect the hippocampus and the choroid plexus inferiorly, you see fibers of the optic radiation or the Mayer's loop as they curve and form part of the lateral wall of the temporal horn. You can see these Mayer's loop as they are curving and forming the lateral part of the temporal horn. And this is a lateral view where you see the Mayer's loop and the optic radiations as they form the roof in the anterior part and the lateral part of the temporal horn in the posterior part. So temporal horn, how do you approach this temporal horn? This is important for tumors of the limbic system, for epilepsy surgery, and many approaches have been described. So there is a trans-Sylvian approach that you can see that can come here. Then there is an approach to the middle temporal gyrus and the inferior temporal gyrus. Then there is an approach to the fusiform gyrus. And then there is the supracerebellar infratentorial approach straight to this region to approach the mesial temporal lobe. Now, the approach that we most commonly use is the middle temporal gyrus approach, and I will tell you why. So this is the superior temporal gyrus, middle temporal gyrus, and the inferior temporal gyrus. Now, this is how the hippocampus is located anatomically in relation to the middle temporal gyrus. And quickly, these are the fibers that come. So the arcuate fasciculus, the middle longitudinal fasciculus. So this is the arcuate fasciculus. Once I lift this arcuate fasciculus, I will see the other fibers here. Just to show you, this is the uncinate, this is the IFOF, this E is the ILF. Once I lift the arcuate, I will see the IFOF as it is going. beneath that fibers of the anterior commissure, beneath that fibers of the optic radiations. Now you see this relation. Why the middle temporal gyrus approach? So if you see this temporal horn here, these fibers of the IFOF are here present in the roof, and more posteriorly, they form the lateral part of the temporal horn. So if you enter into this region, this orange circle here, and straight if you enter into the temporal horn, you will avoid injury to all these fibers. And then if you remain beneath the roof and just remain in this region, you will not cause any visual deficit to this patient. And this is the approach that we use for epilepsy. Again, you can see in this image, this is the hippocampal head and how the optic radiation fibers are related. So this portion where you see this pinhead, there are no fibers here and you will avoid injury. So this is the approach we use in our department. It was started by Professor Goel, the middle temporal gyrus approach. So you enter in this region and then you remain beneath the roof and you just remove this whole structure in block along with the amygdala, hippocampus, and the whole neocortex. And that is our approach for amygdala hippocampectomy. And this is the paper on the subject. Now, this is an interesting tumor that I did recently. This is an epidermoid. Now, where is this epidermoid? This epidermoid is in the region called as the choroidal fissure. So I will just show you choroidal fissure images. But if you realize when you enter into this choroid fissure, you can straight enter into the region of the ambient cistern by going through the temporal horn and opening the choroid fissure. So this is an intraoperative image where you see the hippocampus, this is the amygdala, and this is the resection cavity after the tumor has been removed. This is some part of the capsule of the epidermoid that you can see. Now coming to the choroid fissure and the third ventricle. So you see this region, this is the fornix, this is the thalamus. What is this structure? So the choroid fissure is actually a C-shaped structure that runs between the fornix and the thalamus. So in the lateral ventricle, here the fornix is in the roof and the thalamus is in the floor, whereas more posteriorly, the thalamus forms the anterior boundary, the fornix forms the posterior boundary, and inferiorly, the thalamus is superior and the fornix and the hippocampal formation are inferior. And the whole choroid fissure is a C-shaped structure in this region. Now, this is the region of the foramen of Monro, where if you enter, you will straight enter into the third ventricle. So now, as I told you, see, this is the region of the fornix, this is the thalamus, this is the hippocampus, and this is the whole C of the choroid fissure. Here you can see the star marked. So this is the thalamus and this is the fornix and this is the choroid fissure. What is the importance of this choroid fissure? Once you open this choroid fissure, you have a direct access into some deep structures. So if you open it in this region, you can straight into the quadrigeminal cistern. If you open it in this region, you can enter into the ambient and crural cistern. And you open it in this region, in the body and the frontal horn, you will straight enter into the third ventricle. So this is again a superior view of the choroid fissure where you see the thalamus and the fornix. And once you enter in through the foramen of Monro or beneath the fornix subfornicial, you will straight be into the third ventricle. And that is the last topic for this presentation, the third ventricle. So the third ventricle is a very beautiful structure that you see here. It has a roof, it has a posterior wall, it has a floor, and it has an anterior wall. So this floor of the third ventricle, you see these structures. This is the optic chiasm. This is the pituitary stalk infundibulum. This is the infundibular recess. This is the optic recess. And then the part. An interesting thing about the third ventricle is half of the third ventricle floor is formed by diencephalic structures and half of the third ventricular floor is formed by mesencephalic structures. So this part you can see that it's a tegmentum of the midbrain. Whereas here, these are diencephalic structures. You have the median eminence, the tuber ciliarium, the mammillary body, the posterior perforated substance. So that is about the floor. Here it is divided into the thalamus and hypothalamus by this hypothalamic sulcus. The superior limit is the striae medullaris thalami that run from this region all the way back to end in the habenular nuclei here. And then these fibers cross over in the upper leaf of the pineal, as I had shown you, as the habenular commissure. Now this image shows it more beautifully here. So this is the striae medullaris thalami coming all the way. This is the fornix and this is the choroid fissure. And then this next thing is the roof of the third ventricle. So this roof of the third ventricle is another important structure, and it has 4 layers. It is formed by the tila choroida. It has some vessels in it, the internal cerebral veins and the medial posterior choroidal arteries, and the superior most part is the fornix. The cavity between the 2 layers of the tila is the velum interpositum. The velum interpositum opens into the quadrigeminal cistern. Sometimes there is a huge cavity here that is the cistern of the velum interpositum. Otherwise, it just opens into the quadrigeminal cistern. And sometimes there is a cavity between the two leaves of the tila, and that is the cavum virgae. I think I need to end fast. Samay, give me 5 minutes, I'll finish. So
Okay,
this is this is the floor from the inferior aspect. I'm looking at the third ventricle. So the floor of the third ventricle, this is the anterior commissure. This is the optic chiasm as it is forming that. This is the region of the infundibulum. This is the mammillary body. Now you can see them more clearly here. So this is the region of the third ventricle. You open this ependyma and you will be in the third ventricle from below. This is the anterior perforated substance. And you see this is the optic chiasm, the infundibulum, the tuber cinereum, the mammillary bodies, and then the posterior perforated substance. Now I've cut the brainstem. I've cut the midbrain, and this structure that you see here is the anterior commissure. And more inside, if you go, you will see the massa intermedia. This is just another image to show you the anterior commissure and how this is the choroid plexus from an inferior aspect. So the choroid plexus that is hanging from the roof of the third ventricle, this is the region, this is that choroid plexus that you see on cutting the midbrain. This is the anterior view of the third ventricle. So as I told you, the anterior boundary of the third ventricle is the lamina terminalis, which runs from the anterior commissure above to the optic chiasm below, and it is part of the telencephalon. And this is the posterior view of the third ventricle, which we most commonly see by the supracerebellar infratentorial approach. This structure you see here that is connecting both the thalami is the massa intermedia. This is the pineal body. So in its upper leaf, you'll have the habenular commissure. In its lower leaf, you'll have the posterior commissure. This is the pulvinar of the thalamus. That forms the medial wall. So the thalamus actually forms the medial wall of the third ventricle, as you can see here. And it is a slit-like cavity that is there present between both the ventricles. So when you see from this approach, so you see this, when you enter into the foramen of Monro beneath the fornix, you will enter into the third ventricle, which is covered on both the sides laterally by the thalami. So just some interesting cases. This is, as I told you, sometimes the velum interpositum has a cavity, and this was a colloid cyst that we encountered in the velum interpositum, and we operated, and the patient did well. This is a case I did very recently. There was an AVM actually in the roof of the third ventricle. It was being fed by the medial posterior choroidal arteries, and you see how it had formed this venous varix. So this is the region of the roof of the third ventricle, and this is the supply, and this is the venous varix. And then I went interhemispheric and removed this, and this is the post-operative image, and the patient did well. So this is a great approach to the third ventricle when you enter from below the fornix and above the thalamus. So this is all about the ventricular anatomy today. I thank you very much for your time, and I'm ready to take any questions.
Thanks a lot, Abida, for this excellent presentation and very interesting dissections. Thank you. Is there any question from panelists?
Well, Abida, it's excellent as always, you know. Seeing your anatomical dissection, I always get the complex of inferiority. How come that I became a senior neurosurgeon without fluent knowledge of all this? It's amazing. Thank you very much.
Thank you. Thank you, Professor Benes.
Well, I have a comment to make for those who would like. All of this knowledge actually goes back to Professor Klingler 67 years ago in Basel. He published, these brain dissections where you freeze the brain is, I think, what Dr. Shah also started doing. And for those of you who don't have access to such a lab and doing all this work, I will put my email address in the chat box, and I will send them via Dropbox links or somehow directly a PDF of that atlas, Klingler's atlas from 1956. And you will see all of these pictures and all of these names that we never really pay too much attention to, but it is all there. Thank you.
Thank you.
Thanks a lot, Abida, for this excellent presentation. And now we will shift to next speaker, Professor Bashkaya. Please start sharing your screen. Thank you, Abida.
Thank you, Sam.
Thanks, Abby.
Hey, good morning, good afternoon, or good evening, wherever you are. I am in the small hotel in Wisconsin, so I apologize for the background, and thank you for being here. It's a great pleasure to be among the friends. I see very familiar faces: Vlad, Abida, and John. Abuzer, thank you for having me, and special thanks goes to Dr. El Morsi for including me in this nice webinar. So I'll talk about the vestibular schwannoma surgery. What are the treatment options in general? Observation is always a good option, microsurgery, and we always utilize these three approaches, depends on the case: radiation treatment and the so-called hybrid treatment, which I'm against it, and I'll tell you why. Aim of vestibular schwannoma surgery should be maximal safe resection, but when we say maximal safe resection, we should go there with the aim of gross total resection, not the inferior resections, like going there and, oh, sorry, I couldn't do it, but not trying your best to get the gross total resection. Preservation of normal facial function, preservation of hearing if the hearing is useful, serviceable hearing is present. And while you are doing this, you shouldn't have any more mortality and minimal postoperative morbidity. How do we select the approach? First, intracanalicular tumors. If there's a good hearing and only tumor is only in the internal acoustic canal. Middle fossa, if tumor is very lateral in the canal. Retrosigmoid, if there's some cysternal portion. Intracanalicular with no hearing, you can do retrosigmoid, you can do translabyrinthine, whichever approach you are familiar with. This is the two examples of the case selection between retrosigmoid versus middle fossa approach in intracanalicular tumors. You see here, there's a fundal cap, and tumor is not very lateral, more cysternal, more on the medial side of the canal. This is perfect case for the retrosigmoid when you are doing the hearing preservation. This is, on the contrary, there's little more tumor in the cysternal segment, cysternal part, but tumor goes all the way lateral. Reaching out this with the retrosigmoid and drilling the IAC and preserving all these structures around the IAC will be difficult. So middle fossa coming from the top is a good approach for this particular case. And so this is what we did. And we preserved the hearing and same time achieved the gross total resection. And this is showing the two cases to make a contrast between middle fossa and retrosigmoid. I'm going to skip this. What other factors important in decision making? Level of hearing always, depth of tumor extension into IAC. We just talked about that fundal cap, that the CSF in the lateral IAC, position of sigmoid sinus, how it is positioned, more anterior, it's going to be difficult. Small mastoid, contracted mastoid, it will be difficult for translab approach. But more anterior transfer sigmoid sinus location is good for retrosigmoid approach. Position of the jugular bulb, high versus regular, contracted mastoid, presence of the or absence of the flow, and the dominance of the sigmoid sinus is important, and your experience at the end. How familiar you are with these approaches, but tumor size has no effect on selecting the approach between translab and retrosigmoid. So large tumors bigger than 3-4 centimeters can be done via translab. Advantage of the translab is early identification. You drill the canal, you fall onto canal right away, and you decompress and mobilize the facial nerve at the lateral IAC very early. And it's direct route to the CPA as almost purely epidural approach. You don't even see the cerebellum. You just make a little cut in the parasigmoid dura, and you don't deal with the cerebellum. And you can expose the IAC 270 degree. In the retrosigmoid, that's not possible. And this is questionable. Some studies found less CSF leak than retrosigmoid approach. I concur this experience in our cases too, but I cannot substantiate with any data. And definitely wider anterior and superior exposure, almost no postoperative post-craniotomy headaches. Disadvantage, it is if tumor goes far anteriorly, way ventrally, it's very difficult to see this part of the tumor with the translab approach, and caudal extension in the lower clivus can be problematic sometimes, and jugular position of the jugular bulb can limit surgical exposure. One contraindication is the active or chronic otitis media or mastoiditis. This is a case, again, showing you the size not that important in selecting the approach. And this is a 23-year-old nursing student, comes with this no hearing, so perfect case for translab, and not too far anterior location. So this is just showing this quick translab approach, drilling the labyrinth, getting the IAC early, exposing the IAC. Once you expose the IAC, you amputate the superior vestibular nerve, and then facial nerve, cochlear nerve, everything comes to the view, and you start pulling the tumor from the canal towards the cerebellum. Then eventually you open the dura in the parasigmoid region, and then start debulking the tumor. And this was very, very vascular tumor, but we did very well and achieved the gross total resection. This is the fat graft, abdominal fat graft we like to put to seal the area, because you cannot replace the bone, you cannot repair the dura primarily. And she did very well. Postoperative day 1, Hals-Breckman grade 2, and improved right away, and has been tumor-free with a completely normal function status and facial function. Again, to show the size that not important. A cystic tumor, as you know, cystic tumors are notorious for being stuck to the cranial nerves or the neurovascular structures. So presented with signs of hydrocephaly, imaging showed this almost 5 centimeter cystic acoustic neuroma. It goes very high all the way to the midbrain cystic portion. And you don't want to leave the cyst wall. In my experience, leaving the cyst wall is calling for the recurrence. So translabyrinthine approach gave us the perfect exposure, gross total resection, normal face, and this patient also has been tumor-free for almost 10 years now. Another case, cystic tumors, immediate post-op, you see large fat. It's key to put this fat and replace the bone, replace the tumor. It looks like this fat itself is causing the compression, but it is not. And if you do less, it's going to leak CSF, so you're going to have more problems. And eventually this shrinks, like I show in the other cases in the routine follow-up MRIs. Another one, cystic tumor. So now let's talk about the retrosigmoid approach. What is the advantage? You can preserve the hearing if hearing is present and is serviceable. And you have better control of lower cranial nerves with the retrosigmoid approach. Retrosigmoid approach is the workhorse of the lateral skull base and much shorter exposure time. Translab takes time, drilling the mastoid, drilling the labyrinth, but you can get in the retrosigmoid readily right away and complete your exposure in 30-40 minutes. Disadvantage, lateral cerebellum is exposed. You are dealing with the cerebellum, and you may need to retract the cerebellum, or even if you don't use self-retaining retractors, with your suction, you are dynamically on and off retracting the cerebellum. And poor ventral control and exposure, And this is a problem. It can be sometimes very serious in less than 5% of the cases, very severe post-craniotomy headaches. Even though you replace the bone, you do everything, they get a post-craniotomy headaches, similar to the post-craniotomy headache you get after the terminal approach. This is a case example, 51-year-old, a serviceable hearing, perfect case for retrosigmoid. Will come, remove this part, drill the IAC, and remove the tumor, save the hearing, save the face, initially slight facial grade 2, 3 months follow-up, completely improved, no sign of any cerebellar injury, and achieved. We achieved our goal, saving the face, saving the hearing. This is a 30-year-old, again, good hearing. It's very rare to have good hearing in this size of tumors and no canal involvement. So this is a perfect case for retrosigmoid, attempt to preserve the hearing. It's very difficult though. Saving the hearing, tumors greater than 2.5 centimeter, almost less than 5% chance. And we did the gross total resection, but unfortunately, we couldn't save the hearing in this case. But we tried. This is another one, 36-year-old, 38-year-old professor here at the UW, the University of Wisconsin. So large tumor, significant brainstem compression, and almost no canal involvement. And it goes all the way anterior. So in this case, retrosigmoid versus translap, my approach, my selection was the retrosigmoid because of this ventral and also most importantly, no canal involvement. So why am I going to drill all this canal in the translap, spend 3 hours to do the approach? So we did the gross total resection with retrosigmoid and grade 1 facial function. So now I'm going to review the complex cases. Patients had treatments before, and I'm going to show you the utilization of the translab approach in post-retrosigmoid cases. So this is a case, 40-year-old female, and had the surgery at somewhere else. You see, they went to retrosig, removed the cisternal segment of the tumor, but left the intracanalicular part. And patient did well facial function-wise. Her hearing was perfect before surgery, and she lost her hearing after the surgery. And they follow her, and meanwhile, she develops a very severe trigeminal neuralgia. And now tumor is slightly bigger, and trigeminal nerve you see is here, is kinked. So they try many things, and the same center who did the initial surgery recommended gamma knife. They came to me as a second opinion. I said, this is 2 things you can do. You can remove the rest via translap. Now she lost the hearing after her first surgery, and you can decompress the trigeminal nerve. Why do you subject the patient to another procedure, inferior procedure, and you know that she's 40-year-old and you don't know the natural history after gamma knife? And she will still have you're going to burn her trigeminal nerve. There's no way. And this is the case, again, is perfect, is a virgin approach. You are not coming through the retrosigmoid they did before, so you don't have to deal with the scar. As you see, you identify the cranial nerves right away in the canal, and now we are opening the presigmoid dura. There's still some scar, you're going to deal with it, but it's not like going through the lateral cerebellar surface, which was exposed before. So now we are identifying the facial nerve and low intensity ultrasonic aspiration and debulking, so you create a space. And I'm not seeing cerebellum here at all. You see, this is I open the dura a little bit and excise that part of the scar dura. So now identifying the nerves in the canal. And we're gonna amputate this superior remnant of the superior vestibular nerve. And here is the facial nerve now. Sharp dissection, if possible. or at least semi-sharp dissection, no blunt dissection between tumor and the facial nerve, and finding the facial nerve at the brainstem now. And this is the diamond knives, arachnoid knives, whatever you use, and dissect, debulk, identify the pathology, identify the normal anatomy, and develop your planes. And these are yours. Again, I'm using my suction. This suction hand is the most important hand, and I can adjust suction with my thumb. I don't need anybody else doing that for me. And this, I call this samurai dissectors, as they are super sharp, fine instruments, and you can use them to create the plane and hold the plane. Again, dissection, debulking, and traction, contratraction. That's another thing Spessler introduced, right? When he removed the cavernous angiomas from the brainstem. Traction, contratraction, and dissection. Stretching the bands and cutting them. So we are making progress, and we're going to find the trigeminal nerve, but first we need to deal with the facial nerve. Believe it or not, dissection between tumor and the facial nerve was much easier, but dissection between tumor and the trigeminal nerve, that wasn't easier. So that explains the patient's symptoms. But facial nerve is not like trigeminal nerve is not like a facial nerve. Okay, so it's a robust nerve and tolerates the trauma much better. And it is, as long as you didn't cause the vascular injury, it's going to be all good. Okay, so then this is the thing, creating the plane and removing it. Facial nerve stimulates at the brainstem. Everything is preserved, and immediate resolution of her trigeminal neuralgia right after surgery. So the fat graft here, good face, and happy patient. Another patient, this patient had the surgery somewhere else. They were going to subject him to the hybrid surgery. They call hybrid, but it's not actually surgery, it's hybrid treatment. So retrosigmoid craniotomy first, then the gamma knife. Patient wanted to wait a little bit, didn't want to have a gamma knife right away. And meanwhile, tumors start growing again. And they recommend another debulking and the gamma knife. And patient came to me second opinion. We did the gross total resection. Perfectly worked because, again, different route. We are not going through their approach. We are going through the separate approach. And Translab works perfect for that. Another patient from Spain. We don't have the first pre-op patients, but pre-op MRIs, but they did this good surgery, left the tumor in the interclavicular part, and the gamma knife, and the tumors start following after surgery and gamma knife. And this is hybrid treatment, and then grows to this size. Grade 3 facial post-op day 1, perfect face, facial, great post-op 2 months, gross total resection of the tumor. Again, Translab works perfectly in these cases. And again, another case, another story, same story, subtotal resection, this time CyberKnife. Tumor continues to grow in spite of CyberKnife, and gross total resection, good facial function, good functional status. And you can do this Translab versus retrosigmoid, but in my experience, this is again a case. Patient received the radiation, tumor continues to grow in spite of the radiation, and then we did the gamma knife, we did this Translab, gross total resection. You see that big fat becomes no fat over time. And Haas-Breckman grade 2, happy patient, good outcome. But sometimes we fail too, okay? Or we fail in a way that we go there with the gross total resection, but we cannot achieve the gross total resection. And I'm not advocating at all cost, you should do gross total resection. You go there with your aim is to get the gross total resection, But if nerve is getting tired, you keep stimulating and it's not stimulating well, it's stop at that point. And it's not stimulation is not coming back, don't continue. And you did your best and stop at that moment with and this is the case. You see, we left the tumor in the canal here. He had a weak phase, like grade 3, improved to the grade 1, but it was getting weaker. And there's no point in this patient inducing a facial paralysis. Then you say, oh, I did my best. I did the gross total resection, beautiful MRI picture, but horrible patient picture. So this is the judgment you make at surgery. You don't go to idea that, you debulk and radiate or you debulk and watch, okay? So this is another failure of the initial approach. I thought I can get this tumor via translab. We did the translab. It's 29-year-old and very severe ataxia and gait imbalance. Hearing is gone completely, and then a lot of swelling here. I underestimated, and I think I can get it. I couldn't, and this time we didn't, because we're gonna come back. I didn't put much fat here. I couldn't see the ventral part. I kept debulking, dissecting, kept debulking, but she's 29-year-old. You don't want to hurt. Stop, reevaluate the situation, reassess the situation, and come back. And this is the coming back as a retrosigmoid. This is the translab parts. So initial first surgery, but this was sometimes I do planned surgeries, but this is unplanned stage surgery, because I was planning to get everything at the translab. It didn't work, and I come back as a second stage. I'll skip these parts. You see, and then when you come back, don't wait longer than 2 weeks, okay? Ideally, next 2-3 days, you should come back so you don't deal with the scar. And the initial translab allows you to devascularize the tumor in the canal. See, this is the still initial translab approach. Now we are coming as a second stage. These are all scars, blood products, but I came back in 2 days. You see the fat we put from the approach and identifying structures again. And creating the new planes. See, this was a failure on my side to selecting the correct approach at first time. And this, okay, I'll skip. And sometimes I do, like I said before, I do planned stage surgeries. If tumor is too large and you know that it's going to take more than 8-10 hours, and you're at the end of today, you are dealing with the team B, team C, team Z. Everybody comes and goes. In the United States, is like that. They work in the shifts, and then you start doing this complex surgeries with the surgical team that have no idea about the brain surgery. So in those cases, stop, come back. And also, it's important in some of these cases, there are the hemorrhagic tumors, very vascular tumors. After debulking first stage, they get less vascular over time. Just wait, they calm down those things, and then you come back, you can come back as a second stage. So this is the facial nerve. Again, the sharp dissection between facial nerve and the tumor. I am applying traction with my suction hand and creating the planes, traction, contratraction, using the suction hand as a dissector, and exchanging all these maneuvers, and then taking your time, keep stimulating, keep the nerve moist, and don't use cold irrigation around the nerve. And I use sodium nitroprusside to prevent that capillary vasospasm. and the last piece of the attached tumor. And remove the rest. Nerve stimulates at 0.05, which is a good indication of the predictor of the postoperative facial outcome, gross total resection, grade 1 facial function. And she felt so good after a couple of weeks because she was super ataxic and gait imbalance from the compression. So I'm going to just briefly mention and finish my talk about the nervus intermedius. Nervus intermedius, a nerve has been ignored in the acoustic neuroma surgery. And it's small acoustic neuromas. If nerve function is preserved, patient has a good taste, you can preserve. But it becomes difficult preserving the nervus intermedius after tumors bigger than 2.5 centimeters. But you need to identify the nerve in small tumors and preserve. And I'm just going to show this video to this nerve, to identifying this nerve and then preserving it. It helps a lot to the patient's postoperative recovery. They don't feel good. See, this is the that just we got the glimpse of the nervus intermedius. It's very tiny nerve. It goes along with the facial nerve, and identify that and do your best to preserve. And if patient has lost the function already in large tumors and compensated, it's okay. But the small tumors, you can preserve it. I am cutting the 8th nerve here because patient has no hearing. See, just came to the view, facial nerve and the nervus intermedius. Okay, it won't stimulate with the facial nerve function. So it can be preserved and you can have a happy patient and they can taste well. So general principles and tricks, correct selection of the patient, right? Which patients you need to operate, which patients you need to wait, correct selection of the approach. If in some cases, do the stage approach if you are going to hurt the patient or you feel like you're tired or you feel like you need to stop at that point. And the patient's hearing and facial nerve status is important in decision making. Anatomy is everything, and correct surgeon's discretion, gross total or near total resection versus hybrid treatment, which I am completely against. CSF drainage, lumbar drain, early cisternal drainage from the lateral cerebellar medullary cistern, early localization of the facial nerve course with high amplitude stimulus. And I use sodium nitroprusside to prevent vasospasm, keep the nerves moist and warm, correct orientation of tumor limits, and preservation of nervus intermedius. And these are all the things we know, you guys know, I don't want to repeat it. And these are my very crude, not detailed results, but I have if tumor is greater than 2.5 centimeter, my facial nerve outcome, grade 2 or 3 actually is near 92%. And I have only 99%, I mean, not only, I have less than 1% chance of facial nerve injury or paralysis at tumors smaller than 2.5 centimeters. So at the end, like Vlad was saying, you know, anatomy, going to the lab, Abida, what she's doing these beautiful dissections, do like her, go to the lab early, okay? When we were growing up, we didn't have this luxury, we didn't have this chance, but you can, and if you don't have it, you can go to the places they have the lab. And now I have it, and I welcome everybody to join my lab to learn these techniques and study the anatomy in cadavers. Thank you very much, and I'm happy to take any questions. And I hopefully I didn't exceed the time too much.
Thanks a lot, Professor Bashkaya, for this excellent presentation. There is a question from Professor Baik. Please go ahead. How should, are you there?
Hi.
Okay.
Hello.
Okay,
Hello.
go ahead.
Hello, Professor Baskaya. Fantastic lecture. Excellent
Thank you.
lecture. And I enjoyed all the approaches which you have shown. I am also a great fan of a translab approach apart from the retrosigmoid. Now, many a times I have observed we have anatomically preserved the facial nerve, and by stimulation also we know that anatomically intact. But the patient, when wakes up, there is a grade 2 or grade 3 facial palsy, which of course may recover after a few months. Have you experienced such thing, or it is just my thing? And if you have, then why it happens?
Sorry, if so, I
See,
didn't
if there
understand
is-
your question
yeah,
exactly, but let me explain you. If you preserve the nerve anatomically,
The anatomical facial nerve during
and then it
surgery,
stimulates
Yeah,
with electrical
yeah,
stimulation.
yeah. But when
But
patient wakes up, there is a paralysis.
paresis grade 2 or 3.
Yeah.
Yeah, I mean that's normal. I mean that's we commonly see, because grade 2, 3 is not a bad, just apraxia of the nerve. It's going to get better eventually. But if the facial nerve you anatomically preserved, it's stimulated, you stimulate with the highest stimulation even, and it is not stimulating, and that is a poor predictor of the facial nerve outcome. You stimulate the nerve 0.05 milliampere or 0.1 ampere, that's a good predictor. If you go beyond 0.2, that's also poor predictor, but patient facial nerve will recover. We don't know to what extent.
Correct. Do you find difficulty in translab because being a small approach to access little larger tumors?
It is initially, we neurosurgeons are more familiar with the retrosigmoid approach.
Yeah.
And then when you do the retro translab, if you feel like it's limited approach, but as you get familiar and get experience, you overcome that. And then large size tumors you can do translab without any difficulty. Only problems you may encounter, like the cases I showed you, choosing the wrong approach in the tumors going too ventral or too inferior.
You drill yourself the labyrinth, or the ENT colleagues help?
No, a neurootology team there is. Can I do it? I can do it, but drilling 2.5 hours, 3 hours translab, and then doing the microsurgery is like doing 3 hours pedicle screws in spine and doing the microsurgery or bypass. So drilling long hours cause tremor in the hands.
Absolutely correct.
And also, you know, you don't know, but the neurootologists who drill the bone constantly every day, they lose the hearing. They have a conductive hearing loss from that constant sound of the drill.
Wonderful, wonderful, excellent talk. Always you are pleasant. Thank you, thank you.
Thank you. Is there any question from panelists?
Well, okay. Can I just say something about? In 1990, you know, I was working with a consultant with T.T. King, and was trained with T.T. King in London. They were all translab people. Unfortunately, there is no training for the translab approach, really. So you would be one of the places where we can send young people to see this again. Because really today, radiosurgery and all this hype about it, it is difficult to get even otologists enthusiastic about it. What you suggest regarding that?
Actually, going to lab, I learned in Miami when I was doing my fellowship. I saw this translab approach neuroautologists, ENT people are doing, and I got curious about it. I went to the lab. I drilled probably 100 temporal bones, and then learned that, and then came back and watched the surgeries and did part of it. And I can do it. It's even we are doing a bypass, we are doing clipping aneurysm, removing the tumors from the choroidal fissure. Why can't we drill the temporal bone? We are doing the transcondylar approach. We are doing Kawase. So we can do it. Just learn, just develop a curiosity and go invest time. Then you'll learn it. I mean, or you go to the centers that they do translab, mastoid bone a lot, neuroautologist, and then you learn from them. I'm happy to help anybody who wants to learn the translab or mastoid bone, and we do every week.
Very good, very good.
Thank you.
Thanks a lot, Professor Bashkaya, for this excellent presentation and for discussion. Thank you.
Thank you very much. Thank you all.
Thanks for going the extra mile in the hotel lobby.
Now I'm going to my room to get my family so we can have a breakfast.
Thank you. Thanks for going the extra mile.
Thank you. Thank you very much.
Thank you. And now we will shift to next speaker, Professor Carlo Bortoletti. Please start sharing your screen. Thank you.
Okay. Did you see my screen?
Yes.
Yes, it's not presentation mode yet. Go ahead.
Okay.
Yeah, perfect.
Okay. Good morning, everyone. I would like to thank Dr. Sami for having me here with this outstanding faculty. My topic today is a multidisciplinary treatment of high-grade brain arteriovenous malformation. So the decision to treat high-grade AVM is a complex process and should include analysis of cumulative and natural history risk, on the cumulative multimodality therapeutic strategy risk, potential benefits of a high rate of lifelong cure, and patient preference. In this paper coming from the Helsinki group is a follow-up study of 63 patients. The author analyzed the cumulative hemorrhagic risk, and they found that the 20 years hemorrhagic risk of ruptured high-grade AVM was 62%, with 24% for the ruptured ones. So in this AVM Italian group study, we collect only 48 grade 4 AVM, so they are a very challenging lesion with a obviously modified ranking scale of 70 of favorable for the ruptured lesion as of the 24% of favorable lesion outcome for the ruptured lesion. So in 2017 in Milan, a European consensus conference stated that there may be an indication for treating patients with higher grade based on case-by-case consensus decision. So they represent a very challenging lesion. In 2010, Dr. Lawton, UCSF group, published this a new grading scale called supplementary grading scale for selecting patients with brain AVM. The author added 3 new items: age, less than 20, 20, 40, or more than 40 years, the bleeding state, yes or no, and the architecture of the nidus, compactness, yes or no. And in 2014, this validation study coming from 4 with extensive experience in AVM surgery group, and the author stated that the supplemented system performed better than classic supplementary spectrum-marking system, and in terms of postoperative surgical risk. And all the original paper and the validation paper state that suggests that the supplementary grade 6 was the upper limit of brain AVM operability. In 2022, the BNI group tried to push boundary higher and analyze the result also of the grade 7 less. And they conclude that a young patient with small nidus in the low risk supplemented grade 7 have a favorable postoperative outcome. And the grade 7 patient did not improve the surgery experience. But very recently, the Beijing group, unfortunately, they use the classic Spethler-Martin grade, analyze the result of the surgery of the grade 4 and 5 AVM with excellent result in terms of modified ranking scale. In the late follow-up, the unwrapped lesion carry a 67.9 modified ranking scale 1 and 48 for the Raptor 1. And they conclude that intervention is reasonable for properly indicate Spethler-Martin grade 4 and 5 because it provides satisfactory seizure control with decreased risk and severe disability and subsequent hemorrhage than conservative management. Another very important useful contribution is the so-called AVU-ICH score coming from the Zurich and UCSF group in terms of predict clinical outcome in brain AVM with hemorrhagic presentation. The author added 3 new items to the supplementary grade: the Glasgow Coma Scale score, the intracerebral hemorrhage volume, and the intraventricular hemorrhage. And they conclude that this score predict outcome better than the ICH score. And afterward, this international multicentric validation paper confirmed the original paper, and another score equal or less than 9 is associated with a good outcome in terms of modified ranking scale 0 and 2. This is our group of patients, 20 patients treated between 2014 and 2019 with supplementary grading scale 7, 8, and 9. This patient coming from 2 centers in Italy, from my center, Bellari Hospital in Bologna, 15 patients, and 5 patients from the Humanitas of Milan. The modified ranking scale at presentation was 3.9 at the patient, and from 1 with of the unwrapped lesion. And this is age. All the people, all the patients are older than 20 years old. We have 13 grade 7, 5 grade 8, and 3 grade 9 in AVM. So our result for the grade 7, we found a 58% of good outcome, modified ranking scale equal or less than 2, that improved to 83% at the follow-up. Why this result? Because all the patients with a modified ranking scale greater than 2 at discharge had surgery in acute stage, so ruptured lesion with diffuse nidus and deep seat AVM. And 100% of the good outcome in the grade 7 patient are AVM located in the temporal-occipital lobe and with a superficial location. What about supplementary grade 8? 5 patients. All the patients have a superficial nidus in temporal-occipital location without motor cortex involvement and with compact nidus. And we confirmed the result of the AVICH score. So all the patients with this score equal or less than 9 presented a good outcome with a modified ranking scale equal or less than 2. So what about our strategy? We usually have a multi-stage, multidisciplinary strategy with the pre-op embolization. Our target are obviously the aneurysm associated to AVM, in particular the pseudoaneurysm. The second key is, the intra-nidus high flow arterious venous fistula and the perforating artery that represent a challenge mainly in the late stage of the surgery. With the Mayo Clinic, we propose a redefinition of the classification of the aneurysm associated with the brain arterial malformation. We focused on the so-called pseudoaneurysm. The pseudoaneurysm in a setting of a ruptured AVM, pseudoaneurysm results from unclotted portion of the hematoma still communicating with the vessel lumen without a real vessel wall. It could be multiple and could be increased their size over the time. So, in case of pseudoaneurysm, you have to fix immediately the pseudoaneurysm, which represent the still source of bleeding, and then we can delay the treatment of the nidus in 2 or 3 weeks. This is a case, a 40-year-old female with a sudden onset of aphasia, right hemiplegia, and a psychomotor agitation. At the emergency department, she presented somnolent and she was intubated. CT and CTA showed a intracerebral intrainsular hematoma with a grade 4 cerebral arteriovenous malformation with a deep venous drainage. So we decided to, this was the feeder with the drainage, venous drainage, the feeder from the posterior communicating artery, from the anterior choroidal artery, and from the M1. And so we decided to go on acute stage of the surgery with the initial protectomy to evacuate the partial evacuation of the hematoma. And beneath the hematoma, we will find the nidus of the AVM. The acute surgery for this kind of lesion, like Dr. Lawton said every time in their presentation, his presentation is a real war with a lot of battles. So you have to plan very carefully. This kind of lesion has to manage it from experienced neurosurgery in the surgery of the AVM. And then we have, you can face with the different hemorrhage in different part of the surgical field. Like Professor Lanzino told me a lot of time, the brain AVM surgery like a cha-cha-cha. I mean, you can move on a part of the surgical field and then come back, compress the bleeding, and go to another side of the bleeding. And then we took away the nidus. So also at the end of the surgery, when the draining vein is already thrombosed, you can face with a challenging hemorrhage. So you can stop with a part of your work in different part of the surgical field and come back and then take the nidus out. This is a post-operative CT scan. This is pre-op angiography. This is post-op angiography. She developed acute hydrocephalus that required an EDD, then recovery of the consciousness but persistent of right hemiplegia and aphasia. At 1 month after surgery, after initial rehabilitation program, she progressively improved the right hemiparietal in aphasia. And this is a patient after 3 years of follow-up with the 5-rank scale of This is a second case, a ruptured case. It's a 32-year-old man, a 52-year-old man, I'm sorry, 32 years ago, diagnosis of symptomatic huge left temporal occipital AVM with generalized epilepsy, controlled with medication. The case was deemed inoperable at that time. In 2018, the day of admission, the patient experienced an acute onset of headache with aphasia and right hemiparietal. The CT scan showed the huge nidus with intra-peri-nidus hemorrhage, and the CT scan showed that this huge AVM with several venous aneurysmal dilatation, which represent drainage of the AVM. So we decided to start with the multi-stage preoperative embolization. This kind of AVM presented also a meningeal feeder artery support from feeder artery from meningeal system. And then we start with embolization of the cerebral hemorrhage. And then we start with the occlusion of the intranidus high flow arteriovenous fistula with plug 1. And then we move to the onyx and with the second embolization. and coiling, first embolization. Then we operate on the patient. We start with, for this kind of a huge malformation, with occlusion, temporary occlusion of the feeding artery, and then check with the microdoppler of the drainage veins. And then we start with the coagulation of the major feeder, and with the dissection of this huge nidus. And then we go to the deep side of the AVM, and with the echocolor Doppler, we try to analyze and differentiate the feeding artery with the outstanding artery or in passage artery. And then after the check with the Doppler, we start the occlusion of the feeding artery and the coagulation. Of these feeders. Then we move to the dural part, the dural feeder, coming from the inferior part of the nidus, from the dura of the temporal fossa. The coagulation is not easy because they come outside from the dura. And then we move this nidus slowly, by avoiding out the traction with the brain. We took the nidus out. This is a pre-op MRI. This is a post-op MRI. Unfortunately, the patient refused the CT angiography. This is a MRI, and this is the patient. 10 days of follow-up. Stop. Sulle mani. Apri chiusa. Stia su una gamba. Appena follow-up. So high-grade AVM are challenging lesions with potential poor natural history, and the treatment has to be reserved to highly selected patients with multiple hemorrhage, disabling symptoms, unresponsive to the medical therapy. A favorable outcome can be achieved even in supplementary grade 7 brain AVM. We confirmed a good correlation between the AVIC score less or equal 9 and the good outcome in terms of modifier ranking scale. A multimodality approach should be the treatment paradigm, the so-called downgrading attitude. This is our attitude for this kind of lesion. Embolization or radiosurgery may contribute to significantly in the downgrading of the AVM for a presurgical strategy. The treatment of high-grade AVM should be performed in high specialized neurovascular center with high volume activity, equipped with all the therapeutic tools, surgery, embolization, technique, and radiosurgery. Thank you very much.
Thanks a lot, Professor Bortoletti, for this excellent presentation. Is there any question from panelists?
Good morning, Professor Tu.
How are you?
I'm
Very
fine.
good. Very
Nice.
beautiful presentation.
Nice to see you again.
Thank you. Thank you.
Of course, welcome to the king.
Thank
Welcome.
you.
And Louis, welcome.
Hello, how are you?
Okay. I think Sam, where are we going now? Sam?
Okay, and now we will shift to next speaker, Professor Boba. Please start sharing your screen. Thank you.
Can you hear me?
Yes.
Hello, Atul.
Hello, Luis. You look younger to me.
Yeah.
Hello. Hello there. Bom dia.
Bom dia. How are you? Okay, good. Let's see if we can share the screen here. Can you see my screen?
Yes.
Okay, okay. Good morning, good evening, everyone. I'm Luis Bourbon calling. I'm talking from Brazil, from the south. Now here is, time is now 10 a.m. Saturday, 10 a.m. Do you know, craniopharyngioma is not so easy surgery. Craniopharyngioma is not so easy disease. Craniopharyngioma, you need to know the way to treat, the way to approach. There is no standard approach, as the people is saying today. Today, you see a lot of publications about and presentation about craniopharyngioma say that now you have all the information. I don't need anything. I just need an endoscope and I go from the nose, I can do whatever I want. Maybe you can, but this is the best way to treat the patient. We are doing neurosurgery to show our beautiful videos or to treat the man. Craniopharyngioma is not a common tumor. It's 2.5 to 4% of all brain tumors and have two peaks in children and in the late adults. The clinical presentation can be just visual loss, pituitary dysfunction, especially in children, or intracranial hypertension, very common in adults. In 80%, 85% of the children have calcification, the typical X-ray. Simple plain X-ray, you can do the diagnosis, a calcification in the suprasellar area. The CT scan, you can show calcification and lesion and the cyst around in the sellar and parasellar region. The MRI can show more extension of the lesion, sometimes delimitate the most difficult part of the treat craniopharyngioma, that is the displacement or invasion of the hypothalamus. You cannot do neurosurgery, you cannot do surgery without excellent endocrinological and ophthalmological evaluation, especially endocrinological evaluation. I remember Professor Yashar Gillis talk about craniopharyngioma can be the most beautiful surgery, the most beautiful video, and the worst post-operative. Because of what? Endocrinological disturbance. Because this has to plan and to understand the disease. The tumor can get just in the sella, can get up to the third ventricle, can go lateral, can go superior, and sometimes completely isolate from the sella. But this relation of the hypothalamus is the big issue. As Professor Stenner published many years ago, this relation of the hypothalamus make the difference in surgical results and selection of approach also. You know that to treat craniopharyngioma, the best way, it may be the only curative treatment, radical total removal. However, in not every case you can do. Sometimes the extension, sometimes the invasion, sometimes the relation of nerve and vessels you cannot get. In this situation, maybe you need radiation therapy or intracystic chemotherapy as adjuvant treatment of craniopharyngioma. But you know that the surgery is the only curative, but not possible in every case. It's completely different in adult and children. See, the histology is different, the behavior is different, the size is different. This is different, and you have to treat different way. Maybe the approach will be different also. to decide how to do the surgical procedure. You train many medicine, you know that radiation therapy works for craniopharyngioma in majority of time. Yes, works. Can control the disease. However, you have complications that can come in the future, not only to the pituitary function, not only to the hypothalamus function, not only to the temporal lobe, but also to the vessels. The intercystic therapy that you used during many, many years showed that effective to control. In this time, this situation, you gain time to the definitive treatment that can be radical removal or radical removal associated with radiation. Radiation has complication, you know, in children more than you can imagine. Very common complication in children is related not only to the brain dysfunction, to the visual field, but also to the vascular disease. This patient that young people that is submitted to radiation therapy may have this Moya-Moya syndrome, like Moya-Moya syndrome or Moya-Moya syndrome like. This after radiation therapy. It's not uncommon when you have children that you treat with radiation therapy. It means that radiation therapy is not the best choice. You need a strategy. If you have all the therapy, you have to understand the disease. Look this case here, very interesting case. A guy, 25 years old, vision loss and pituitary dysfunction. The guy is very prominent in neurosurgery in Brazil. He does more functional than open surgery. He decided to put a catheter, Ommaya catheter, in the cyst and treat. The patient improve the vision. The patient decrease the cyst, but the tumor is still there. And during 2 years, the patient become very well in control, and the vision came back. However, what's happened after 2 years? The tumor start to come back, the vision start to lose, and the tumor that was difficult to remove, now you can go by transsphenoidal surgery and do the transsphenoidal approach with endoscope, microscope, with everything. When you see scar in everywhere. This scar related to the function of the cyst and the bleomycin, and the scar related to cyst. And the surgery that was possible to do in the first time and get a radical removal of the lesion, may be cured. Now is completely different after bleomycin and previous surgery. As we know, is the only way to treat. However, I'll say again, it's not possible in every case. But to get the maximal removal, we need to understand the tumor. We need to understand that there is more ways to do the surgical approach. As I said in the beginning, now everything is from the nose, but there is other ways to treat and remove craniopharyngioma. This is the classical book of Professor Raposo. It shows the approach to the third ventricle. And craniopharyngioma is one of the examples. You have several ways to reach. Depend of location, depend of extension, depend of the consistency of the tumor. If you have a solid calcified tumor, paracellular, located laterally or encasing the vessels, is a smart way to come from the nose, pull and pray? I don't think so. The classical way, and I think today the #1 approach to the craniopharyngioma, except in the tumor that is located in the sella, that can be a retrochiasmatic extension, but if there is tumor in the sella, in this situation is another approach, but the classical and the #1 approach is the frontolateral. See, you call the paternal approach. You can come inferiorly from the nose, as I said. You can come superior from transcallosal. And maybe you need a posterolateral approach for very unique situations. You can do the classical paternal approach. You can extend a little bit more frontal. You can extend cranial orbital. Each case you select. In majority of the case, the frontolateral approach, the classical paternal approach, you give you the correct view. Do you know why? Because the root is made by the Sivian fissure. It's not by the extension of the bone that you remove. You open widely the Sivian fissure, you have the approach. Look this case here, very example. A 13 years old guy. Look at this. Sorry, 7 years old guy. Somebody proposed to this man to do a minimally invasive treatment. Come from the nose, do a transclival approach to remove the cyst. Try to remove this part. In this part that was going up, maybe give it to radial surgery. Minimally invasive. Don't open the head. Man, look, you say this for the patient. The patient will think that you God. You take this tumor without opening the head after you give a small shot. See, a small shot and kill everything. But it's the best way to treat for the patient? I don't think so. What you do in this situation? The classical transceivable paternal approach. As you saw this video, you can come, you open the Sivian fissure, open widely the Sivian fissure, and you find the keys inside the Sivian fissure, and use the plan that the God gave to you. See, it's the natural plan, and you go slowly and separate it one by one. You can get this, you drain the cyst, and start to find the capsula, work in the arachnoid, you find the third nerve down. Now there is the wall of the cyst. You should to remove all this wall of the cyst. See, it's very important to get this. Identify the nerves, identify the artery. You see the third nerve is here. See, is this place. How do you imagine you pull this from the nose? Man, you come everything. You come down everything. See, you hear in the cyst that was proposed, the transclival approach is very simple. In the window between the tentorial and the third nerve, you open here, you have the cyst. The cyst that was in the posterior fossa is the basilar artery. You can get the cyst very gentle and take and take it gently here. You can take the dissect from the vessels and remove. And the calcified area that is attached to the optic nerve. Oh, from the nose, you don't touch the optic nerve. Of course, you don't see. See, the last thing that you see that's coming, the optic nerve from up. I will show you videos about that. And the cyst in the posterior fossa, the calcified part, you take it. Basilar, you see, very short instrument. Oh, have a spatula in the brain. Of course, to hold the brain. I have this spatula to hold the brain. Here's the pituitary stalk. You separate the pituitary stalk and find this plane. This way you can preserve completely the pituitary stalk in this situation. In some case, or majority of the case, you cannot preserve the pituitary stalk because the tumor is invaded. But if the pituitary stalk is free, maybe you can save. And can do a simple procedure that you learn during many, many years, the classical paternal approach. And this way you can get this and clean and understand and clean very well. And pre and post-op removal. Situation like this, you need cranial orbital zygomatic, something like that. You don't need nothing. You just need a classical paternal approach and go there and go for the cyst. and you take the mass, you dissect the structure, you give the structure, and see the superficial temporal vein going to the finished parietal sinus. Here's the tentorium. Here's the carotid artery, third nerve, op nerve. You can clean this very, very, very well. In the pre and post-op delayed here. There is a situation that you can use a different approach. You can come from the head, of course you can, but it's midline, it's under the optic nerve. There is tumor inside the sella. We have a big sphenoid sinus. This is easier to come from the nose. And you can come from the nose, you can use the endoscope. With microscope or endoscope. Endoscope gives you wide view. It's better the view with the endoscope, with the microscope. I use both. See, I'm used to work with the microscope. I use a lot microscope, and at the end, I use the endoscope. Sometimes I start with the endoscope, but in the majority of the time, I use microscope, and at the end, the endoscope. You have to understand that one tool, don't you make you a Harry Potter. A tool is there to help you. See, as professor, a tool, the tool also is good for neurosurgery. The view that you have in the endoscope is unbeatable. You cannot compare. You can see things here, see anterior cerebral artery, you can see the basilar artery from up to down. You cannot have this view with the microscope. The endoscope show you wonderful. But sometimes you can see and you cannot reach. Sometimes you cannot reach there. See, you need curve bipolar, you have curve suction, you have curve dissector. You need microscope, endoscope, neuronavigation, whatever one. Use all the tools that you can use to help you. Don't need to be like that. This is a guy, a young guy, 9 years old. It's an old video. I just from the nose. Very simple. 9-year-old boy. I just open here the columella, see, and went directly to the sella. You can dissect this part. Is in the sella. You can clean this very well. You took the calcified area, and at the end, you can add the endoscope view. See the cured endoscope, and at the end, you can see and put the endoscope. You can see it's a very old video. The quality is not so good, but you can see the whole cavity there. Situation like that, same thing. Come from the nose. You can remove from the nose. You can use the endoscope to see how up you can go. You see here, open the anterior fossa. You see it is under the optic nerve. You separate the capsula from the optic nerve. You separate the tumor laterally. You can take it out. I prefer to remove with the microscope because I have the two views. But use the endoscope and the microscope to work together. You see the endoscope view for the third ventricle. You see the foramen maron from down to up. And at the end, you can close safely the area. You can see, you can play and go around with the endoscope to see all this area here. It's unbelievable, the view that you have with the endoscopic approach to this area. And the pre and post-op. Another situation, very similar. Same thing. See the extension of the lesion. You can plan the pre-op with neuronavigation. You can go around. You can see the artery. You can plan your approach. It's very important to strategy and to plan what you do. Where will be the artery? Where will be the tumor? Where will be the optic nerve? Today you have this information in the pre-op. It's very important to have this information. You can do surgery. I always start with the microscope. I make the flap. I start with the microscope. You can do the flap with the microscope. Yes, you can. The old way. You can go there, find the sinus. You can identify here with the endoscope, the sella, the anterior fossa. You see here, the view have the cell here, the microscope. The view if the endoscope is much, much better. You see, you can see very well here. And at the end of the surgery, you can, after remove the tumor, you can put the endoscope and see. You see, I like to dissect with the microscope. I dissect there, you see the optic nerve is coming down. See the optic nerve here? This is the problem with this approach. The last thing that I see is the optic nerve in the chiasma. And when you remove the tumor, it's come down the optic nerve, come down the chiasma. You see, the dissecting become not so easy as the people show there and see here. Lamina terminalis, here's the optic nerve. We have to manage. I don't think that through the head, I will have this kind of manipulation of the optic nerve. I'm not sure. You see here there, you can take this, you can liberate from the bilateral optic nerve, you can liberate that and take the tumor out. From the microscope and here from the endoscope. Same case. Optic nerve one side, another side, you go to the cellar, you have this. But this chiasma came down and manipulate a lot. This patient, the vision in the right side was worse in the post than in the pre because of the manipulation. Thanks God, now is improving. Now is the same as was in the first. And remove, take the craniopharyngioma, now you have a lipoma. Put a C and fill with fat. Another situation, very similar disease. Tumor like that, you come from the nose. In this case, you did pure endoscopy. You open there, here's the cella. Here is the intercavernous sinus. Have to open anterior fossa and the cella. Leave in the middle. Now you cut and coagulate the superior, the intercavernous sinus. You find the tumor, you shrink the tumor, you separate it, separate from the mucosa, and what you do? You pull. Of course you have to pull, independent of the endoscopy, of the approach. Oh, you can dissect more, microsurgical technique. No, it's not true. It's not true. Behind are the nerve, behind of the vessel. See, it's difficult. You see, I'm not sure that this is the best way to treat this kind of tumor. For a small lesion, it's okay. But for large tumor like this, I'm not sure. This was adult. The plan was very nice. See, you can get the tumor, you see, it comes, you see that like that. Clean, beautiful. You see all the anatomy there, third ventricle, lateral ventricle. You can see the whole world from here. And the post-op, you have this. You take the tumor out. Same situation. Now the situation just with endoscopy, just with the microscope. You go inside. What was this? Was a cyst. See? Same situation, pre and post-op, endoscope, microscope and endoscope. And pre and post-op removal preservation of pituitary function. But there are situations that are different. This one of that. Tumor displacing the hypothalamus. This case came to me very close, difference 1 month. First, this big case here. See, big time here. See, whoa, it's a good idea. I come from the transcaloso. And this came later, 1 month later. This case went very well. I do transcaloso also. Okay. I did the first case, the transcaloso approach. The classical transcaloso approach. The tumor was coming in the lateral ventricle. You came up, you came from up, you did the surgery, you removed the tumor from the transcaloso area, for the transcaloso approach, the very calcified area. You see here the basilar artery. You see there the sixth nerve, the dorsal sella. See the pituitary stalk. See, you can see it's the dorsal sella. See the tumor, the pituitary stalk. See The tumor gave the approach to me. I just followed this solid part and went directly to the tumor. You see the clean there, and pre and post-op. The patient had no hypothalamic disturbance in the post-op, just DI that's control. When I did this case, man, I found a way. And came another situation like that. Sorry, another situation like that. I did, okay, let's do transcallosal approach also. Same situation, see, small lady, large tumor, I came from here. Through the solid part of the tumor. And the post-op, you could go through the transcallosal and follow the tumor from up to down. Now this patient has 9 years old now. I just talked to her 2 days ago. I found a way to take this tumor. Anatomy, microsurgery, go directly there. I came this. I did the same. Come from here. What was the problem? This patient already had hypothalamic disturbance. I did through this area, and the hypothalamic was displaced up. I did the surgery through the hypothalamus. What's happened? The most beautiful post-op that I have. Look at that. If I show this video in any congress, the people say, man, this guy is good. Okay, you see, very small cut. 60 days in the hospital, severe hypothalamic disturbance. See, a lot of complication. The patient went from home to recovery room. Now more than three months in the recovery room. See, and severe hypothalamic dysfunction. Do you know why? Wrong approach. I went through the cyst. In this situation, I should come from below, from the solid part, and leave the cyst to the end. What I learned in this case, select your approach to the solid part. And the solid part, you go through the solid part to the cyst. Never go from the cyst to the solid part, except in large cysts in the middle fossa that give you the whole approach. But when you go to the third ventricle, go through the solid part, not through the cystic part. And came another guy now for just to finish the presentation. The tumor that you go to everywhere. You decide the approach that you do will be okay. And I decided to do this approach. That's the Professor Hakuba described many years ago. I think Professor Goyo also described same time. See, long time ago. See, the transpetrosal approach, but it was very confused. The anatomy was very confused. The paper was difficult to understand. The draw of Professor Hakuba. And Professor Amesti came and showed better the anatomy. You see, you can come from posterolateral. See? You call the Petrosal approach for giant heterochiasmatic craniopharyngioma. Not small, but giant, a real giant like this boy. And I came in this situation. This is the post-op. See, this large tumor like this, cyst in everywhere. Now you can come by Petrosal approach. You go from one side to the other side. You just follow the cyst, give you the correct approach. What I want to show is this approach. Very rare, my baby, you need. Because this you need to learn skull base. We need to learn, need to go to the lab, you need to learn temporal bone, you need to learn all the anatomy. It is you select the best approach to your patient. Now, not the approach that you have in your friend or the approach that you did advertisement in the media to show the patient, I don't open the head. It's very common today in the world. The patient go to the center and say, I came here because you said you remove my tumor without opening my head. And the surgery does. You go there and take the tumor from the nose, independent if it's the better approach or not, is the best approach or not. just to satisfy the media. They say you are lying to the patient. You're not saying the correct way. Talk of the patient, say the correct way, say the way. Sometimes can go for the nose, sometimes not. This is the important. The other thing that's very important in undeveloped countries, you have a very good neurosurgeon, very skillful neurosurgeon. They buy very nice instruments, but the ICU is terrible. The ICU is the medical resident that is there during the night, that work during the whole day, in the night go to sleep in the ICU. These post-operative, especially the first 24, 48 hours, are crucial to the patient. Hypernatremia, hyponatremia, hyperthermia, hypothalamic dysfunction. You can lose the patient. The post-operative care is so more important than the surgical procedure. Recurrence, of course, you have more than around 30% of the tumor, 30 to 40%, depending on the series, have recurrence. In this situation, you can give radiation. In this situation, maybe you redo the surgery. That's very difficult, redo craniopharyngioma. You get to save this very good tool that is a radiation therapy for a special situation. What changed everything? Hormonal replacement. This changed the history of craniopharyngioma more than any tool, more than any approach, more than any new radiation therapy. What changed the history was hormonal replacement that, thanks God, that is available in the whole world. Thank you very much, Sam. Thank you for the time. I hope you enjoy our presentation. Thank you. Bye.
Thanks a lot, Professor Boba, for this excellent presentation. Is there any question from panelists? Or comment?
Yeah, Dr. Same.
Okay,
Can you hear me?
Yes.
Yes.
So, Louis, that was a wonderful, wonderful presentation.
Thank you, sir.
In my estimation, craniopharyngioma surgery or craniopharyngioma chapter is an unfinished chapter of neurosurgery. Like for chordomas, you see,
Yes,
chordoma, you remove whatever you remove, you be aggressive. When it will recur, nobody knows. Similarly, craniopharyngiomas, how much beautiful presentation you gave, how much to remove, whether you can save the pituitary stalk, whether you can save the hypothalamus, how much to remove, whether it will recur or not. You do radical surgery, you can have a recurrence. So I have a feeling that craniopharyngiomas, the treatment, the outcome is still unfinished chapter of neurosurgery, like chordomas.
Yes.
What do you have to say,
Yes.
Luis?
Yes, I totally agree. I say here, for chordoma, you send to your enemy, not send to your friend. Okay. In craniopharyngioma is the same situation. It's the same situation, especially in child and in children. See, very high,
Louis,
almost 40% of her recurrence. Almost
Louis,
40%.
Louis,
It's
both
crazy.
craniopharyngiomas and chordomas, for that matter, are histologically not very aggressive tumors. They are histologically maybe
Yes.
benign.
This is, but when they come back, they are more
Yes.
aggressive.
So
Looks like they change something.
and nobody knows which will come back. And you do
Yes.
again, they come back again. So radical surgery, as you correctly mentioned, is a very important for surgeons to do radical. But even after radical surgery, you can have a recurrence. And
Yes.
that is the very, difficult chapter of craniopharyngioma treatment.
Yeah. The craniopharyngioma today, I think the people is start working a lot with new medication, new chemotherapy. In the future, you'll be just relating to treat the intracranial hypertension. I think that you have chemotherapy that you help a lot. But unfortunately now, in our reality around the world, we need to do that. And the other thing, the radiation therapy today is changing a lot, but still complication long-term for these young children will be a very big issue in the future. But it's very passionate tumor that you like it. Thanks, man.
Can I say something to both of you? Well, you know,
Yes, sir.
there's this story out there that, of course, in recurrent cases, you get into the gliosis, you get into the hypothalamus and all these stories. But actually, this last case where Louis said he went through hypothalamic tissue and then had a bad outcome. Yes, so if you come from above and you have a solid tumor, so then you can properly dissect it. But what is his, can you elaborate why the cyst, which by itself should be, a cyst wall should be easier to dissect off the wall of the third ventricle, etc. Why would that be? Why was this his message? Please elaborate on it.
Yeah, the message is when the cyst went up, the hypothalamus go up.
Yeah.
When the solid part go up, the hypothalamus does like that.
Okay.
See, it's the work of Professor Steno from Bratislava. Very nice work of him.
Okay.
I think it was the cover of the Journal of Neurosurgery. Very nice work. And the pre-op, the patient will give you this information. But I was that time, I was so impressive with the transcalosa that I did before. I saw this basilar right. I said, man, this approach is the best approach in the world. And I did a mistake. Today, if the cyst is there, I come from below. Or the pterygium approach from the nose, you see. From the nose is good, but the last thing that you see is the optic nerve. The last thing that you see are the vessels.
And the pituitary stalk, remember that if you can preserve it, it will be of a benefit usually. I mean, in 50% of the cases at least.
Yeah.
Okay, thank you for
cranial,
this message.
From the cranial, short instrument, microsurgical technique. See, it's our life. Why today we pull and pray if you can dissect? Thank you, sir. Bye.
Thanks a lot, Professor.
Hello, Abdida.
Excellent presentation and discussion.
Bye-bye. Thanks.
Hello, Professor Barba.
Thank you.
And now we will shift to next speaker, Professor Atul Goel. Please start sharing your screen. Thank you.
Just a minute. Can you see the slide?
Yes, perfect.
Okay, so craniopharyngiomas are difficult, craniopharyngiomas are dangerous, and it is difficult to understand which patient will recur, which patient will not recur, whether radical surgery is good, whether how to preserve pituitary stalk, how to preserve hypothalamus, whether to come from the nose, whether to come from the head, whether to use petrosal approach, whether to use stereonal approach, whether to use radiation. I have to also say that radiation is effective in several cases of craniopharyngioma. So it is a complex issue, it is a difficult issue, and as I have said, craniopharyngioma surgery treatment is an unfinished chapter of neurosurgery. Similarly, I say AVM chapter is the last chapter of neurosurgery. AVM is to be dealt with philosophically, it has to be dealt technically, beautifully. It is the last chapter, but craniopharyngioma, chordoma, unfinished chapters of neurosurgery. Now I'm going to talk to you on a chapter which is finished, which is done with, and I will like to talk about a very important issue in skull-based surgery, one of the very favorite topics of skull-based surgeon, and that is surgery for trigeminal neurinomas. Trigeminal neurinomas are benign. Trigeminal neurinomas are disciplined. We have to understand trigeminal neurinomas. And if we understand trigeminal neurinomas, we can do a beautiful neurosurgical operation. So this was the article I wrote in the year 2003, where I discussed my series of 73 cases of trigeminal neurinoma. And now I have got a series which is more than 300 cases of trigeminal neurinoma, which is without any doubt the largest series in the world. In this article, I consider this article as a very fantastic article because for the first time in the literature, we said that trigeminal neurinomas arise from the region of Meckel's cave, like acoustic neurinomas arise from internal auditory canal. Similarly, trigeminal neurinomas arise from the region of Meckel's cave. And in the Meckel's cave, they go in front, they go behind, and they go very much in front. So these tumors are benign tumors. They remain confined in the middle fossa within the dura. So we said for the first time that they are interdural tumors. So this classification that these tumors can be in the middle fossa, they can be in like a dumbbell middle fossa and posterior fossa, and they can go extracranial. So there are multiple classifications of trigeminal neurinoma, and these tumors arise in the region of lateral wall. Lateral wall, they are not intracavernous sinus tumors. They are within the lateral dural wall of cavernous sinus. So in this article, for the first time in the literature, as a series, we said that following surgery, you can preserve the trigeminal sensations. You can actually improve the sensations of the face. There was never a mention about improvement in the sensations of the face. And believe me, my dear friends, in trigeminal neurinoma, if you lose the sensations of the face, for instance, if you lose the sensation of the V1 division, you lose the sensation of corneal sensation, you have to lose your eye. So you cannot lose your eye. You have to preserve the V1 division. That is very important. And I want to discuss as to what to do in these tumors. So in the year 2002, we discussed our series of 260 cases, and in 2017, and needless to say that we have to understand the anatomy of the petrous apex, anatomy of the cavernous sinus, anatomy of the anterior clinoid process, and anatomy of the petrous apex, and things like that. Trigeminal neurinomas are relatively rare. Next to acoustic, we have trigeminal neurinomas, and they are frequently, here it is written rarely, but whenever you have neurofibromatosis, you have trigeminal neurinomas quite often. So this is the petrous apex. This is the region of cavernous sinus. This is the lateral wall of cavernous sinus. This is V1 division. This is V2 division of the trigeminal nerve. V3 passes away from before entry into cavernous sinus, it goes away. This is the Gasserian ganglion. This is the root of trigeminal nerve. V1, V2, V3. This is the third cranial nerve. This is the fourth. This is the third cranial nerve. This is the fourth cranial nerve. This is the V1, V2. This is the sixth cranial nerve, which is intracavernous. So what is the important thing in trigeminal neurinomas and third nerve neurinomas and fourth nerve neurinomas is they are located in the lateral dural wall of cavernous sinus. They are not this is the trigeminal nerve within the dura. Trigeminal neurinomas are also within the dura. They never transgress the dura and come into the confines of cavernous sinus. This is the most critical understanding for trigeminal neurinomas. Dura matter, dura mother. Dura is divine, dura covers the entire brain, dura covers the nerve, intracranial and extracranial. This is the important issue in all neurinoma surgery. Cavernous sinus surgery we have been talking about. You see, in the year 2001, we published these articles about meningeal architecture of cavernous sinus, how the arteries are displaced, how the arteries are involved by the cavernous sinus tumor. Trigeminal neurinoma will never encase the artery of cavernous sinus here in the region. It will always displace. It will displace around the dome of the cavernous sinus, dome of the tumor. Here, artery will go inferior. Here, it will go medial. So it is very important to understand how the arteries are displaced when you are going to evolve the surgery on these tumors. So these are some important articles which we wrote. So middle fossa tumor in the middle fossa is always confined to the lateral dural wall of the cavernous sinus. There is dura here, there is dura here, and you have to work interdural. This concept was not there 25, 30 years ago. This concept, 30 years ago, nobody understood really what is trigeminal neurinoma, what is the tumor, how to remove. Not much information was there 30 years ago. Tumors in the posterior cranial fossa. We said in 2002 that these tumors are subarachnoid like acoustic neurinomas. But I have to say that now my understanding has a little bit matured, and many of these tumors in the posterior fossa can also be within the dural confines or interdural in location, many. But many of them can also be like acoustic or subarachnoid in location. Most important thing that I have understood during my surgery over all these years, that you have to save the trigeminal nerve like you save the seventh nerve in acoustic tumor. If you lose the trigeminal nerve, you can have very bad neurological complication. These kind of dumbbell tumors, here, this dumbbell in the middle fossa, in the posterior cranial fossa, here, this part of the tumor is in the interdural compartment. In multi-compartmental tumors, even this posterior fossa part of the tumor is within the dural confines. Many a time, not all the time. But if you have this concept that this is a very confined kind of tumor, you can design this surgery in a very appropriate fashion. So these kind of dumbbells, trigeminal neurinomas are several times. This is the very frequent kind of trigeminal neurinoma. And you see here, this is in the middle fossa, this is in the posterior fossa. And for a skull-based surgeon, these tumors are one of the most fascinating stories of skull-based surgery, where we like to remove this tumor, relatively straightforward tumor. The issues are not so complex. The issue is that we have to remove these tumors radically. The issue is that we have to save the trigeminal sensation. Issue is that we have to understand the dural integrity in these tumors. So these kind of tumors, middle fossa component is smaller, posterior fossa component is bigger. These are tumors which go extracranial. So extracranial extension along the extension of these trigeminal nerve is quite a frequent finding. This is tumor going along the V1 division. You see how the tumor is going along the V1 division in the extracranial compartment. This tumor, this patient presented with only proptosis as the main issue. Another case where the tumor is extending along the V1 division of the trigeminal nerve. So this nature of extension of these tumors is very critical to understand. You see now this tumor is along the V2 division, foramen rotundum. It is coming along the V2 division, and this part of this tumor is extracranial. There is teeth here. V2 division comes out from the maxilla, and this is along the V2 division. The other very beautiful thing that we discussed in the literature, for the first time in the literature, that even this extracranial part of the tumor is between the dural confines, dura here, dura here, dura here. So when you can actually design your surgery as to along the dural issues. Now you see this tumor along the V2 division, it has taken the teeth here. It is along the V2 division going here. And the most important thing is it will erode the bone. It will erode the bone. It will displace the soft tissue. It will displace the arteries. It will displace the nerves. It will break or erode the bone. This tumor is along the foramen ovale. You see, it is coming around the V3 division of the trigeminal nerve, and it is going in the infratemporal fossa. It will not encase the carotid artery. It will not encase the arteries in the infratemporal fossa. There is dural cover, and there is erosion of the foramen ovale. So this understanding that there is this kind of dural integrity in these tumors is a very absolute important understanding. This tumor is multi-compartmental. It is in the posterior fossa. It is in the middle fossa. It is in the infratemporal fossa. It is in the extracranial compartment. So there are multi-compartmental tumor in the 4 compartments: posterior, middle, extracranial, and subcutaneous. So you see there is a bulge here, and the tumor is extending into this kind of multi-compartmental thing. So many of the tumors, type A is only in the middle fossa, type B is only in the posterior fossa, dumbbell shaped, and extracranial. So these are the various differentiation. Trigeminal neurinomas can be very small, you see, like a small tumor, and can be huge. Most important differentiation issue is trigeminal neurinomas present with numbness or decreased sensation in the face and wasting of the temporalis muscle. If you find a patient coming with wasting of the temporalis muscle, if you find a patient coming with numbness over face, it is trigeminal neurinoma. And it is not a meningioma. It is a predominant symptom of worsened sensation, numbness, and worsened temporalis muscle and pterygoid muscle function. So they can be small and they can become huge. They displace the soft tissue, they erode the bony structures, like petrous apex is eroded, anterior clinoid process is eroded. You don't need to drill the anterior clinoid process. That drilling is done by the tumor. You don't need to drill the petrous bone. That drilling is done by the tumor. So these tumors can be huge, like these kind of tumors with multiple cysts. You see, this is, but whether it is small, whether it is huge, it remains benign. It remains disciplined. It remains within the dura. And that is a very important thing in these tumors. And you can make a diagnosis on the basis of presenting symptoms, numbness, wasting. So these are the issues in trigeminal neurinoma. They can become huge dumbbells like this. And these dumbbells are also, you see, there can be cystic and necrotic changes in these tumors. So many of the tumors in my series are very huge, more than 6 centimeters and more than 8 centimeters. Sometimes these tumors can be cystic. You see, cyst of dark cyst, white cyst. This is the only tumor other than craniopharyngiomas where the cyst can be of multiple colors. So this is multiple colored cyst. As you can see, this is white cyst, this is black cyst, and with different kind of enhancement and different kind of on T1 and T2 weighted images. Another very important thing is this fluid. There can be a fluid level within this cyst. Can you see a fluid level? And I have to tell you, when you see a fluid level within the tumor cyst, they are more aggressive tumors. They are much easier to remove because this cyst is like, there is fluid and there is proteinaceous material and there is some blood kind of material, and on the walls there is tumor, but there is a high rate of recurrence in these kind of tumors where there is a fluid level in the cyst. Now you see this another tumor. This is a trigeminal neurinoma. I'm not sure if you can carefully see there is a fluid level in this. There are multiple fluids level in this tumor, and it is quite straightforward to remove this tumor, but there is a high possibility of recurrence. So there can be a consideration of upfront radiation if you are not able to remove these tumors radically or completely. You see, there is a huge tumor and there are multiple cysts, and each cyst has a fluid level. If you see carefully, there are fluid levels in all these cysts. There is a large fluid level, but whether fluid level or no fluid level, it remains confined to the dural margins. Bilateral cysts are also, bilateral tumors are quite frequently associated with neurofibromatosis. And in neurofibromatosis, there can be one large tumor, one small tumor, and all these tumors do not need to be resected. And when these tumors have to be resected, you have to consider on symptomatic presence, when it is presenting with symptoms and what are the symptoms. In my estimation, the only indication, the first prime indication of operating on these tumors is ataxia. When the patient comes with ataxia and with this kind of tumor, you have to remove even when there is a bilateral tumor. Now, this is a patient with NF2. You see there is one large acoustic and one there is a trigeminal neurinoma. I call them very close proximity. They are almost kissing tumors. And this kind of tumor is a very interesting tumor. Patient may present with only marginal symptoms. Of course, there may be ataxia in this patient and you have to remove the acoustic tumor. If there is some sensory loss in the trigeminal, you may not have to remove this trigeminal neurinoma in a case of NF2. This is a case of NF2 where there is an acoustic tumor along the GSPN. There is a fourth nerve tumor. There is a sixth nerve tumor, and there is a trigeminal neurinoma. You see how the fourth nerve tumor is encasing like this, the brainstem, and traveling along the course. There is a sixth nerve tumor. There is a trigeminal neurinoma. So NF2 can present to you a therapeutic dilemma as to when to operate and when not to operate and how much to operate. Radical resection may not be necessary in these cases. How much tumor resection is necessary, that you have to decide on individual basis. Ossified tumors have very rarely reported. Trigeminal neurinomas are chronic tumors. Trigeminal neurinomas are benign tumors. They can be present for a long duration of time. In my series, there are 4 cases with ossification. You see, bilateral ossification in trigeminal neurinomas is a very, very rare, but it has been described and we have identified 4 cases. And you see how bilateral tumors, they are almost touching. The brainstem is squeezed. The patient may present with marginal symptoms of chronicity of tumor. That is the beauty. Chronic tumor, the brainstem also gets adjusted to it. The symptoms may not be very massive, but how much to remove, how much not to remove, how safe you have to, is a very beautiful chapter in NF2 surgery. This is another tumor. There is a trigeminal schwannoma on one side and there is a retrobulbar tumor on the other side. This is a hemangiopericytoma. This is a trigeminal neurinoma. So there are 2 tumors. It looked like this tumor and these tumors are looked on imaging very similar, but this turned out to be, you see, this was angiogram. There was a very high vascularity. This tumor was removed first and then the trigeminal neurinoma was removed. Next, both tumors relatively benign, and after several years, this patient is still very fantastic, no radiation, no other treatment. The beauty is that you have to know how to resect. And I have to only tell you that several years ago, 25 years ago, trigeminal neurinoma surgery was in infancy, and there is no question that we took part in the development of this surgery. So the diagnosis of trigeminal neurinoma is very straightforward. Characteristic clinical features: symptom of numbness in the distribution of nerve and wasting of the temporalis and masseter muscles. These are characteristic features. In our series, I had written this article several years ago that these kind of large tumors can present with pathological laughter. Rare symptom like hypothalamic hamartoma, but I had reported 4 patients. Now I have got 7 or 8 patients of this kind of large tumors where pathological laughter was one of the important presenting symptoms. Another important issue is characteristic anatomical feature. This tumor, you see, this was a meningioma, this was an aspergilloma, this was a hemangiopericytoma, trigeminal neurinomas. This looks like dumbbell, but this kind of vascularity is never found in trigeminal neurinoma. So on the basis of anatomy, you have to identify this is trigeminal neurinoma, because surgery for trigeminal neurinoma is quite a small. You don't need huge or massive exposures. You need to understand the anatomy. You have to understand the petrous apex anatomy. You have to understand the superior petrosal vein anatomy. You have to understand that these tumors are firm but not very vascular. Many of these tumors are soft. You can break these tumors. You can debulk these tumors. The most important issue in trigeminal neurinoma surgery is learn the art of breaking the tumor. And that is surgery for trigeminal neurinoma is a very important surgery for skull-based surgeons. And I have developed in this field over several years. In 1992, you can imagine, so 31 years ago, I did this case. At that, in those era, only, you know, these tumors were, there was two-stage operation. Nobody talked about, you see, there was discussion, Malice described one-stage operation, but one-stage operation was under development at that point of time. So even in 1992, I did this tumor in two stages. So first stage, I removed the part in the middle fossa, and then I removed the part in the posterior fossa. So this was two-stage surgery in 1992. Another case in 1992, this was a large tumor. I removed this tumor first. This was the residue after first surgery, and then I removed. So essentially what I'm trying to say is two-stage surgery was very important and was the only surgery because these tumors were not well understood in that era. In 1991 or 1989, Malice described single-stage middle fossa approach probably for the first time in the literature. So trigeminal neurinoma, my initial concept was play with the dura in the middle fossa and play with the dura in the posterior fossa and play with the dura in the extracranial compartment. So this slide, which I'm showing for the last 30 years, the same slide, that this part of the tumor can be within the dura, this part of the tumor is intracranial and maybe subarachnoid in location. As we developed trigeminal neurinoma surgery and cavernous sinus surgery, as we understood the anatomy of this area, we described for intracavernous sinus extradural approach to tumors. You see, we all know extradural approach was described by Vinko Dollens for aneurysms, but this paper in 1997 was the first time that extradural approach was described for trigeminal, for intracavernous sinus tumors. In 1996, my exposures were very big and huge for all these tumors, but understanding of the dura had made my understanding and surgery a much more anatomical surgery. I have to show you this slide. In 1995, I published this paper, Infratemporal Fossa Interdural Approach. So about 30 years ago, I have to tell you 30 years ago, trigeminal neurinoma surgery was very much in infancy. And you see the advanced nature of surgery at that time. I removed trigeminal neurinoma surgery on the tumor on the basis of anatomical understanding, diagnosed on basis of characteristic presenting features, and did infratemporal fossa interdural approach without a craniotomy. At that time, and even today, I will say not many people understand these tumors and orbitozygomatic. In 1994 and 1995, skull-based approaches were very popular. Orbitozygomatic osteotomies and things like that were very much in demand, but I removed this tumor without craniotomy in 1994 or 1993. This tumor, posterior fossa extension. This tumor, even Cushing had said that these kind of tumors which extend in the posterior fossa are the last chapters of neurosurgery. Elmefty wrote about it in 2001 or 2002 that these are difficult tumors. And you can imagine, I wrote this paper, I did this tumor trigeminal neurinoma without craniotomy in 1994 on the basis of understanding of dural anatomy. And you can see there is no craniotomy, and I just widened the foramen ovale, worked within the dura and removed this tumor. So, and this was another paper, one other figure in the same paper of mine where I did not do any craniotomy. So essentially, we developed this interdural approach in a very magnificent manner right from 1994 and 1995. Similar to trigeminal neurinoma are C2 neurinoma. C2 ganglion is the largest ganglion in the spine, like Gasserian ganglion is the largest ganglion in the cranial cavity. And the C2 neurinomas are amongst the similar kind of issues. So we wrote this article 60 cases in the year about 15 years ago, and this paper we wrote about 10 years ago. And my strategy was C2 ganglion tumor are interdural here and intradural here, like trigeminal neuronoma, intradural here, interdural here, interdural here. Can you just hold on for 1 second? Sorry for that. No, I'm sorry. Whether I'm no. Hello, Samay.
Okay, go
Samay,
ahead.
is there some override over some voice is coming?
Yeah, I'm sorry, I'll take care of that, Atul. I didn't
There is some
know.
voice coming or what?
Yeah, okay. I don't see any other noise there.
What
Atul.
is this coming? I think some overriding is coming. Can I stop that? there is
It's
some
either coming from Sam, you, or me.
So
No,
from where is this
coming
noise
from-
coming?
from outside.
No, because I can hear some noise. This is my noise, but from some other. Just a minute.
Okay, it's coming from yours microphone
I'm
or
not
Sam,
sure.
or Sam's.
Sam, I think it is coming from your microphone. Can you remove that voice?
Yeah, let me just mute Sam and then we'll see.
This is my,
Yeah, let me see.
no, there is, can you
Okay.
just, I'm little bit,
Yeah, he's muted there, but it's still a noise. It's not coming from mine.
so what should I do, you think?
Let's see, I'm gonna mute you for a second there. Atul. Okay, the noise goes away when you're muted, Atul. So the background noise appears to be coming from your mic. Okay,
I think, Atul, it could be something in your computer that some recording or something else that might have activated without you realizing.
yeah, you may have something else going on, Atul.
Yes, I think you should just continue. It's not that bad of a noise.
You're muted now, Atul. Okay, are you okay there, Atul? Can you hear me? I think he may have dropped out for a second. Just wait, just be patient. He usually comes back. He always comes back. The digital break.
Well, let's have a coffee then.
That's it. Digital coffee break. Popcorn break. We'll just wait a second for Atul. He should be coming back. This has happened before.
Okay, we will proceed then.
Okay, Sam, whatever you think.
Okay, Professor Lanzino.
Yes, thank you for the opportunity of being with you today. I thought that to change slightly course, I would just discuss on some basic and advanced concept on spinal vascular lesions. Now, I remember when I started, I was a resident, you know, the classification of spinal vascular shunts, arteriovenous shunts, was really difficult to remember for me because it was really not based on any specific criteria. More recently, a classification popularized by Dr. Spetzler, among others, I think makes quite a lot of sense. And based on these classifications, arteriovenous shunts are classified based on their relationship to the spinal canal. So you can have paraspinal arteriovenous AVMs usually, and then you have the epidural arteriovenous fistulas, the proper dural fistulas, the type 1 vascular spinal malformation of the old classifications. And then as you go intradurally, you have PL, arteriovenous direct fistulas, the perimedullary type, that is a particular type. And then you have AVMs of the spinal cord proper that share a lot of characteristics with AVMs of the supratentorial compartment. Now, the dural spinal vascular malformation, the so-called type 1 of the old classification, is by far the most common one. And I will use a few case examples to illustrate the most important characteristics of these different types of vascular malformations. This is the case of an 82-year-old man. This is very important because, as we will see, the demographics of the dural spinal vascular malformation is very typical. Usually men in their 7th or 8th decade of their life. The presentation can be quite subtle at first, but progressive myelopathy characterized by both motor and sensory symptoms with bladder involvement in the later phases. It's a characteristic as the hallmark of the disease, but because the symptoms are subtle at first, and because of the demographics, these vascular malformations are found in elderly men. It is not uncommon that even today, quite a number of these patients is submitted to spinal surgery at the lumbar level for symptoms that in retrospect were not related to the degenerative disease of the spine, but indeed to the vascular malformation. The MRI findings in advanced cases are pretty striking in characteristics, but in early cases, in some cases, can be also quite subtle, but they all mark on T2 MRI, as you can see in this sagittal study, is the T2 changes with the increased T2 changes that characteristically involve the lower thoracic segments, and usually, although not always, as you can see in this particular case, they extend all the way to the conus. Now, in these cases, you can see some cases have the typical presence of flavoids along the dorsal aspects of the thoracic spine. But like in this case, sometimes the flavoids might not be quite as easy to identify. Spinal angiography is still the gold standard to identify these lesions, characterize them, and also identify the correct location. You can see here a typical injection of an intercostal artery with the radiculomedullary artery that forms a tiny little nidus, usually at the level of the dura. And then you can see the intradural dorsal vein, which usually emerges from the dura at the level of the corresponding pedicle and nerve root. You can see here the feeder and the intercostal, and this is a magnified view. You can see here the connection, and as you advance, you can see that there is a small nidus which converges into a single draining vein which emerges from the dura. It is important information on the spinal cord, as you can see in this case. You like to know the origin of the Adamkiewicz, and in this particular patient, the Adamkiewicz originated from the opposite, from the left side, but at the same level of the feeder, which gave rise to the dural spinal vascular malformation. Now, the catheter, the spinal angiogram for these lesions is not always straightforward, and we still see a fair number of patients that have had one or even two prior spinal angiograms where the angiogram did not show the actual fistula. And the main reason why this the spinal angiogram can be particularly challenging in this patient is because, again, often these are elderly men, so they have an important degree of atherosclerosis. And particularly challenging can be those vascular malformations that are fed either by arteries of at the high thoracic level, that like a T3 might be very difficult to catheterize, or the those arteriovenous fistulas that are fed by branches of the internal iliac. So those are some of the most common reasons why a fistula, when present, might not be easily identifiable on the angiogram. In exceptional cases where we were unable to clearly demonstrate a fistula on a spinal angiogram, we have utilized PC Fiesta MRI in helping us to identify similar sequence that is utilized to identify vascular conflicts in for cranial nerve neuropathies like trigeminal neuralgia. And more recently with the CT angiogram, and we are doing a study looking at photon counting CT angiogram, seems to be promising in helping with these lesions. Now, once you identify the lesion, that is often the most difficult part of the entire process in this particular pathology, The question is endovascular versus surgery. Well, endovascular therapy is a valid therapy, but it's usually less effective than surgery in achieving a complete occlusion and permanent occlusion of the fistula. Sometimes endovascular therapy might not be the safest approach because the feeder might share supply to the spinal cord. It's very important to be particularly aware of this possibility, especially nowadays when we tend to use liberally liquid embolic agents. Once surgery is planned, especially when these lesions are in the mid-thoracic area, visualization and identification of the correct level can be challenging. And for this reason, I like to place a marker before the surgery in the pedicle so that, as you can see in this example, the marker is very easy to identify during planning of the incision and during removal of the bone and the bone work. So, as I said, once these fistulas are identified and localized, then the treatment is really pretty simple and straightforward. And it's for the true dural types, you open the dura, and as you can see, you find consistently a vein arterialized draining vein, which emerges from the dura, usually, but not always, at the level dorsal to the corresponding pedicle, right at the level or adjacent to the foramen. Once you identify, the treatment is coagulation and division of the early arterialized vein, not dissimilar to the treatment of supratentorial dural fistula with exclusive retrograde venous drainage. Sometimes, as you can, if you look, you can see this a patient that had been previously treated with onyx. You see in the epidural space, the feeding artery is converging into the focal point, but again, the treatment is not in the epidural space. The treatment consists on opening the dura, looking intradurally, and you can see the characteristic arterialized draining vein emerging from the dura. And there is controversy whether the shunt is inside the dura, if the shunt is intradural. In any case, this is a very typical characteristic appearance of the arterialized draining vein, and the treatment, as I said, it's fairly typical. This is another case, the arterialized draining vein emerging from the dura, and I like to place do a baseline ICG fluorescent, place a temporary clip, repeat the ICG fluorescent to indeed confirm that we have obliterated the target. But again, once you have done a few of these, the intraoperative findings are pretty typical, and ICG fluorescent is a nice tool to have, but not necessary for this particular problem. And yet another example, open the dura, arterialized draining vein, draining into the dorsal venous plexus. Here is particular of the arterialized draining vein emerging from the dura, dorsal to the corresponding pedicle, and you can see the corresponding nerve root. And I'll go quickly. These are some of the basic steps that are common, that are known to everybody, but here is a short video. Small opening, once you localize, you go above the corresponding pedicle, and we don't open the arachnoid except for a very small segment along the course of the arterialized draining vein. separating the arterialized draining vein from arachnoidal adhesions. There is here a small bystander vein that it's not involved, it's not part of the fistula. Lifting the arterialized draining vein and with the low power cautery, coagulating a short segment very close to the origin, and then interruption of the vein, and that results in treating these fistulas 100% of the times. And here you can see after ligation, you see that the characteristic change in color of the exuberant dorsal venous plexus. So as I said, that these fistulas are relatively uncommon, but they are an important cause of correctable myelopathy. And you have to be very careful in correctly identifiable. And then there are some types that the epidural arteriovenous malformations of the spine or arteriovenous fistulas, it looks like they are becoming more common. As far as the typical spinal dural arteriovenous fistula is concerned, as I said, the demographics are fairly typical. Usually patients in the 7th, 8th decade. So if you find a fistula, or if you see MRI findings typical of a fistula in a young patient, be suspicious that might be a different type. There is a striking male predominance, and the true dural fistulas are very common in the thoracic spine, in the thoracic levels. If they involve the lumbar levels, usually it's L1 through L3, they are exceptional in the cervical spine. Here is over 18 years, a compilation of over 200 cases of different spinal vascular malformations that we have seen. And you can see that the dural type, it's by far the most common, but the epidural arteriovenous fistulas is something to keep in mind because they are more common than we thought just a few years ago. So this again, some of the now the pathophysiology is very interesting because it's a venous congestion, and being a venous congestion, of course, the most dependent areas in the at the level of the conus and the lower thoracic segments are interested. And again, the pathophysiology is in ascending myelopathy. I remember if T2 changes, because this always comes into the differential with transverse myelitis or other pathologies of the spinal cord. And if the T2 changes are present on MRI, the conus is usually, but not always involved. So this is a very important discerning factor. And I'll go just here to say that we tend to use steroids a lot in neurosurgery, but in these patients, the steroids are contraindicated. And it's very common that these patients are first diagnosed as having transverse myelitis, are treated with high-dose steroids, and almost uniformly after treatment with high-dose steroids, they experience a clinical worsening that is related to the fact that this is a venous pathology. There is congestion, and by giving high-dose steroids, what we do, we increase the venous congestion paradoxically by increasing intravascular volume. So be very careful and avoid steroid in this type of pathology. We can now shift gear and talk about a different type of vascular malformation that is classified apart from the arteriovenous shunts, and that is cavernous malformation. This is a case of a 52-year-old who presents with neuropathic pain, very typical presentation of these cavernous malformations. They can be quite large, but especially at the beginning, the presentation, the clinical symptoms might be relatively minor. She did not have any deficit, and you can see that on the pre-op, the characteristic appearance of the cavernous malformation. This case was localized in the upper cervical spine, so very delicate, of course, very delicate location. And we recommended surgery as her symptoms started progressing, because you see some of these patients, they develop slow oozing of blood, and this can create quite tedious progressive dysesthesia like in this patient. So here is, the exposure is can do usually we do a laminoplasty. I always like to open the dura separate from the arachnoid, and you can see we recommend surgery if the lesion is coming to the dorsal or to the lateral surface. For those rare purely anterior lesions, we consider surgery only after a recurrent bleed. But in the spinal cord, especially when the cavernous malformation comes to the dorsal or lateral surface, we recommend surgery after the first symptomatic event. This is a subdural electrode that we use for delta weight, which is the continuous monitoring of motor function. Separating the arachnoid, we try to preserve this vein by skeletonizing and mobilizing it. Carefully incise the pia, drain some of the liquid component present in the caverns, and then carefully going and identifying that interface. And the challenging part for these lesions is the fact that this is like a cauliflower. So there are lobes that are digging inside normal parenchyma, and therefore it's important, really to stay, as we all know, really to stay at the surface of these lesions. And usually I prefer a piecemeal resection to en bloc resection, just because, at least in my hands, that diminishes the degree of manipulation. And I have this custom-made forceps with the round teeth that you see. They have a diameter of 1 millimeter, and they are very, very useful in the management of these lesions. And here is the immediate post-op. I always like to do an MRI the day after to establish a baseline, and you can see the resection and the bed. And always we leave in the spinal cord. We don't go after the hemosiderin staining surrounding brain, but stay inside the gliotic plane. And these patients, they do quite well. And again, we are very aggressive in giving indication for those patients with dorsal or lateral extension of the cavernous malformations. We do not operate in asymptomatic patients with incidental lesions. And here, before concluding, just a few words on this particular type of spinal vascular malformation, the so-called perimedullary one. These lesions are rare. They are typically localized at the level of the conus. They can present with the hemorrhage, with the progressive myelopathy, or with the radicular symptoms secondary to compression of nerve roots. The treatment is surgery, endovascular, or sometimes both techniques combined with the pre-surgical endovascular embolization. This is a 34-year-old who presented with really typical sciatica, an S1 radiculopathy that presented during pregnancy. You can see on the MRI there are T2 changes involving the conus, and you can see that there are perimedullary flavoids. There was some degree of contrast within the spinal cord. And here is the spinal angiogram. You can see a dilated anterior spinal artery, which goes around the conus. This is a lateral view around the conus, and then anastomosis with the branches of the posterior spinal artery at the level of the so-called basket of the conus. And here is the direct AV shunt. Often these lesions have a direct AV component, like a direct fistula, and then there is an associated small nidus, as we will see in this patient. And you can see here there is a varix at the level of the proximal draining vein, which in this patient was causing the symptoms. Here it's after exposure. Let's see if I can get this to after exposure. You can see this large varix compressing the nerve roots of the conocauda. And here the key is the ICG fluorescence. Here is very helpful because the key here is to identify, particularly to identify the main direct AV shunt. So you can see this large venous varix that was compressing in these patients the nerves of the cauda. A small AVM clip and coagulation of the point of the direct AV shunt. You can see now the draining vein has changed color, but there is, in these patients, there is still, you can see here, there is still a small nidus that in this particular patient goes inside the conus. Since she did not have any evidence of conus dysfunction, we did not chase the nidus inside the parenchyma. And here you can see the post-op with the direct shunt is been excluded. There is still a persistent nidus, but having excluded more than 90% of the flow, you can see that after 1 year, there is a resolution of the contrast and improvement. And you can see here the clip artifact. We left in this patient a small clip at the point of interruption for reference. And here again, the compression of the nerve root. Thank you very much. And once again, thank you for giving me the opportunity of being part of this distinguished panel.
Thanks a lot, Professor Lanzino, for the excellent presentation. Is there any question from panelists?
Hi.
Yeah.
Hello.
Sorry. I have a question regarding intramedullary lesions, cervical ones, which are a big problem. And what is your approach there?
So some of many of these cervical AVMs, they tend to have a primary PL component. So we would consider surgery in a patient that is symptomatic. Usually they present with the bleed. And several authors have shown that they surgically they behave a little bit in a different way than supratentorial AVMs, in the sense that you can progressively identify the feeding arteries and coagulate the feeding arteries without necessarily removing the complete nidus, just by disconnecting the arterial inflow. And that is our approach. And for those particular lesions, ICG fluorescence is incredibly helpful because you can do multiple sequential ICG runs to help you to differentiate the feeding arteries as they enter the nidus from the draining veins.
Well, thank you very much for that very helpful tip. Actually, but you would not want to employ any temporary clips, obviously, because you have to minimize the manipulation in the cervical cord in these lesions, isn't it?
Yes, you work on the surface, and like in the AVMs in eloquent areas, you stay at the interface between the nidus and but it's surprising how we did, probably because the flow is much lower than the supratentorial brain AVMs. You can in these cases you can in some cases you can do almost like a piecemeal resection of the AVM by disconnecting certain areas and slowly removing again in a almost in a piecemeal fashion.
All right. Thank you very much. Very excellent presentation and very practical presentation. Thank you.
Hello, Professor Lanzino. How are you?
Hey, I'll be here.
And if there is a if I don't get a spinal dural fistula, like you said, spinal angiography negative fistula, but there is a fistula, can you get a clue on the axial cut of the MRI? Do you have some kind of venous congestion? I found that in one patient, but is this consistent?
Yeah, so if you do like a PC Fiesta sequence where you can see, basically we call it a hook. You can see the draining vein that usually comes off the dura, goes up and then turns down. So that's one indirect sign. The other thing is that a lot of these fistulas that are difficult to localize on angiogram, it's because they are fed by branches of the iliac, internal iliac arteries. So it's very important to pay close attention to those runs. And the other thing is that those usually those are epidural spinal vascular malformations, but on MRI and clinically, they look exactly the same as a dura. In those cases, what you see on the MRI, you see a single vein that comes down and goes and runs along the phylum. You don't see the typical flavoids, but you might be able to see a prominent vein. And that on the MRI, it's a clue that the fistula might be, usually it's fed by lateral sacral arteries in that situation. So those are the two main indirect clues that, at least in our experience, we can get from MRI.
Thank you, Professor. That was a great talk. Thanks.
Thank you, Dr. Lanzino. Hashar, do you have a question?
Hi, Professor Lanzino. Once again, I'm hearing your lecture, wonderful lecture. In the past also, I heard you few times in same lecture. I wonder how many cases you found intradural bleed due to the AV fistula. Did you encounter anything? Any cases?
From a dura fistula?
Yeah.
Only if they are at the craniocervical junction. I've encountered only one bleeding from a spinal dura fistula below the craniocervical junction, but still to this day, I wonder if that patient had a spinal dura fistula, but also an intradural cavernous malformation. So the bleeding subarachnoid hemorrhage or intraparenchymal hemorrhage from a spinal dura vascular malformation below the craniocervical junction, below C1, 2, it's, I think, extremely rare, almost unheard of.
I recently encountered similar kind of patients who was again a dorsal fistula, AV fistula. Now, I'll tell you, this patient, elderly lady, presented with acute paraplegia and bladder ball involvement and presented after 48 hours, and the MRI showed just a bleed in the, and we evaluated by many coagulopathies and all sorts of things, except the spinal angiography. And I explored this patient, and what I found at D8, D9, there was an AV fistula, which was after evacuating the hematoma. And to my surprise, this was the first time I was seeing, although I don't have a large experience like yours, but whatever number of cases I've seen, and it was very difficult to even find out what is the cause of this bleed. So AV fistula causing bleed is very rare in dorsal spine, which we have never seen. That's why I ask you, have you seen this kind of lesion?
Only once.
Yeah. And second thing, I would personally feel even if you operate or embolize, the neurological recovery is very, very slow, or they don't recover. What is your experience?
So usually I tell patients, you're correct. The recovery is not quite as good as some publications might imply. So I tell patients that if we find the fistula and we close it, we can stop their worsening. In terms of getting better, I would say that most patients report some degree of improvement of motor symptoms, unless they are they have a complete paraplegia. But if it's incomplete, they experience some degree of improvement of motor symptoms in 80 to 90% of patients, sensory symptoms less so. But the thing is that they don't go back to normal. They will often are left with some degree of persistent dysfunction. Now, there are some cases that have a really incredible recovery, but the majority, they do improve, especially when it comes to motor symptoms, but they rarely go back to a normal baseline unless you find them and diagnose them very early on in the course.
Even the sphincters, once they are involved, difficult to get them back.
Yeah, only
this is our experience here.
Less than 30%. I agree. Yeah. Sphincter, so it's a motor. They improve quite often to some degree. Sensory less often. Sphincter function is the least one to show any degree of improvement. Usually about 30% they experience some improvement as long as they did not have complete loss.
Wonderful, wonderful. You are always free to listen. Great.
Thank you.
Thanks a lot, Professor Lanzino, for the excellent presentation and discussion. Thank you. And now we will shift to the next speaker, Professor Tanikawa. Please start sharing your screen.
Hello, can you hear me?
Yes.
Okay.
You want to make it full screen? Yeah. Perfect.
Can you see my slides?
Yes, it's okay.
Perfect.
Okay. Okay. Thank you for the invitation. It's a very wonderful neurosurgery meeting. Today, I'd like to talk about the surgical treatment of intracranial aneurysms. In treatment of the complex intracranial aneurysm, so we need microanastomosis. The principles in microanastomosis is very important. The most important thing is everything of both vessels to stitch. Intima to intima attachment is very important. Otherwise, you can't get successful anastomosis. And another principle is a Fishman streaming like this, and end-to-side anastomosis. At the end of a donor vessel, I usually perform the Fishman streaming like this, the 60-degree oblique cut, and same length cutting up along the donor like this. With this Fishman streaming, you can make the stitching area longer, approximately 2.3 times larger than the shrunk diameter of the donor. But it makes it easier to stitch, especially to confirm the intima to intima attachment. This is the principle to stitch how much the stitching bite is necessary. I recommend to do 2 times of wall thickness as the stitching bite, and stitching intervals should be 4 times of wall thickness like this. With the stitching, you don't have the leakage after the reflow of the recipient. This is a drawing by McLean Cosmonoda. With this principle, you can stitch with 2 times the wall thickness stitching bite, and you can make this kind of exact stitching. Then you can have the successful microanastomosis. This is the radial artery M2 bypass. This is the radial artery as a donor, and here is the stitching after the stay suture at toe and heel. And this part is the most difficult part to stitch next to the stay suture. After finishing one side stitching, you can confirm inside whether there are some mouth stitching or not. Anyway, after finishing stitching, you can remove the temporary clip on the recipient. This is the proximal stitching at the external carotid in the cervical neck. Then you can finish the radial artery, external carotid, and intracranial MCM anastomosis. The principles which describes in drawing the Cosmo drawings well, like this. And this is a current my rule to stitch the stitching order. As a stay suture at heel and toe, then the first stitch should be next to the heel stay, and the second stitch should be next to a toe stay. After this first and the second stitch, you can make the third stitch at the as a intermediate stay suture like this. Then you can stitch the remaining part. I usually perform like this: number 4, 5, 6, and then 7 and 9, like this. So usually, if you stitch like this, you need 20 stitches. And the important thing is that we need the sufficient practice to finish the one stitch in 1 minute. If you spend 1 minute with this manner, you will need 20 minutes to complete stitching. It's a very appropriate temporal occlusion time. Less than 20 minutes, in my experience, 20 minutes temporal occlusion causes nothing, no ischemic complication, even in the M2 of middle cerebral artery temporal occlusion. So the 1 minute and 1 stitch is at least condition to perform the successful anastomosis. I'll show you exact actual case of complex aneurysm. This is unruptured right side ICA, basilar ICA aneurysm. You can see this is a relatively high position ICA. So in this case, you can approach to this aneurysm through the terminal approach. This is the right side terminal approach. And this is orbital skeletonization after standard front temporal craniotomy. And I am trying to detach the dura propria from the supraorbital fissure, elevating the dura propria. And I'm confirming the anterolateral triangle in between the V1 and V2 and the third and fourth nerve through the inner reticular layer of lateral cavernous sinus wall. By elevating dura propria, you can open the oculomotor foramen as well as the trochlear foramen. You can see it. And with the dissection of the arachnoid, especially lyricus membrane lateral to oculomotor nerve, you can expose the supracerebral artery, and additional dissection of the dura mater between the third and fourth nerve. You can open the posterior cavernous partially, but the bleeding from cavernous sinus could be easily controlled with a fibrin-soaked gel form of Sargicel. The cavernous segment oculomotor nerve could be detached, and now you can secure the operative field to clamp the basilar trunk proximal to the aneurysm and ICA, and you can make the complete neck clipping in so-called oculomotor tentorial triangle. In this case, of course, the tentorial edge is elevated, and you can extend the surgical field, the caudally, and you can secure the operative field to clip the ICA aneurysm safely. Another case, this is an unruptured symptomatic thrombosed giant supracerebral basilar aneurysm. You can see the aneurysm is embedded in the brainstem midbrain. So the problem is the patient have the hemiparesis. So the purpose of surgery is to block the blood flow, blood supply to inside the aneurysm. You need the neck clipping of the aneurysm. But the problem is to expose the aneurysm neck like this, and secure the operative field to put a temporal clip on the basal trunk. As I expected in the previous video clip, you need to extend the oculomotor tentorial triangle by elevating dura propria, and of course you need to open the oculomotor foramen. Then you can secure the operative field to clip the aneurysm neck. In this case, the first clip could be occluded aneurysm, but the superior cerebral artery was occluded by the first clip, so I replaced the clip using a second clipping. But the several minutes observation, the superior cerebral artery gradually occluded because the clip is slipped in gradually. So I tried to do a STA, a superior cerebral artery bypass, as an end-to-side anastomosis. Then the post-operative CT scan and the CT angio shows a good fitting of the both of PCA and the superior cerebral artery, and diffusion image shows nothing ischemic complication. The patient recovered well. Another case, this is a 55-year-old man. 10 years ago, the patient had the clipping for ruptured distal AC aneurysm, but unfortunately, the aneurysm has a recurrence as a thrombosed giant aneurysm. So the patient referred us to undergo the direct surgery. In the preoperative surgical plan, we expected that the direct clipping will be impossible. So I'm doing the STA ACA direct ECIC bypass with using the superficial temporal artery. And in this case, the parietal branch and the frontal branch is to show, so the both branches was anastomosed as end-to-end anastomosis, and make the STA longer and direct STA right side ACA bypass could be performed. After the securing blood flow to the ACA territory, I am trying to detach the previous clips on the aneurysm. Now the revascularized right side distal ACA is clamped, and thrombectomy of the aneurysm could be done. Then gradually you can reduce the mass of the aneurysm, and it makes easier to detach the aneurysm from the contralateral A3 like this. Here is the proximal ACA, and this is the contralateral A3 proximal side. And now I'm detaching the adhesion of the aneurysm and the granulations. Now I put the temporal clip on the proximal A2 and the bilateral A3. Then I could make the space to put the clip on the neck. Partially, the fragile part of the aneurysm is ruptured like this, but the neck clipping was possible. So as a result, I could do a complete neck clipping with the two clips. The STA ACA bypass was just insurance before the neck clipping in this case. This is the final case of in this presentation, the 16-year-old female thrombosed calcified giant aneurysm in the left MCL bifurcation. Now the aneurysm is exposed now, and small lenticular striate artery is attaching on the aneurysm. In this case, I have done the STA-A2 bypass, and I try to preserve this lenticular striate artery. After detaching it, I put a temporary clip on the distal M1 and M2 segment, but the thrombosed part of this aneurysm has the calcification, and I removed the calcified part and remove the temporary clip. But the lenticular striate artery was occluded with manipulation. So I decided to reconstruct it with the STA, another branch, as an end-to-end anastomosis. It looks good. The ALS lenticular striate artery could be preserved. And after that, the M1, M2 direct end-to-end anastomosis could be done. The IC green shows the occlusion of the STA lenticular striate artery bypass. So I tried to re-anastomosis for lenticular striate artery bypass. You can see in a second bypass, the lenticular striate artery could be filled with the STA. Like this. So in this case, the lenticular striate artery was preserved with the STA bypass, and the MCA is filled with a direct M1, M2 anastomosis. Fortunately, patient tolerate well, and the patient recovered with no death-rate ischemic complications. So in summary, the clean and bright operative field is necessary to complete not only a neck clipping, but also the revascularization of intercranial vessels. Now, of course, hemostasis in every step is most important thing. And we need the highest magnification for exact dissection and the stitching of the vessels. We can cut only arachnoid membrane, and the intercranial veins must be preserved during the approaches like transribian or interhemiscal approach. The most basic principle is the technique of distal cerevian separation is the fundamental skill to perform the microanastomosis. And watertight dural closure during head closure. And this is a very important part in the craniotomy, and daily craniotomy and watertight dural closure is a very good practice for, especially for young neurosurgeons. My mentor, Professor Kamiyama, 30 years ago, he told me that the neurosurgeon who cannot close the dura watertightly cannot perform the microanastomosis. I think now, I think it's true. So, especially this is my message for young neurosurgeons in daily surgery. Please meticulously stitch the dura to close dura watertightly every day in every surgery. That's all. Thank you very much.
Thanks a lot, Professor Tanikawa, for this excellent presentation. Is there any question from panelists?
Yes, I want to congratulate him for bringing these very, very essential points of microanastomosis, presenting them in such a nice way. Now, a lot of people you see, and they do running sutures. Now, I don't like them. I'm against it. Why are you not doing running sutures? Well, what are you thinking about running sutures?
Yeah, I do a running suture in intracranial sutures of the vessel sutures. Depends on the size of the vessels and softness or hardness of the vessel wall. For example, when I perform the moya microanastomosis, in such case, the recipient is less than 1 millimeter, sometimes 0.5 millimeter. And of course, for such microanastomosis, we need the smaller branch of STA to avoid the discrepancy of the size. So in such a case, the interrupted suture is appropriate. The running suture is to squeeze the orifice of the anastomosis. But if the vessel is large enough and thick enough, even with the running suture, the orifice cannot be squeezed too much. So that depends of the vessel condition. You can choose the way of suture, whether the running suture or interrupted suture. So I do not deny the running suture. It depends on the vessel condition. I choose the running suture.
Right. And what size of needle is your favorite? Is it 8-0 or 10-0?
Yeah, as well, it depends on the vessel size. For moya, the less than 0.8 millimeter, I usually perform the 11-0. For standard STA-MC bypass, including STA-M4 bypass, usually use a 10-0. But if I anastomose the radial artery or saphenous vein to the M2 segment, I choose a 9-0. Sometimes, if necessary, I choose 8-0 nylon. And if I try to do a running suture in the radial or saphenous to a M2 segment, I choose nowadays 8-0 or 7-0 Pronova. Previously it is so-called Prolin. The Pronova is the advanced model after the Prolin. It's much more stronger than the Prolin. So I prefer Pronova now to do a running suture.
Right. And one last technical thing. I believe 3 knots, produced or done in the right way are enough for a single stitch.
Yeah, exactly. Yeah, exactly.
But they have to be done the right way. One left, one right, one left.
Yes, exactly. It's right. We need to the stitching direction should be the right side and left side, right side and left side. That we need to understand the the direction of making a loop, in every time you need the opposite side making loop.
Yeah.
So the 3 times is necessary to stitch.
Okay,
time.
thank you very much, sir. Thank you. This is all what we did for hours in Professor Yashagil's lab in the 80s actually. So very nice lecture. Very good points. Thank you very much.
Thank you.
Is there any question from panelists? Thanks a lot, Professor Tanikawa, for excellent presentation and for accepting our invitation. Thank you, sir.
Thank you.
And now we will shift to the next speaker, Dr. Kanyan. Dr. Kanyan Molo, please start sharing your screen.
Yes, sir. It can be seen full screen.
Yes, it's okay.
The first, I'm Kani Amulu, and the first of all, I would like to say thank you to my dear friend, Dr. Al Morsi, for inviting me here. It's a great pleasure to be here. So my talk is going to be about like principles of skull-base approach through the skull base or along the skull base to the brainstem lesions, either intrinsic or extrinsic lesions. So as we talk, we are looking from above to skull base here. We have anterior, middle, and posterior fossa. And basically, the border between anterior and middle fossa is a sphenoid ridge. And the border between the middle and the posterior fossa is a petrous ridge here. So the brainstem sits in the posterior fossa. So if you look at here, basically the lesions located in front of the brainstem or the ventral part of the brainstem can be reached through the middle fossa or anterior fossa, or the alternative pathway comes through the nose here. The lesions located laterally or dorsally to the brainstem, the posterior fossa approach, and from behind, we use a surgical approach from behind to reach the lesions located dorsal part of the brainstem or lateral part of the brainstem. The first option, I'm not going to go to detail for endonasal approach, but as we know, there's a midline approach through the nose endoscopically, and we can just reach, if we remove the clavus here, we can reach all the way down to the odontoid process here for the front, in front of the brainstem. So what kind of lesions can be reached through the nose is especially originating from the clavus here. Go this way. Here we see the midline tumors, the chordoma, like chordoma, chondrosarcoma. We can reach the petroclival meningioma, which is originating from the petroclival fissure. So we can reach it through the nose here, all the way down to the odontoid process. But today, my focus is going to be the open craniotomy. So the brainstem is divided into 3 parts, as we know. The top is the midbrain. The middle part is the pons and medulla, and cerebellum just covers the brainstem from behind. The vascularization we see here from front, we see the 2 vertebral arteries come together to form the basilar artery before the junction gives off the pica. And here we see the ICA arising from the basilar artery, and all the way up, we will see the superior cerebellar artery here. From lateral again, brainstem 3 parts, midbrain, pons, and medulla. And the rule of 3 from Dr. Roten, 3 parts of the brainstem and 3 parent arteries. And the medulla, the cerebellum has 3 surfaces. the tentorial surface, which faces the tentorium, suboccipital surface, which faces with the occipital bone, and the petrosal surface, which faces with the petrosal, the bone here laterally. So 3 surfaces of the cerebellum, 3 parts of the brainstem, and the 3 parents arteries. So the pica supplies the medulla and the suboccipital surface of the cerebellum. The ICA supplies the pons and petrosal surface of the cerebellum. And the superior cerebellar artery supplies the midbrain and the tentorial surface of the cerebellum, basically. Of course, the midbrain also takes the blood from the posterior cerebellar artery too. So for the intrinsic lesion in the brainstem, of course, the origin of the lesions, extension origin, excuse me, of the lesion is very important for make a decision. But basically, we can say this is the medial lemniscus that divides the brainstem ventral and the dorsal. Basically, we can say the lesions located in front of the medial lemniscus, which is the ventral brainstem. We can use the front approaches or lateral approaches. For the lesions located behind the medial lemniscus, in other words, the dorsal brainstem can be reached coming from behind. Those are very basic, of course, because there are some details. But today, my focus is going to be the surgical approaches. So let's take a look at the midbrain. The midbrain is the top of the brainstem, and it can be reached through the anterior fossa and the middle fossa easily. So looking from above, the anterior fossa is here. This is the sphenoid ridge part. In front of the sphenoid ridge is the anterior fossa, and here we see the middle fossa here. The target area is the midbrain, especially ventral part of the midbrain. We can come through the anterior fossa to reach the ventral surface of the midbrain, or the lesions located in front of the midbrain here. So this is Dr. Spesser's the technique, and for especially located to ventral located in the midbrain, for the usually we can use the ipsilateral or OZ approach. The OZ approach, when we remove the orbital roof, that gives access to the upper part of the brain, but also just gives the greater angle of attack for like the down. We can even reach the upper surface, like upper 1/3 of the pons, through the orbitozygomatic approach. So here's a contralateral OZ approach to give a straight shot to the lesion here. For this, the approach, and to reach that part of the midbrain, we can just our landmark is the occipital oculomotor nerves, ipsilateral and the contralateral. We can, if we follow the oculomotor nerves medially, we can reach to the interpennicular fossa right here, and we can just make an incision to reach to the ventral part of the midbrain. This is kind of risky because we will see a lot of perforating arteries in the interpennicular fossa, but it can be done based on the case. So this is the target area, the ventral surface of the midbrain. This is the options for surgical, the access. We can either go pterional approach, modified OZ approach, mini pterional approach, or we can use the eyebrow supraorbital approach to get to the ventral part of the midbrain. This is a modified OZ approach. We are on the right side, frontozygomatic suture. This is a zygomatic arch, upper part of the zygomatic bone. This is after turning the bone flap. Then here we see on the right side, we are still on the right side. Here's the ICA. We see the optic nerve is here. If you follow the oculomotor nerve all the way down, all the way back, we can reach the ventral, the surface of the midbrain here. Also, oculomotor nerve, like 95% usually passes between the posterior cerebellar artery and superior cerebellar artery here. Sometimes we can see a superior cerebellar artery above the oculomotor nerve is very like 3 to 5%. And here again, this is also kind of like pretemporal. This is the cadaver, so more stiff than the patient, alive patient. So we need to more retraction to demonstrate all the structures. But this approach, this exposure can be done through the orbitozygomatic approach. Another option is mini-OZ approach. This is the McCarty keyhole drilling. Put the one drill, the one hole is here, and then basically is removal of the orbital roof here, and here is the sphenoid ridges here. If you need to access to laterally, if you need to go laterally, we need to also drill the sphenoid ridge here. Otherwise, if you're gonna go straight forward all the way back, so sometimes you can leave the sphenoid ridge here, and we can go the subfrontal road all the way back. This is a eyebrow supraorbital. This is the medial limit of the incision is a supraorbital notch, and supraorbital nerve passes through the supraorbital notch. This is the foramen. Mostly we see the notch here, but we can also see the foramen here. And here we see the superior orbital rim here. After we remove the bone, this is the frontal lobe, and we can go proceed between the subfrontal area. This is the endoscopic weave again. You're on the left side. To reach the midbrain, I'm looking for the oculomotor nerve, but other structures here is optic nerve is here, is a contralateral, ipsilateral ICA, contralateral ICA here, and we see the ACA, Hebner's artery. This is the MCA, and if I follow the oculomotor nerve all the way back, we can reach the ventral part of the midbrain. Even we can see the pons, upper surface of the pons here. For lateral midbrain, this is the target area. We can come from above the tentorium, which is called subtemporal approach. Here what we see, this is the tentorium here. We are above the tentorium, but this is the surgical position. And this is the temporal. Here's the temporal lobe here. And we see here's the lateral mesencephalic sulcus, which is the border between the ventral and the dorsal midbrain. And here's a lateral mesencephalic vein. This is a landmark for the intrinsic, the cavernous malformation, or especially we see the glioma pylocytic astrostoma in this part. The lateral mesencephalic sulcus and the lateral mesencephalic vein is a landmark for the entry of the brain stem, midbrain, for the lesions located either ventral or mostly dorsal. And what we see is the thinnest cranial nerve is an oculomotor nerve before getting into the tentorium. Another option, we can come below the tentorium and supracerebellar infratentorial, and there's 3 options: median, paramedian, and the lateral supracerebellar infratentorial approach. This is the lateral supracerebellar infratentorial approach. We see that is a transverse sinuses here. The sigmoid sinus, this is the junction. This is the cerebellum. When we go all the way between the surface between this the cerebellum and the tentorium, we can reach the ventral lateral part of the midbrain. Here's the tentorium again. This is the pineal gland, back, front. The vein of lateral mesencephalic sulcus is here, and this is lateral mesencephalic sulcus, and here's the vein. So for dorsal midbrain, what we see here, we see the superior and inferior colliculi. This is after dressing the arteries and the veins. We are below the tentorium. This is the tentorial tent. And what we see here, pineal gland, superior and inferior colliculi, And we even like, can reach the third ventricle through the suprapineal recess here. How can we reach here? So either we can come from above, which is interhemispheric occipital approach, or we can come from supracerebellar infertentorial approach, above the tentorium or below the tentorium. And again, here is the colliculi here, dorsal surface of the midbrain. Of course, we can also reach the pineal region tumors through these two trajectories. Looking from behind, occipital and cerebellum, we see the sagittal sinus, superior sagittal sinus, transverse sinuses here. We can either go from here, inner hemispheric occipital. Here's the final exposure. We see the splenium here. Vein of Galen is here, and we see the vein of basal vein of Rosenthal. Sometimes when we retract the occipital lobe, it starts bleeding somewhere. It's usually cause of the internal occipital vein stretch when we just retract the occipital lobe. It's always good to check that this internal occipital vein is here. We can open the tentorium about like 1 centimeter midline off to get greater exposure. And here we see the surface of the cerebellum, tentorial surface. We see the pineal gland is here, and here is the more exposure after cutting to the tentorium, just next to the straight sinus, which is located in the midline. What else we see here? We see the internal cerebral veins. And here we see the basal vein of the Rosenthal, and this is the internal occipital vein is here. The second option is supracerebellar infertentorial. Again, there's a three, the variants of supracerebellar infertentorial: median, paramedian, or lateral. This is paramedian because the midpoint, the distance from inion to the asterion is here. So once you come paramedian, you just go to lateral to the vermis, because when you go from midline here, the vermis is going to be here on your way. It's difficult to deal with, but of course depends on the lesions. But when you come from paramedian, you just to put the vermis out of your way. And here is superior nuchal line, and transverse sinus is located here. This is the final the exposure, and superior inferior colliculi, the pineal gland is here, and we see the vein of Galen, the vein complex is here. The pons is the bulging part of the brain stem. Again, so the medial lemniscus, it's a good landmark for making the decision making for which part of the which trajectory we are going to use it to reach the especially intrinsic tumors. If the lesion located in front of the medial lemniscus, in other words, in the ventral the pons, we can use lateral approaches. If lesions located behind the medial lemniscus, which is the dorsal pons, we can use midline suboccipital approaches. For the ventral pons, here's the target area, the lateral surface of the pons here, and of course the retrosigmoid approach we can use. There are different kind of skin incisions, of course. We can use a horseshoe incision, linear incision here, or hockey stick incision can be used also for the retrosigmoid approach. It's dealer's choice. The one burr hole can be placed like 5 millimeter or 1 centimeter below a medial to the asterion. Here's the transverse and the sigmoid sinus. We don't need to expose all the sinuses, only H is enough. Some surgeons, like to expose, open the drill the bone overlying the sinus for getting greater exposure, the increase the exposure all the way down. But we see the cerebellum here, and this is the lateral part. See the trigeminal nerve, 7 and 8 complex here. And this is also the lower cranial nerves, 9, 10, that can be reached with the retrosigmoid approach. So another, the tidbits, I would say, this is the petrosal fissure of the cerebellum that can be open to get better exposure, and also it's also less retraction of the cerebellum. Here we see the ventral part of the pons, 5 and 7 and 8 complexes here. This provides, the less cerebellar retraction and also more exposure of the middle cerebellar peduncle for the lesions located, the central located ventral pontine area. Of course, in case of the tumor, let's say the CPA, schwannoma or meningioma, that the tumors creates own natural corridor here, and you don't need to, depends on the case, but you don't need to open the petrosal fissure here. So because all the structure is going to be here distorted, and the natural corridor is going to be made by tumor. But for lesions located, intrinsic located lesions, so it would be, the helpful for more exposure and the less retraction of the cerebellum. As we see here, once we open the petrosal fissures here, we can reach ventral pontine area. This is the trigeminal nerve. Usually originates the point of the pons. In other words, just the cuts the pons in the upper and the lower parts. So the surgical approach, another option is come from about a tentorium through the middle fossa. This is a middle fossa craniotomy. Usually put the 2/3 in front of the ear, external acoustic meatus, and the 1/3 behind the external acoustic meatus. What else we see here? This is the landmarks, arcuate eminence, and this is the greater petrosal nerve. And here's the petrosal apex. This is Kawase approach. After opening the tentorium and drilling to the petrosal apex, we can reach the trigeminal nerve, trochlear nerve here, and this is the ventral part of the pons that I will show. Especially here, we see the greater petrosal nerve is the posterior border for the Kawase approach, and here we drilled apex of the petros bone, and we see the trigeminal nerve, facial nerve, that we can expose all the structures. For the dorsal pons, especially this is the 4th ventricle. How can we reach here? We can do suboccipital midline approaches, either the televelar or transvermine approach. I believe televelar approach is more commonly used than transvermine approach, because when we cut the transvermine approach, we are coming to midline and cut the vermis here to reach to the 4th ventricle. That can cause some, like the post-op complication, like akinetic mutism, and also other cerebellar the problems. Once we use a televelar approach, which is natural, the corridor, there is only membrane. We are coming between the uvula and the tonsils. That also we can reach to the 4th ventricle here. And here we see the foramen Olushka. This is the choroid plexus. Once we done the suboccipital midline approach, here is shows the televelar approach. This is inferior medullary velum, and here's the telechoroidea, is a junction. That's why it's called a televelar approach. When we cut this membrane between the uvula and the tonsil, we can reach the 4th ventricle. This is kind of final, the exposure of the fourth ventricle. For medulla, the lower part of the midbrain, and continue with the spine cord, cervical cord, spinal cord. Our goal to reach is here, and we can reach that. We can use the bilateral approach. A little bit down. Again, just dealer's choice. We can use a linear incision, hockey stick incision, lazy S incision. But finally, here we see we are on the left side, and we see the C1 is here. This is the vertebral artery, which is surrounded by the venous plexus here, which is also called as the cavernous sinus, the cervical cavernous sinus here, spinal cavernous sinus. This is the venous complex around the vertebral artery. This foramen magnum is here. After craniotomy, we can also remove the posterior arch of the C1 for better exposure. And here's basically the final. This is bilateral with retrosigmoid approach, but usually what we see after bilateral approach is this part. And this is the condyle here. We want to be careful about accessory nerve when we drill the condyle. Usually, the most commonly just the posterior 1/3. Drilling of the posterior 1/3 of the condyle is enough for exposure, and it's always nice to bear in mind the close proximity with the accessory nerve, with the occipital condyle here. And of course, for the dorsal located the medullary lesions, we can use the same approach, suboccipital midline approach, to reach the dorsal surface of the medulla here. There's a natural sulci that can be used to reach the intrinsic pathology in the medulla. Thank you. This is all what I would like to mention about the Scalab's approach to the brainstem, and also more detailed information can be found in this atlas. Thank you so much.
Thanks a lot, Professor Khan, for this excellent presentation. Is there any question from panelists? Oh, come on.
Dr. Woodley? Dr. Woodley?
Yes, hi there. Yes, excellent dissection you did, and a brief overview of all of this. Now, one of the more fashionable things has become to go along the cavernous sinus and then go into the posterior fossa. And I was just wondering, this approach to the, following the third nerve through the subfrontal area, that is really what we call steep mountain climbing in Switzerland anyway. And but how about this, kind of basically perional approach, and then you go into along the cavernous sinus, and you drill the posterior clinoid, and you enter the interpeduncular fossa as well. Is that something that you also describe?
Yeah, I totally agree with you. This is another option. So those kind of, the surgical approaches, dealer's choice. So the surgeon, whatever they, they feel more comfortable, they usually use the same kind of surgical trajectory. But of course, the terional approach can give the same, the exposure. Some surgeons, prefer to do like transcavernous approach, even go to the PICA aneurysm, or just the ventral interappendicular fossa. Again, this is, I cannot say, the one is, the better than other. It depends on dealer's choice. But I totally agree with you. The terional approach also could give the similar exposure of the interappendicular fossa.
Right, and then one more thing about this idea of, like, we're also talking to a lot of surgeons here who may, or I mean, I was a skull base fellow at one stage in my time in Toronto, but this one basic thing which you didn't really mention is like this division of the orbitomeatal band, or the proper dura, which is very, very useful for so many operations around the anterior clinoid.
Yeah.
And what is the role of removing the anterior clinoid in your armamentarium of approaches, actually?
For anterior clinoidectomy is talking about the techniques is meningoorbital band, is a good landmark for anterior clinoid to start, because the sphenoid ridge, I can show actually if you have time. The sphenoid ridge comes down and becomes the anterior clinoid after passing the meningoorbital band.
Right.
The meningoorbital band also corresponds to the superolateral edge of the supraorbital fissure. Sometimes we can pass, we can just cut it, when we just but the peel in the dura, we can cut it. But the anterior clinoid, if we compare with the sphenoid ridge with the anterior clinoid, sphenoid ridge is very sharp, and it suddenly becomes like very flat. So that also I would say another thing that we know that we are on the anterior clinoid before we remove the anterior clinoid. The anterior clinoid removal is also gives access for more ICA proximal control, and for opening the cavernous sinus, of course, from the Hakuba approach, or just from if we are going to open with the Dolenk approach through the intradural part is key, I would say, for the cavernous sinus.
Okay, and one last thing, can you explain to everybody, the 120-degree rule when you do a Kawase drilling? Where to start and where should the borders be, and what to watch out for?
Yeah, in the United States, we usually the hospital usually use the navigation stealth and to see.
I see.
Yeah, the thing is, people usually put more exposure, but actually it's always nice to I would say always nice to put this Petrous ridge, bring the Petrous ridge like the straight like this. I need to show, actually it would be better to show if I can share my PowerPoint again here. We see the Petrous ridge almost like 45-degree. When we turn this, here, we just coming through that part. It's always nice to be like this straight shot with straightforward, like straight angle here to reach to that part. What do you think? What's your opinion about it, Dr. Woodley?
No, that's okay. No, I was just thinking of, you have the middle meningeal artery, you have the superior petrosal nerve, and then you can find the meatus midway. You guys, you see a lot of us who are not working in all these very well equipped North American clinics, we might not have such good navigation or no navigation at all. So we have to rely on clinical anatomy, and that's why I wanted you to talk about this.
Yeah, absolutely. Before we start, the drilling Petrous apex, usually most surgeons usually prefer to open the interacoustic canal here.
Yes.
So to make it safe and secure, and then actually even opening the interacoustic canal, usually start drilling with the medially, because there's nothing here, especially.
Yes.
Trigeminal nerve is going to be here, just the lateral to trigeminal nerve. We can start drilling coming from medial to lateral. Now find the interacoustic canal is here. Just unroof it and then come back again, because this is the border for the Kawase approach together with the greater petrosal nerve. There's some surgeons want to preserve the greater petrosal nerve, but some surgeons prefer to just cut it at the beginning before start the peeling the dura, because sometimes when we stretch the nerve, it can just the tear ripped from the geno of the facial nerve that can cause some facial drop here. This is another, like the two other possibilities. Some surgeons, prefer to save it. Some surgeons just cut it out at the beginning, I would say.
All right. Well, thank you very much for this excellent overview. And I hope people understand all of this. And anatomy is where it's at. And maybe navigation is just to make sure, or if you have it. Okay. Thank you.
Thank you. My pleasure. Thanks for inviting me.
Thank you, Ken, for this excellent presentation. Thanks a lot for this great discussion. And now we will shift to the next speaker, Professor Jahwar. Please start sharing your screen. Thank you.
I think everyone can hear me.
Yes.
Yes. So thanks on the beginning for giving me this opportunity to present this talk. So I will be basically, we have seen some beautiful anatomy in previous lectures. So now we are shifting to something endoscopic, transnasal, of course, and how to avoid complication. Most of this dissection was done in UPMC, some was done in King's Memorial in Bombay with Professor Goel. So if you see what is a surgical complication, it refers to some unexpected happening and unfavorable event in situation that occurs during or after a surgery procedure. Of course, surgical complication can be caused by various factors related to patient, technique, equipment, skill of the surgeon, and overall surgical environment. So the best way to go is to avoid the complication. So once you have the complication, then of course you have a lot of problem. So this pituitary surgery, now you see a lot of people, it has become a very common to do endoscopic pituitary surgeries. Everybody is doing, even young neurosurgeon, they are learning the skill of operating through a nose with the endoscope. Of course, it is new to neurosurgeons, but of course it is quite common for our ENT colleagues. But with time you learn this is a pure anatomical operation. If you see a lot of surgery, there are some, you need special skills. Here you need a very good knowledge of your anatomy. If you know the anatomy, if you know where you will get what structure, how to avoid those structures, how to avoid some structures, and how to follow the basic steps, just basic steps. This is a very straightforward surgery. If you see, this is the cut section of the human brain. This is the sella here. Of course, this is the anatomy of the nose, which we will be discussing, and the approach is directed in the midline to the sella and the tumor around the pituitary glands. So of course, this is a close-up of the, here you can see pituitary stalk, optic chiasma is, you can see. And this is just the upper brain stem here. This is coming to the, just the bony anatomy. This is the endocranial view of the sella. This, as you can see, anterior clinoids, and you can see tuberculum here. And here is the sella and the dorsum sella. So, but here, this is the more appropriate view for endoscopic point of view. The important point here is the large, this spongy bone over here, which is in front of your sphenoid sinus. This is mostly the ethmoid bone, which we as a neurosurgeon are not oriented sometimes. So once you remove ethmoid, you can see how this is related to anterior part of the sphenoid sinus here. So this is just a oblique view. This is this, you can see how this is a large spongy bone here. This is a ethmoids, and this ethmoid sometimes you have to remove for the extended approaches. And once this is again same view. So this is the sphenoid sinus, and this is the final, you know, how the main artery which we have is in this endoscopic approaches is the internal carotid artery. So here it has been dissected from endoscope point of view, how it is oriented to the skull base, right from foramen magnum here. This is of course cervical part, then the petrous part, then we have a clival part, then we have a sellar, and then the clinoid, and after that we have the intracranial. And in between, this is the main area of interest in this study. So once you remove, you can remove the dura, and you can see some part of the brainstem also through these approaches. So this is a supratentorial view. And of course, this is a frontal view here, how this olfactory nerves are oriented, how you can see the pituitary stalk here. This is the optic chiasma here. So coming to the this, of course, the all these cranial nerves which are going through the cavernous sinus to the eyeball. You can see how eyeball is very critical. Vision is also concerned with this nerve, and vision is mostly affected in pituitary tumors. Just to give an overview of microscopic anatomy of the cavernous sinus from superior aspect, you can see this is the bony hair. This is here you can see the ophthalmic artery. So this is just the superior view, pituitary gland, ophthalmic artery, the ICA. So I'll just skip this from there. So coming to this picture. So this is all of the cavernous sinus anatomy. You can see ICA giving the meningohypophyseal trunk. So inferior hypophyseal artery going to the posterior part of the pituitary gland. Of course, this is dorsal clival artery supplying the dorsal clival dura. And we have some tentorial artery of Bernasconi, which is supplying the cranial nerves and some part of the tentorium here. And this is inferior lateral trunk on the this side, which is supplying the lateral wall of the cavernous sinus. And you can see this is Gruber's ligament and the sixth nerve going like this. And here is the Dorello's canal. So this is the final picture which you see from the endoscope. This is the pituitary gland with the stalk. And very important, this is the superior hypophyseal arteries, which divides into this three branches and supply part of the stalk and with the hypothalamus. Very critical artery here. So just quickly, I will show you some steps, pictures of this basic dissection. Then we'll see you in the case on the case basis. This is the anterior keel of Vomer and the anterior wall of the sphenoid. Once you remove this bone, you will see a beautiful picture of this sphenoid sinus. Here is the main. This is the main working area where you will be working to deal with these tumors. This septa can be variable, but in this part, very rare to have a central septa like this. And the landmarks is the opticocarotid recess. You can see how the bone is thinned out, and sometimes it is dehiscent also in this here in the ICA here. This is the sella here. So another part of very critical part is the repair, which is the CSF leak and Haddard flap. These are the branches of Haddard's flap, and Haddard flap, nasoseptal flaps. They have basically revolutionized the endoscopic approaches. Before that, of course, the leak and these infections, especially in underdeveloped countries, is a major issue. But with this Haddard flap, vascularized flaps, you can see how nasoseptal, this sphenopalatine artery, then it divides into multiple branches which supply part of this flap, and that forms a robust, this is a very strong barrier which is totally changed. You can see how the flap, it can sit all the way from the clivus, and you can even extend to the anterior cranial fossa and of course the sella area, and it can epithelize in a very short time. Within 24-48 hours you can start epithelizing, and after that there is very less chance of leak of any kind. So this is just the basic anatomy which you once you enter this clinoid. So we can have different type of septa. This is of course lateral. This is a where is my marker? Okay. So this can have a variable kind of picture here. You can have all kind of septa. It can be on the one side. So idea is to study this anatomy in your preoperative scan also. So where are these septas? Or they are oriented to your skull base, how they are oriented to the ICA, how they are oriented to the optic nerve. So intraoperatively, it would be very easy for you to find those landmarks. So if you see here I am seeing, so once you remove the bone, then you can see all the dura with this, all the venous injection. So there can be variable configuration of the ICA, of the cellar ICA related to your pituitary gland. There can be a very wide area. Sometimes this is a very narrow area. Of course, the tumor can also have some displacement to various types. So here it is with the bone. Once you remove the bone, you can see beautifully how this dura is there. And there is a large venous lakes are there, some anterior intercavernous sinus. So this medial compartment is quite wide here. So just to sometime you can see even this opening the dura is also a challenging. Of course, this, if you know how this is oriented, now you carefully see sometimes this sharp instrument, you have to be very careful. They can, of course, this is here, this is not the right technique. They can jump and you can have injury of the ICA here. You can see again, this is a very dangerous kind of movement. And just to give you idea how this dura opening is also a very critical part of this operation. And if you see, so once you remove the bone, then you open the dura. This is the optic chiasma here. This is the sella and the ICA. Coming to, of course, this is the, once we remove, you can see how great big access. And this short video, I'll just summarize the whole steps. Of course, this middle turbinate can be removed, and just remove it and put it down, or you can take it out. And then depending upon the nature of the lesion, whether you need a flap or not, you can just do a, you can see the sphenoid sinus now, and just be careful about the pedicle of the flap. Just take a small incision and do a rescue flap like this. So in case you need a flap, you have the pedicle secured. Once you just push it down, you have now your keel of Vomer. You just remove the mucosa from opposite side. Then you can remove this bone and you have a good access to your. So just anatomy, you are just following your anatomy. You are just doing some basic steps. And basic steps will give you, if you skip one step, then you will be in trouble. You may get lost. You may start having some unnecessary bleeding. Just follow the basic steps. Remember the scans, study the septa, study the preoperative scans. You remove this bone, you see the dura. Of course, dura, once you remove, you get this beautiful soft tumor depending upon the consistency. And then you can move ahead with the next slide. And sometimes, in the beginning, of course, it is you have to be a little patient. Once you start doing this surgeries initially, there may not be any landmarks, but if you keep on removing this bone and just following the steps, slowly you will see you will start seeing the anatomy, and end result will be very nice. So exposure is the key. Always remove this. And you can see some decent bone over here. Very careful about the drilling in this part. Very thin bone over the ICAs. And always remove this base of the basal bone here. Otherwise, it can push your instruments and not give you proper orientation, because you are working in a very narrow corridor with long instruments. So you have to remember it's not like a microscope where you are close to your lesion. Here you are far away from your lesion and you have long instrument, narrow corridors. So it may be minimally invasive, but from the inside, you need a lot of exposure. So here you can see here, median nerve on the both sides. Once you see here the clival branch of the meningohypophyseal, which I showed earlier, and in some clival lesion, this can enlarge and you can have a torrential bleeding. But if you know how this anatomy is there, how these are oriented, of course, you will be more careful here how to deal with this branch. And you can see this branch also giving supply to 6 nerve. Sometimes we can have 6 nerve palsy. Why this palsy is there? We are confused. We have not done anything. So sometimes there can be vascular injury to these nerves because of these branches. So of course, then there are McConnell's capsular arteries. And one of my colleague, he had a lot of torrential bleeding. He was not sure. He left the tumor. Of course, these branches can be there or mostly on the anterior surface of the sella here, and they can be coagulated without any effect. And then the inferior hypophyseal artery is also a very important artery, if you see here. And this is the inferior hypophyseal. They can also be coagulated on one side without any long-term effect. Of course, then it gives you access to the posterior part of the posterior clinoids and dorsum sella, and transposition of pituitary. All these are again anatomical operations. If your anatomy is clear, now you see some part of the lateral wall, you Here is the opticocarotid recess here, which is which is the ventral representation of the optic strut, and this is the clinoid segment between these two. And this is the suprasellar. Now you can see stalk. Of course, this is the diaphragmatic cellar opening, and I'm going a little fast because the time of this. And this is how that artery. You can see how this is the superior hypophyseal artery. And this kind of tumor, which are multi-compartment going up like this, then there is a bone which is not allowing this type of tumors to fall. Here you need a much wider extended approach. And of course, for extended approach, you have to remove the plenum, and you have to remove the tuberculum, so that this anterior fossa and the part of middle fossa, they become one. So once you remove, then you have to deal with the anterior intercavernous sinus, which is again not so difficult part, but you should know how this is the, here you can see anterior intercavernous sinus. Now you are seeing that in the live video here. So once you remove that bone, there can be some bleeding, which can be easily controlled by any sort of gel form or flow seal kind of things. And once you see this, and then of course you can just coagulate it. It's easy to coagulate and cut it. And so once you cut it, now this all become a very wide cavity to work. So you have access to the front of the tumor, the inferior part of the tumor. Then of course, once you remove, then you can say, so once you remove, you can see again the same picture which I showed you. There's a stalk here, and you can see superior hypophyseal arteries arising from the supraclinoid ICA here, pituitary stalk. This is the other side. And with the angle scope, even you can see some part of the ICA bifurcation. And of course, this is after you remove the tumor has given you this luxury of seeing all this anatomy, which generally it's easier to see in cadaver. And you can see here recurrent arteries and all anterior communicating optic chiasma. So beautiful anatomy. Sometime even you can see in your patients, but you should also understand that where is this anatomy, where to look for that anatomy. Coming to the lateral and paracellular extension, of course, this compartment can be narrow here. So sometimes it can be very narrow. You can see here the lateral cavernous wall. Once you medialize it, you can see here the sixth nerve going very oblique course, which is intracavernous. There's a third nerve here. This is the V1 here. Of course, the V2 is here. We'll see in the, now you can see have a better, this is a sixth nerve, and it has communication with this sympathetic plexus here. This is the third nerve entering the roof of the cavernous sinus going into the lateral wall. And this is another view of the third nerve. And sometimes this pituitary tumor, they can extend into this oculomotor part of this triangle here from the cavernous, from the endoscopic point of view. This is the third nerve here. So this is the sixth nerve. This is the Gruber's ligament. So this is all, this is just to give you anatomy. So this is inferior hypophyseal part of the posterior dura has been removed. This is the third nerve entering Lilliquist membrane here. So of course, this is the most important, of course, now gland preservation with sometime young patient, small tumor. Of course, you should know how to preserve the gland and the hormonal function, which is very important. And if you can know the anatomy, and with the endoscope, it is with the better visualization, it is sometime possible. Just a small example, if I can show here. Here you can see that gland was displaced anteriorly. Tumor was little posterior here. Here is the gland. This is tumor. Young doctor here from a dentist here. So just see. So remove. So I am just opening here normal pituitary. So you can see normal pituitary here. Once you just remove, very soft tumor, can be easily removed, and no pituitary dysfunction, and no need to be very aggressive. Sometimes if tumor, most of these tumors, they are very soft, can be easily removed. And with endoscope, you can go close and see and do a beautiful dissection. So of course, now this is again posterior, this dissection not relevant to this. And the most dreaded in kind of complication are vascular injury, and we have to be very careful. Sometimes this again third ventricle. So these are a paracellular extension. Here you need to be, these are very recurrent kind of tumor, and they can be densely stuck to the internal carotid artery. And the main part of our complication here is to how to avoid any vascular complication. Other complications are not that threatening, but vascular can be sometime. Of course, they depend on the consistency of the tumor. These are very fibrous tumor, densely stuck to adventitia. You can try removing, but have to be very careful. And but try to preserve the vessel. So densely stuck here, you can see this is a very, it's not easy to do dissection with long instruments. Here you can see, again, as Professor Lewis showed, that for endoscopic, there is a lot of pulling. We can say that we are doing micro dissection, but of course, you have to pull sometime. And of course, now we also have some recent publications on the ligaments of the pituitary gland, which are, you can see how these ligaments, they are, here you can see a ligament which is extending from medial cavernous wall to the pituitary gland, and sometimes they can also, you can see them intraoperatively also. So coming to now the vascular part of this injuries. So of course, you can see here the ICA is oriented here. This is the orbital muscles here. So even this is the posterior fossa. So and sometimes this tumor, they can involve this clivus area. Here you can see all the clivus, and of course then you can see the basilar bifurcation and the PCA here. And here you have to be careful while removing this part of the tumor, and you can directly enter the brainstem. So very careful here. So of course this endoscopic gives you a beautiful view of this area also. This is the area of the brainstem here. You can see fifth nerve, sixth, seventh here. These are 12th nerve here and lower cranials here. So coming back to the vascular part of the hair, you can see now, these are some of the recurrent cases where you can see this is the ICA here, pulsations are clearly visible. So this fascia, which was densely stuck, so no landmarks are visible in reoperation cases. So here you need to be little patient and slowly remove this fascia. And once you start seeing, slowly you will see some landmarks here. You can see, of course, neuronavigation can be a useful tool here. But as sir told, many places still they don't have that kind of facilities. So this is again just a short video to show. Sometimes this is what type of bleedings can be there. This is just a routine cavernous sinus bleeding. So this can be easily controlled with any kind of gel form or hemostatic agents. Here you can see ICA here. And but of course, sometimes it can be scary in the beginning, but of course this can be controlled without any special instruments, and it doesn't need any special skill. Just put some gel form or Surgicel and wait for some time. Warm irrigation is really helpful. So coming to the more sinister kind of bleeding, of course, this is a video, little older video. Now you can see how this, we accidentally, I think, ruptured some, we thought it is a ICA, so we tried to control it. It was a profuse bleeding. Of course, don't need to be panic. The first instinct is, of course, to, put some pressure, put some surgery, some cotton or something just to control. And meanwhile, you ask for help, keep your vascular suit ready. Of course, here it was a torrential bleed. And then we put something, we tried use extra suction and just put a gel form. So these are really difficult situations here. Your vision can be compromised. Your everything is in problem. You have a lot of adrenaline rush. So try to be calm and try controlling it. Of course, not easy job sometime if it's a major vessel injury. So just to of course, you cannot practice these kind of things in the lab, but we devised a model where we can artificially created a live cadaver kind of situation. Here, it was attached to a heart pump, and we were infusing the blood-like solution. And we tried creating these type of injuries and see how they can be practiced. This is just an example of a sharp injury, or just to how it can be controlled. Of course, the first thing is to put whether there can be some special clips which can be used in such a drastic emergency kind of situation. But this is, of course, in a cadaver, and I've shown you in some real situation also. Of course, that patient, luckily, she did well. There was no problem. Of course, we will do a later angiograph to see if there is any pseudoaneurysm. So just put some Surgicel, try to control, may not be controlled by this. Let's try some clipping also. There can be special clips which can be designed with this model. Of course, this is a cadaver model which is very useful if can be practiced to, see. Still, you can see the clip is not working. Maybe reapply another one and just see if we can control this. So mostly sharp instrument, they can do this injury. And another point of injury is sometime if you are drilling or some blunt kind of instrument, your drill can slip and can cause injury. So here we were able to control. Of course, then we tried some other techniques. You can put some patch and try to, reform this after doing some temporary clipping, put some clips to reform the vessel to try for vessel preservation. Of course, it will be not an easy job, but of course, if these things are also possible, may not work. So this is just example of blunt injury can happen. And blunt injuries, I will say, are more, of course, both are dangerous, but this is again, here you may not be able to apply clip also. So here, only option is to sacrifice the vessel with pressure. Then, of course, so in short, this idea of all this is to give the orientation of how this anatomy is helpful, how simple anatomy knowledge and more knowledge you have can help you in, avoiding these complications. So, of course, with this, I stop sharing. Thank you.
Thanks a lot, Professor Jawa, for this excellent presentation and for these nice cases. Is there any question from panelists?
Well, I would like you to comment on these septa. It's commonly known that you have to remove them, but they tend to lead you towards the carotid artery because they're not really midline and they're often running obliquely across. So would you please comment on that point?
Yes, that's a good point for, of course, for the beginners. You have to study septa. Always do a CT scan to see whether we are attached. And if they are going towards some internal artery, then you have to be careful when you are close, and drilling is a better option than remove all of them. Of course, then depends where is the tumor, how much exposure you need. But they are a very useful landmark, I will say, during surgery also.
Well, thank you for this excellent presentation. Very, very nice.
Thank you.
Okay, is there any question? Thank you, Dr. Jawa, for this excellent presentation. And now we will shift to next speaker, Professor Leo. Leo, please start sharing your screen. Thank you.
Okay, can you see my screen?
Yes.
Okay, terrific. Thank you, Sameh, for this kind invitation. Always a pleasure to speak in your forums. Today, I'm going to talk about the Kawasi's approach, and I think it's a very important approach. I think sometimes it's not well understood, but I think when you understand it and you master this approach, it becomes a very powerful tool in your armamentarium when treating various skull-based lesions. So this approach was popularized and described by Professor Kawase, and I had the pleasure of meeting him back in 2016 at a course in Taiwan. And he really popularized this initially for the treatment of basilar trunk aneurysms. And since then, it's been applied to a variety of other neoplastic lesions in the CP angle. And when we think about the CP angle, we tend to think of the retrosigmoid approach as the workhorse. And it's a very versatile approach. This is the view that you often get. But sometimes when the lesion is anterior to the cranial nerves, I think that's when the Kawase approach can be very useful. And this is the view that you get from the Kawasi's approach. And it's essentially a middle fossa approach going through the tentorium that gets you to the posterior fossa. And the view that you typically get is the zone between the 5th and the 7th nerves. And you can also get to the basilar trunk here as well. And so when we're dealing with a variety of different petroclival, petrous apex, CP angle lesions, we have a different variety of different roads that can help get us there. And when we're dealing with these, I think it's very important to understand the temporal bone and be like an archaeologist. When we think of these transpetrous approaches, we can divide the clivus into fourths. For the upper fourth, we generally use an FTOZ subtemporal approach. And to get to between the 5th and 7th nerves, the Kawasi's approach is very useful. And as we get lower down to the clivus, if they go beyond 7 and 8, I like to add a posterior petrosal variant to it. And I'll show you this in a few case examples. And the lower fourth is really the foramen magnum meningiomas, the pica aneurysms, and this is best done through a far lateral approach. And of course, the retrosigmoid approach is our workhorse. And in some instances, we come in endoscopic endonasally from the midline as well. But what does the anterior petrosectomy really get you? I think it gives you this short distance to the 5th and 7th nerves and a brainstem. And then you can also have a short distance and open up Meckel's cave as well. And this is the view that you get. Again, this zone between the 5th and the 7th nerves. We generally divide the petrosal approaches into anterior or posterior, anterior being subtemporally from the middle fossa, and posteriorly through the mastoidectomy using the variety of different petrous resections based on the preoperative hearing status. One of the major advantages of the Kawasi's approach is it gets you this look back view on the brainstem. So this is a case where I had a large CP angle epidermoid and it was tucked away in this area and I couldn't really see around the cerebellum. The facial nerve was under a lot of traction. And so a residual lesion was left. But when we came back and it recurred, we came back through the Kawasi's approach. And this is the view that you get, this look back view onto the brainstem. Here you can see the 7th and 8th nerves and a complete removal. And then you can get a great view here of the basilar, the 6th nerve, and then also looking superiorly, you get the 5th nerve into Meckel's cave and the 4th nerve. So again, you get this great look back view and we got a nice complete removal. So step by step wise, let me just take you through on how to do this through a cadaver. We generally use a frontotemporal incision. And as an option, you can do a drop-down zygomatic osteotomy if needed. Now, head positioning is very important. And so I teach the residents that the common mistake is to put the patient in a straight lateral position. And if you do this, understand that the petrous bone is sliding away from the surgeon. So when you're looking down through the microscope, the petrous apex is far away from you and it's anatomically oblique. But if you rotate the head so that the head is about 30 degrees from horizontal, the petrous bone is flatter and parallel to the floor and you're looking straight down and you have a much better ergonomic view of the petrous apex. Again, you could do a drop-down zygomatic osteotomy as an option, and this gets you lower down on the skull base and middle fossa floor, and you'll have less temporal lobe retraction as a result. So we expose the extradural floor of the middle fossa by peeling the dura propria, and we want to look for the middle fossa rhomboid structures. Here you could see it's bordered by GSPN, posteriorly by the arcuate eminence, medially by the petrous ridge, and then posteriorly the back of V3. And so here it is on a cadaver. We generally peel the dura back, and you want to see this rhomboid. And once you identified this rhomboid, you can identify in your mind's eye where the IAC is by dropping down this, bisecting this angle. This is roughly where the IAC is, and anteromedially will be the cochlea. And then laterally here is Glasscock's triangle, and that's where you can find the horizontal petrous ICA. So by doing this in your mind's eye, you can have this X-ray vision of where all the critical neurovascular structures are, and you can avoid injury to these structures. So that as you drill, you can open up the IAC dura. Medially, there's the clivus, and once you've identified the carotid and GSPN, you can understand where the cochlea will be and the arcuate eminence, the superior semicircular canal, and then you can preserve these structures, preserve hearing, avoid vascular injury, and then work through this anterior petrosal corridor. So how can we maximize this corridor? It appears to be as kind of a small working corridor. Well, we can mobilize V3 anteriorly. You can see that the true petrous apex is more anterior. This ridge here is the landmark called the tubercle of Princeton, and it demarks the true anterior petrous apex from what you normally see if you don't mobilize the Gasserian ganglion. And so again, here you can see a nice view. And then in some cases of chondrosarcomas, I'll often mobilize the petrous carotid, and you can get all the way down to the clivus bone here, down to the skull base. And we published this some years ago with my mentor, Dr. Caldwell, on trying to maximize exposure of this ICA to do these petrous to supraclinoid bypass, the so-called Fukushima bypass for lesions like this. So again, we want to be able to maximize this opening to the brainstem, the petrous apex. You can also see Dorello's canal. Here's the sixth nerve and the basilar artery. Let's look at some case examples. This is a tentorial petroclival meningioma in the upper petroclival region. This is one we did a anterior petrosal approach. First, we divide the middle meningeal artery by coagulating and dividing it sharply ab frame and spinosum. And then we peel the dura propria from posterior to anterior. And this is an easy way to find the GSPN as it goes into the facial hiatus. In some cases, it's enveloped by very thick periosteum. So oftentimes I'll use a sharp dissection to feather out the periosteal fibers and expose V3 at the foramen ovale here, using, again, here's a 15 blade using sharp dissection, really dissecting off those dense adhesions to get the adhesions off, and then peeling off the dura propria off of V3. In some cases, I'll decompress the foramen ovale by drilling off the foramen ovale and really releasing V3 so I can really mobilize it anteriorly to expose the petrous apex. So here's the petrous apex. You can see the middle fossa rhomboid. Here's V3. Dropping down the IAC, you can see the course of the IAC with the cochlea. And then we'll start the drilling from medial to lateral. And I think this is the safest way of doing it. And then I can mobilize the V3 anteriorly to look at the trigeminal depression, and then finish off the drilling, so forth, anteriorly. But once you've identified the dura, it's easy to find where the IAC is of the IAC dura. And then we'll open up the temporal lobe dura and go subtemporally initially. Here's the meningioma on the subtemporal surface. And then we'll go ahead and debulk this and remove it down until we see the tentorial edge. And then once we see the tentorial edge, we want to find where the fourth nerve is entering. And then we'll cut the tentorium. Here's the fourth nerve going into the tentorial edge. And then removing the last portion of the subtemporal component. And then we'll open up the tentorium from medial to lateral, and then lateral to medial as well. This is the superior petrosal sinus, and that marks the lateral edge of the tentorium. So we'll close this off with bipolar cautery. You can also use clips or suture ligature. And then you have to open up the posterior fossa dura as well, which is the bottom of your Kawasi's drilling. And then we'll cut the tentorium until we reach the free edge of the incisura, extend the posterior fossa dural opening, and then open up the arachnoid membrane. So here is the superior petrosal vein. This is Dandy's vein as visualized from a middle fossa perspective. I'll ligate and divide this, but keep the wishbone component of that vein so that you preserve the en passage venous flow. And then we can open up Meckel's cave by following the fifth nerve into Meckel's cave and just opening the dura right over it, opening up that porous trigeminus. And there's Meckel's cave. There's the tumor in Meckel's cave. But notice how the tumor is anterior to the fifth nerve. This is what I want to demonstrate as the major advantage of coming in Kawasi's, is that you can now access the tumor anterior to the fifth nerve without having to mobilize it or manipulate it. And you get this beautiful view of these petroclival tumors working in front of the cranial nerves. And you don't have this advantage when you're doing a simple retrosigmoid approach, as most people propose. And this is the major advantage, that you get this short access to the tumor, to the brainstem, and getting right into Meckel's cave in such a short distance. And there's the basilar artery, here's the brainstem, and then the fifth nerve, nicely preserved. And so reconstruction is basically a multi-layered repair. You have to make sure you seal off any petrous air cells. We use a little bit of fat graft, but be careful, don't overpack the defect. I think the common mistake is to fill the dead space and you forget that the temporal lobe needs to re-expand. And if you make that mistake, you can have some temporal lobe compression syndromes, and then we'll use a nice pericranial flap from behind. So here's a gross total removal. Here's a dumbbell trigeminal schwannoma going into Meckel's cave. Patient presented with facial numbness. And so we did this through an anterior petrosal approach. You can see here's the drilling of the middle fossa rhomboid going medial to lateral, finding the IAC dura. And then here's the fifth nerve. The drilling has been complete. So we'll open up the dura and the posterior fossa, drain off some CSF, and then cut the tentorium to the free edge. And then we'll open up Meckel's cave by following the fifth nerve going into Meckel's cave. And you can see on this case, there's a large component of the tumor in Meckel's cave. And so now we have a panoramic view of the tumor from front to back. This is the back side of the tumor. We're peeling it away from the arachnoid. We'll go ahead and decompress the tumor with an ultrasonic aspirator. And here's 7 and 8. 7 and 8 is right here. Here's the brainstem. So we can avoid 7 and 8 manipulation, peel the tumor away from the brainstem. And the key here when you're doing trigeminal neuroma surgery is you need to preserve as many fascicles of the fifth nerve as possible to avoid postoperative dysesthesia. And so we'll find the tumor capsule, preserve as many of these fibers. Here's the trunk of the fifth nerve and going right into Meckel's cave. So we have, it's in front of the fifth nerve. So if you did this retrosigmoid, you'd have a difficult time finding this plane. And you could see I followed it into the Meckel's cave. The fifth nerve has been preserved. The motor root has been preserved. And a nice complete removal, neurologically intact. So this was a beautiful approach to this kind of tumor. This is a case I did a few weeks ago. This was actually a chordoma, eccentric to the right side. Notice on the Fiesta, it's medial to the fifth nerve. So based on this idea, I came in Kawasi's approach. And if you were to come in retrosigmoid, the fifth nerve would be in your way. But not only that, the cerebral peduncle of the midbrain would also be in your way. And so this ended up to be a very, very adherent tumor invading the surface of the brainstem. And you could see here we got a near complete removal as this was invading the brainstem. This was an interesting case in a young woman. She had a history of a thoracic spinal clear cell meningioma almost 15 years ago. And then she presented with this tumor that was rapidly growing. Initially, I thought this was going to be a trigeminal schwannoma, but this ended up to be a clear cell meningioma. And I'll show you here. I'll skip the approach since you've seen this approach many times in the prior videos, but we'll go straight to the tumor removal. So we'll open up the dural subtemporally. And then as we go subtemporally, we want to find the fourth nerve. We'll open up the dura here of the posterior fossa. And then we'll ligate the superior petrosal sinus. And you, as you're cutting the tentorium to the free edge, you want to make sure you find the fourth nerve. Here's the fourth nerve, and you want to make this cut so you stay behind the entrance of the fourth nerve so you don't injure the fourth nerve. And that completes the cut. And then we'll open up Meckel's cave. We'll open up the fibrous ring of the pores trigeminus. And now we have a panoramic view of the tumor from front to back. And so I initially thought this was going to be a trigeminal schwannoma. So I find the membrane on the nerve rootlets and I peel the membrane off of the tumor. I call this undressing the tumor. And once you do that, you can debulk the tumor and hollow it out like a canoe. And now it's collapsed. Now it's easy to mobilize the tumor, to come around it circumferentially. I'm preserving as many of these little fibers, these trigeminal nerve fibers as possible. I'm using micro scissors to sort of sweep it around the tumor capsule, preserving these fibers, preserving the trigeminal nerve, and then debulking the tumor sharply in a piecemeal fashion. And then you can see we're saving all of these nerve fibers using careful microdissection techniques, and then finally removing the last component. And look at the trigeminal nerve. It's completely splayed by the tumor. And here's the postoperative CT scan. You could see the area of the petrosectomy, and here a complete removal. And based on this being clear cell, I went ahead and referred her for radiation treatment. Here's an example of a anterior petrosal meningioma, this one with IAC extension. But notice how the IAC extension is on the anterior lip of the IAC rather than posterior. And based on this, I decided to come in from an anterior petrosal approach. You could see the anterior petrosectomy that gets you to that area. And here you could see the tumor being removed. It rolled out quite easily like a convexity meningioma. And then here's the fifth nerve, the basilar artery, and the neurovasculature, and the fourth nerve. And so here's the post-op scan, a complete removal. here's another example of an angiopetrosal meningioma. I think most people would say a simple retrosigmoid approach would be appropriate here, but I like to pay attention to the slope of the petrous bone. So if you look at the slope of the petrous bone, the angle of attack is slightly out of angle if you came in along the slope of the petrous bone. And to really excise this dura, it's a little bit out of your view. And so this would result in maybe excessive retraction of the cerebellum. And so I came in Kawasi's approach, and it was quite easy to remove a gross total with hearing and facial preservation. But you can also use this approach for some vascular lesions. This was an unusual case of a mycotic aneurysm of distal SCA. You could see that this has already caused a stroke in the superior cerebellar region. Certainly this could be potentially coiled off or maybe clipped, but you have to recognize this. So when you see this type of aneurysm, this is not a saccular aneurysm, but this is a pseudo aneurysm, mycotic nature. And I chose a Kawasi's approach based on having proximal and distal control of the SCA, where the vessel is going to be laid out in its longitudinal axis. If you did this retrosigmoid, the proximal SCA is behind the aneurysm, and if it ruptures intraoperatively, you'd have a difficult time controlling it. And I'll show you why. So this is the Kawasi's drilling, and then we open the dura, and you can see we'll open up the tentorium here, and then I'm opening up the arachnoid now, and you can see there's a fibrin clot here, a big mess, and I'm just staring at it, and I can see already something bad is about to happen. And you could see this is a typical pseudoaneurysm. There's no wall of the aneurysm. This is just a big smoking hole in the artery, and you can easily get into trouble here. But I already have in my mind's eye where this artery is going to be laid out. It's going to be in its longitudinal course. And so I'm just going to apply a clip to try to get control. And luckily, I was able to find the proximal SCA, stop the bleeding. And then at this point, you can now start to identify some normal anatomy. I find the proximal SCA and I put a clip on it. And then now I can find the distal SCA. And my hopes was that I can try to repair the vessel or maybe even do an anastomosis. There's the distal SCA. And so you have the course of the SCA in its longitudinal anatomy. But look at this hole here. This looks like a shotgun went off on the artery. And I realized that the wall of this artery is quite diseased. And so I decided not to do any heroic repair. The patient already had a distal SCA stroke, so neurologically she was no different after the surgery, and we were able to occlude the mycotic aneurysm. I want to talk briefly at the tail end of this, the distal, the extensions you can do. You can add a mini posterior petrosal to extend your corridor. Oftentimes the floor of the middle fossa makes your working corridor very narrow. But if you extend it just to do a little mini mastoidectomy, you can widen that working corridor so you're not hitting the bone edge of the floor of the middle fossa. And so this has been nicely described, and I've done this on a variety of approaches. This is a brainstem cavernoma. This was a recurrent cavernoma that other surgeons tried to do endonasally. Of course, it recurred because it was not completely removed, and now he's developing progressive cranial nerve palsies from enlargement of this. And so if you look at this, this is very nice. It comes to the surface right here, but it extends a little bit below 7 and 8. So for this reason, I decided to come in a combined petrosal, and you have to note that there's a large DVA here that you must preserve to avoid a venous infarct. So this is a combined petrosal. This is the GSPN, and we went ahead and drilled the petrous apex, and then we drilled the mastoid, and then you can see here's the otic capsule. There's the otic capsule of the posterior petrosectomy component. And then we went ahead and drilled the Kawasi's component. This is the anterior petrosal. We'll go ahead and open up the dura, find the tentorium and the fourth nerve, cut the posterior fossa dural opening, cut the tentorium to preserve the fourth nerve. And here's the trigeminal nerve. And here's the arachnoid below the trigeminal nerve. And then I tried to open up pre-sigmoid, but there was just too much scar tissue from the other surgeon's prior surgery. So I was able to just continue to work in Kawasi's triangle. There's the cavernoma. And we kind of removed this in a piecemeal fashion. We were able to remove the cavernoma by carefully dissecting it, and it was right on the surface of the brainstem. And then I'll show you at the end here. There's the endoscope view. We'll take a look. There's the DVA that we preserved. So the endoscope is a nice tool to look around corners. And then here is the combined approach. And then here's the post-op resection showing complete removal of the cavernoma. He fortunately regained the majority of his previous deficits, and we preserved the DVA here. This is an AVM rupture deep in the cerebellum. You could see it's feeding off of the distal SCA. And so here is the small AVM. And so instead of doing this retrosigmoid, my idea is that if you put the SCA along its longitudinal axis, you'll get great control of this AVM. I'll skip the approach, but here you can see is the combined petrosal. And then after we open up the dura, you can see you have a wide panoramic view of the cerebellum. So instead of looking into a deep corridor from a retrosigmoid, I have the entire SCA laid out. Here's the hemosiderin stained brain, and there's a lot of arteries fistulizing the draining vein. And you'll see as I'm cauterizing the surface of the AVM, notice how this draining vein will now turn blue. You see how this it's starting to turn blue. And so we've largely devascularized the AVM, and the rest is quite straightforward. We found a nice plane and just staying around it circumferentially. So you have wide access to this quadrangular lobule of the cerebellum, and you don't have to work in such a deep retrosigmoid keyhole, and you have a beautiful control. And especially when you're doing AVM surgery, you really need good vascular control of the feeding arteries and the draining vein. And so here's the final removal. And here's the post-op angiogram. You could see a nice complete removal. And the last two cases, I'm going to show you some challenging lesions. This was a very cystic schwannoma of the fifth nerve going into Meckel's cave. And we ended up publishing this video in Operative Neurosurgery. You could see this is the combined petrosal, including the Kawasi's with a little retrolab mastoidectomy. And then here's the tumor. You could see the tumor in the pre-sigmoid corridor. There's the trigeminal nerve. And then we'll start to debulk the tumor, and we can start to peel the tumor from the brainstem. And then here's the seventh and eighth nerves on the inferior side. So you can see we're working all above 7 and 8. And we could peel the tumor off of 7 and 8. And the tumor luckily was nice and soft. And then we'll open up the tentorium further and then open it up into Meckel's cave. And then as we look superiorly, this is where the SCA is going to be. And there's the fourth nerve. So we have the superior portion controlled. And again, a recurring theme here is opening up Meckel's cave. You can just follow the fifth nerve, open the dura over Meckel's cave, and get into Meckel's cave. And then continue to peel the tumor off of the brainstem. And then the last structures that are always challenging to see is the basilar artery medially and the sixth nerve medially. Sixth nerve is vulnerable to injury if you don't identify it. So there's the last component. And so here's the the basilar artery, there's the sixth nerve, and then there's the trigeminal nerve. And again, the use of the endoscope here, very versatile, allows you to look inside. There's the sixth nerve, confirming the basilar artery is intact. And then here's the seventh and eighth. I left a little tiny residue on the brainstem to avoid injury, but she was neurologically intact after this. And then the last variant I want to show you that I find useful is for a big tumor like this, just taking off the superior and posterior canals is the transcrucial variant. This really gives you a great access with the potential of still preserving some hearing. So a retrosigmoid would be quite treacherous here. Look how the middle cerebellar peduncle wraps around the back of the tumor here. So coming in a combination, this is the approach that I call the CTAP, the combined transcrucial anterior petrosal approach for a large petroclival meningioma like this. And then we'll go straight to the dural opening. You have to preserve vein of Lebet. So vein of Lebet is very important, especially on the left side. So I was able to preserve it and cut the dura around vein of Lebet to preserve its insertion. And then there's 7 and 8. Here's the lower cranial nerves. And again, the tumor here is going to be all above 7 and 8, debulking the tumor. And then there's the basilar artery. And we'll go ahead and open up the dura going into Meckel's cave. Again, this is a technique I routinely do on these approaches. You get great access to Meckel's cave. And then the fourth nerve here is where is one of the challenging parts on petroclival meningiomas. Now we're looking up subtemporally. So by doing the mastoidectomy, I have this looking from down to up view up into the subtemporal area. There's the fourth nerve. And I'm able to bring the tumor down here with micro scissors and then carefully lyse the arachnoid adhesions to the SCA and the fourth nerve. And so here we are bringing this tumor down with the micro scissors. And it's really important to really identify these arachnoid adhesions that's on the surface of the tumor capsule. And if you cut the arachnoid right on the tumor capsule, you can release the arachnoid so it falls towards the side of the cranial nerves. So here's the fourth nerve. You can see it's wrapped around the top side of this tumor. And by cutting that arachnoid, we can eventually release and protect the fourth nerve. There's the sixth nerve. That was the sixth nerve that you saw there. Again, cutting that arachnoid membrane to release it, and then preserving all of these neurovascular structures. And then there's the last component of it. And making sure that the tumor is completely free of any adhesions before delivering it. And here's the endoscopic view. You could see beautiful view of the jugular foramen, and then doing a nice multi-layered watertight closure to prevent any CSF leak. So this was a near radical near total. I left a little droplet of tumor that was adherent to the trigeminal ganglion. And in conclusion, I think the Kawasi's approach is very versatile, and it can be a powerful tool if you understand the anatomy and understand its applications, but it's also a building block so that you can add this on top of other approaches, such as the posterior petrosal, and in some cases, add it with an FTOZ. So thank you again for this opportunity. I'll be happy to answer any questions.
Thanks a lot, Professor Lou, for this excellent presentation. Is there any question from panelists?
Yes, Professor Liu, thank you very much for this very, very nice presentation of this very important approach. Now, what would you say to those who, for trigeminal Meckel's cave tumors, would just skip the drilling and just do the dural peeling and expose Meckel's cave, and then, because these tumors are very soft, and then just tease them into the cavity and remove them that way. Do you think that is a good technique, or what is your approach on that?
Yeah, that's certainly an option. When you're doing through that approach, that's usually more from a frontotemporal approach with frontotemporal craniotomy, where you're peeling front to back, as Hakuba popularized. I think if the tumor offers itself that way, you can certainly do it that way. I think when you have things that extend into the posterior fossa, coming in with the Kawasi's approach, I think you have better control of any of the elements that are in the posterior fossa, such as the fourth nerve and the sixth nerve.
Yes, thank you very much for that. Now, what about doing sort of reduced versions of it? So if you find that you just need to drill a little bit of the bone to get additional access to a nerve that goes in a dumbbell fashion out of Meckel's cave. That have you done that before, or
Yeah, I think in general, I think tailoring your petrosectomy is important. You don't necessarily need to drill what you don't need, but I find that drilling up front is always better than having to clean up at the tail end, because once you've opened the dura, things are more vulnerable. But sometimes when you open the dura, you may have unexpected circumstances. So I think drilling up front has been my preference.
Right. Well, it is for all of us people, but sometimes the more skilled we get, the more we find out that we can actually get away with doing less. But anyhow, I agree with you. Thank you very much for your nice presentation. Thank you.
Thank you.
Thanks a lot, Professor Lo, for excellent presentation and discussion. And now we'll shift to next speaker, Professor William Coddle. Please start sharing your screen. Thank you, Lo.
Great. Can you see that okay? It's really an honor to be here. And I want to thank Dr. Seme so much for organizing this, and John for being such a great facilitator. I'd like to talk a little bit, and this actually will complement Jim's talk really well, because I'll be talking a little bit about different approaches to acoustic tumors with the goal of trying to preserve hearing. And I would just like to say that, I think we're entering a new era. And I think as skull-based surgeons, we've understood the importance of, for instance, maintaining smell as a safety issue, but also localizing sound is important. And we can only do that when we can hear out of both ears, okay? And so I do think that it is important to try to consider hearing preservation as a goal with smaller acoustic tumors. And we'll move this ahead. So these are the classic images of a vestibular schwannoma. Here's a patient on the left side with NF2, obviously bilateral lesions. But they start mostly in relationship to the IAC, as you're all aware, on the Obersteiner-Riedlich zone between peripheral and central myelin on the eighth nerve, usually the vestibular nerve, superior or inferior vestibular. And over time, they obviously reduce the hearing, create tinnitus, and you get this high frequency sensory neuronal hearing loss that then spreads into complete deafness over time as the tumor grows. Now, we've all been using the Koos grading system, and I think it's a good system. It gives us a common language. These grade 1 and 2 tumors are the most common ones that we'll be talking about for trying to preserve hearing. The stage 3 or grade 3 is when the tumor is touching the brainstem, and then there's compression of the brainstem, maybe with hydrocephalus as well in these grade 4 tumors. Here's the imaging characteristics. Oftentimes you'll see a little enhancing lesion in the distal end of the canal, and this is a small acoustic. in a grade 1 tumor. Grade 2, it's in the cistern. Grade 3, it's on the brainstem. And grade 4, there's compression plus or minus hydrocephalus. There's a few instances where the grading system is limited. What do you do with this tumor? How do you grade this? This is actually one of the largest acoustics that I've ever seen. It's 93 millimeters. It defies the grading system. And also, in the case like this, where you've got tumor extension to the region of the geniculate ganglion through the distal end of the canal, so the tumor is growing laterally instead of medially. And this was actually an acoustic tumor. It may be mistaken for a facial nerve neuroma, but you'll only notice that when you get in there and notice which direction the tumor is growing from and where it's attached. This is a pitfall we published some years ago, that you've got to be careful with the prevalent use of fat-sat images. Because if you use primarily fat-sat images, you can miss a lipoma, because a lipoma can be mistaken for a small acoustic tumor on an unenhanced image. So you need to make sure that if it's a fat-sat T1, you need to make sure that this thing takes up contrast, but it may be intrinsically high signal on the non-fat-satted image. So be careful. You can mistake it for a small acoustic, and it could be a lipoma. So this is the technique, and we would do this through a retrosigmoid approach. This is a giant tumor with an elderly woman with hydrocephalus, and we'll use a standard retrosigmoid approach for this. We'd always do these in the lateral position. I know in Europe they like to sit them up, but in America we usually lie them down and do them laterally. And I use the Fukushima lateral position. And we'll go ahead and debulk the tumor. In this case here, we'll open up the ISC and see the internal canal extension of the tumor. So we peel down the dura, overline the IAC, and then go ahead and drill, and then find the distal end of the tumor. You really want to get this tumor out properly. Now I'm going to talk a little bit about how to optimize the drilling for this, but you want to look at the scan and predict how much bone you're going to have to remove to be able to get to the distal end of the tumor. Now, once we find the distal end of the tumor, there's the 7th nerve, and we'll dissect the tumor back off the 7th nerve. And then to approach the mass of tumor in the posterior fossa, this is the way I do it. You'll see I'm using soft cottonoids, and Fukushima and I developed these many years ago. I use them to sweep the arachnoid down from the lateral part of the tumor, okay? And what we're doing then is you're sweeping the arachnoid and all the vasculature off the tumor. And there's the 8th nerve, and there's the 7th nerve. Now I'm identifying with the stimulator, the root entry zone of the 7th nerve, and we'll follow this along carefully. Obviously, hearing preservation is not an issue in this tumor, and we'll dissect it from medial to lateral. And what I'm doing is I'm debulking the center of the tumor and then lifting up the tumor with a micro hook and lifting it off the 7th nerve. And we'll do this, and we'll remove the lateral part, the last part of the tumor, and then sharply dissect the tumor off the residual facial nerve. You can see there, and we'll preserve this, close the dura primarily, and then we'll close with a small burr hole cover or a med-pore cranioplasty in this case. And then the post-op scan, you'll see she's had a complete removal. So I do think that hearing preservation, restoration will become more of a priority, and restoration I'll mention in the last few slides. And I want to point out this type of variant, which is important to recognize. So here's a patient who's a 51-year-old woman. She has a left-sided sensorineural hearing loss. She's got some vestibular symptoms. She can't get an MRI because she's got a cardiac pacemaker, but you'll see she's got a medially located acoustic. And these are important ones to recognize because these people often have good hearing. And you can see her hearing bilaterally. She's got excellent hearing. So what we'll do in this case is we'll do a hearing preservation operation, retrosig, And I'm going to show you the techniques that I use to try and protect the 8th nerve and the 7th nerve when we dissect this. So again, drill up the canal, find the distal end of the tumor. And what I'm using now is I'm using a technique where I'm using a soft cottonoid over the nerve bundle. This is both the 7th and the 8th nerve because we're trying to preserve the 8th nerve function. And we're peeling the tumor off the nerves, both the 7th and the 8th complex. So you need to debulk the tumor adequately with the ultrasonic aspirator, CUSA, Sonopet, and then peel the tumor up. And then as you peel it up, you'll remove the redundant capsule to keep it out of your way. And then keep a direct view of the interface of the capsule with the tumor as you do this. And I'm using counter traction, you see, with the soft cottonoid. So I don't put stretch and I don't let the nerve fold back on itself when I lift up the tumor. We'll stimulate the nerve. Looks good. We'll use AVR and measure hearing, and then we'll remove the last of the tumor in the IAC. If you get into air cells, wax them off. And this is a trick that Al Roten taught me many years ago. A small piece of fat graft, just for insurance. Wax the air cells again on the opening, and then go ahead and close. And we'll just use a burr hole cover, I think, on this case, to close the bony opening. And you'll see on her post-op hearing study that she's maintained her hearing well. So when you think about using a retrosigmoid approach for removing the tumor in the canal, you need to think about the anatomy. And I just want to point out some important anatomy. So here's the horizontal semicircular canal. This is an axial study, right side, horizontal semicircular canal. The posterior canal you're seeing end on here, and you'll see it as a little hole. So these are structures to be avoided if you're going to drill out the posterior lip of the porus. And there's the vestibule. And then this is the bone that you're going to remove. And I'm going to point out, this is the cochlea right here. And so when you're removing the bone, you have to think about your trajectory in this direction where you're making your burr hole for your retrosigmoid approach, and think about how many millimeters of bone you have to remove before you threaten either the vestibule, the posterior semicircular canal, or the horizontal canal. So these are the patients that we want to really use a hearing preservation operation for, these CUS grade 1 and 2s. And we use the AAO HNS head and neck surgery class B or A hearing, which is basically the 50-50 rule, the 50% word recognition score, and then the pure tone audiometry of decibel loss. And so you can think about hearing preservation in two ways. So if the person is losing hearing, you want to try and preserve the hearing. And if you preserve the hearing, you maintain their quality of life, like on the top graph. But if you lose the hearing while you're removing the tumor, you've given them an immediate hit to their quality of life. And so I want to emphasize that. So you want to optimize your results, and you want to pick the patients that you think you're going to be able to do this well on. And that's what I'm going to focus on the rest of the talk. This was a series that we published some years ago. And these are all my patients over the years. And I want to point out this guy is William House, who developed the translabyrinthine approach to acoustics. He was the younger brother of Howard House, who started the House Ear Institute. Brilliant fellow. He died a few years ago in Oregon. And he developed the middle fossa approach to acoustic tumor surgery. And Jim nicely set this up with his anatomy in the previous talk, but so I'm not going to dwell on it. But these are the important structures, because you're coming in with normal anatomy here, and you're going to drill out the canal through the middle fossa. So the important structures are recognizing the GSPN and the arcueminence, which is a rough indicator of where the superior semicircular canal is. And you're going to develop an angle between these two. And it's usually about this angle. And then as you bisect the angle, this is Brackman's line, and this is where you're going to find the IAC. So you're going to start your drilling back here, right on the Petrus ridge, and recognize the IAC. And you can look at the coronal images and see how much bone you have to remove to get down to the IAC, because it's variable in some patients. Remember, the cochlea sits here deep. So we usually leave a cuff about 3 or 4 millimeters in this drilling in this area so we don't violate the cochlea. And then, of course, the carotid artery lies underneath the GSPN and may be dehiscent. So this is the a series of diagrams from our series that's just been published in the Journal of Neurosurgery on this. But basically what you're doing, this is a left-sided tumor. So remember, the facial nerve is more anterior in the canal. And you're looking at the facial nerve, which is lying on top of the tumor in this approach. Most of the time, you're going to mobilize the facial nerve anteriorly, okay? And this will give you your window to remove the tumor in this location. So then we'll go ahead and dissect around the tumor, but it's important, as Jim mentioned, you want to gut the tumor, debulk the center of the tumor, so you have room to manipulate the tumor and get it out without compressing the nerves around it. That's the most key step in this whole thing. So if you look at the bottom panel here, this is what your canal looks like in a figurative fashion. You're going to open up the canal widely so that when you dissect the tumor and the superior vestibular nerve or the inferior vestibular nerve, wherever it's attached, you've got room to pull it out and not have it compressed and compressing the facial nerve or the choroidal or the cochlear nerve when you remove it. So let me show you in a video how this is done. So classic case, I think this is a Kuss grade 1 tumor, 3-year history of hearing loss with increased vertigo. These patients often have some vestibular symptoms. Kuss grade 1, you can see it's almost entirely in the canal, maybe a little bit in the cistern, but he's losing hearing. And I'll talk about that shortly, about the indications for this approach strictly that we use. So I bump the shoulder, put the head fairly lateral here, put the sagittal sinus almost parallel with the floor. Then we'll use a gentle question mark flap. Your bone flap is going to be centered over the root of the zygoma. So we usually use about a 4-centimeter flap centered over the root of the zygoma. Then you're going to come in extradurally, just like Jim showed you in the previous talk. I like to identify the middle meningeal artery and divide it just before it goes through the foramen spinosum. And remember that the GSPN is your guide here. So we're going to be careful. We're going to dissect the GSPN. We're going to identify Brackman's line with that angle I showed you between the arcuate eminence. And then we'll go ahead and drill out the IAC. Here's what it looks like. We're going to be careful here. Remember, the cochlear nerve is going to be lying in this, or the cochlea is going to be lying in this direction. So when you open up the dura, be cognizant of the fact that the facial nerve is going to be right there. Open up the dura widely to the base, and I remove the dura flap just to get it out of my way. And then we find the facial nerve. Here we see right-sided tumor. It's anteriorly, you see. And now we can go ahead and then identify the tumor and gut the tumor, make it into a canoe. And then what we'll do is then it gives us room to manipulate the tumor and lift it out of its investment. Remember, the cochlear nerve is behind you. It's down beneath the facial nerve. You're not going to see the cochlear nerve until the tumor has been removed. Here I've amputated it at the superior vestibular nerve, and then we're just removing any residual tumor on the facial there. So there's the cochlear nerve. And so the operation is fast. It's a fairly simple operation, but I'm going to talk about technical nuances. We want to wax the air cells, be careful of the CSF leaks from the mastoid with the opening. And this is what the post-op scan looks like. So when we published our initial paper several years ago now, probably 8 years ago now, we looked at many patients. I think we had 70 some odd patients, and we had 75% hearing preservation with this series. But you know, as I've gone through this experience, and we have 131 cases now, we got close to 150 cases. It was really frustrating to me because we had these patients with smaller tumors. and I did the best operation I could, but in 20 or 25% of patients, we lost hearing. And so I was really frustrated with it, wondering what was I missing? So if you do preserve the hearing with these small vestibular tumors, it's usually durable. You may lose a little bit over time, but it's the only way to preserve hearing in somebody who's beginning to lose hearing with an acoustic. And I want to just emphasize that to the audience, that if you start to lose hearing with an acoustic tumor, whether you radiate it or whether you watch it, you're going to lose hearing. And I'm going to show you graphs to that effect. So if you think about it, this is the only mechanism that we have to save hearing in these patients. So I had two fabulous fellows a year and a half ago. Budahowski's from Cambridge in England, and Rennert is from California. And I asked them to just boil the ocean with this and say, what are we missing here? Why can't we predict better which patients we're going to lose hearing on? And can we choose them better and more carefully? Because in 20%, we're losing hearing. So this is a paper that's just been recently published. I think it's online. I don't think it's published in the journal yet. But we looked at the anatomy of where the tumors grow in the canal, and also the relationship of the canal anatomy. So if you have here is a right-sided IAC, here's the canal, you can see the nerves in the canal, here's the vestibular apparatus here, and here's the cochlea. Looks like a little acorn, and again, it's anterior. And now this can be variable in where it lies with relationship to the canal. And so in some cases, you'll see the tumor actually involves the modiolus of the cochlea. Here's a left-sided tumor. And this turned out to be a real negative predictor of hearing preservation when the tumor's at the region of the modiolus. If you've got more distance, and this has been published before, if you've got more distance, this fundal cap, it may indicate that it's easier to try and preserve hearing. So there's variability in how the tumors grow. The relationship between the cochlea and the IAC is important to recognize. So we looked at this overlap between the cochlea. So the cochlea in some people is more at the apex of the canal, and in other people, it overlies the lateral aspect of the canal. And so it's important to understand what the cochlear overlap is, because we think this is a limiting factor when you're opening the distal end of the canal and you might be entering the region of the cochlea and then losing the hearing that way. The other thing is that we noticed in some of these patients, there's high DWI signal intrinsically in the IAC. And we think this may represent edema or inflammation in the nerve, and it may make the plane harder to dissect from the eighth nerve. So we looked at all these issues, and I'm going to tell you the important factors that I use when I consider trying to preserve hearing. So the hearing outcomes were 78% in the overall series, and these were my personal series consecutively over about 20 years, and 80% in the most recent patients, in the most recent 50. And this is what I've learned. And remember that this is a small subset of acoustics. I have an acoustic series of over 1,000 patients. So this is just a smaller group of the small tumors that we're trying to preserve the hearing on. So the most important factor is good hearing to start with. So if a patient is losing hearing, you want to offer treatment soon, because the worse the hearing, the less likely you're going to preserve functional hearing. The other thing was we found that patients who got hypotensive during surgery, this was a negative predictor for hearing outcome. And the use of vasopressor, which probably just went along with hypotension. The overlap in the fundus and the cochlea, so that cochlea that's lying along the side of the canal more was a negative predictor for hearing preservation. And the distance between the tumor and the cochlea, as we expected, and the DWI and the cochlea was really a negative predictor. We think it's inflammation. The interesting one was the duration of anesthesia. So the cases that took longer, we were less likely to preserve hearing. And I just think intuitively, this is where I was struggling with trying to dissect the tumor out properly and probably injuring things when I did it. So these are the most important factors, independent patient factors that predicted outcome. The DWI signal in the cochlea, the anatomy of the cochlea and the fundus, and the tumor touching the modiolus. So the most important things. So I just want to then show you my philosophy about when we offer this operation. So now we're looking at those radiographic factors as well that I just showed you. And if the tumor's into the modiolus, I don't offer them surgical resection. I watch them or I offer them radiation if that's what they want. But this paper from Jean Ragy was used as a classic paper demonstrating that maybe radiation was a way of reducing the hearing loss. But if you look over time, if you wait and see, patients will lose hearing over 5 to 10 years in most cases, okay? They lose hearing as the tumor grows slowly. If they're completely incidental and they don't have hearing loss and they don't have vestibular symptoms, we don't offer any treatment. We just watch those patients. Now, the Gamma Knife people have made the case that if you treat it, you can reduce the slope of that curve and you may improve hearing for a longer period. This is a more recent paper published by Doug Konzioka in New York, and he demonstrated these curves overlap in that the wait and see and the radiation of the tumor in the canal, they both had the same hearing loss. And note that they both lose hearing over 10 to 15 years. So if you think about it, we know that wait and see is going to lose hearing. And we also know that radiation is going to lose hearing. So if you operate and can preserve the hearing in a good percentage of patients, it's a reasonable option. And that's my personal philosophy about that. And I know that this is not sort of seen this way in a lot of parts of the world, but I'm trying to introduce the idea of hearing preservation as an outcome for acoustic tumor treatment. So the ideal patient for a middle fossa approach is an intracanalicular tumor or a small amount in the cistern, tumor in the lateral IAC, and good hearing. And as I've shown in our series, we're at 80%, and the outcomes have been improving gradually. So here are the hearing preservation techniques that I use. So I usually start the patients on nimodipine before surgery. There is some fairly weak evidence, and it's been published, that if you start them, it's maybe a vascular insult when you lose hearing from the vestibular artery and or the auditory artery. And so we'll use nimodipine. We'll start them on nimodipine. We use ABR. I must admit, I don't have many instances where I've preserved hearing if the ABR is gone. We do things like we raise the blood pressure and we put papaverin on the nerve, but rarely will recover it after it's lost. We open up the IAC widely because for the reasons I mentioned before, you want to be able to lift the tumor out without pushing on the nerves, decompress the tumor, careful dissection medial to lateral, so we don't pull the fibrils of the cochlear nerve as they're going into the perforated bone at the modiolus. And then blood pressure management. We don't let them get hypotensive is the most important thing. We keep the MAPs elevated during the surgery. And I use a dilute papaverin solution, 1 cc of papaverin to 10 cc's of saline. And then we keep them hydrated. It's like operating on an unruptured aneurysm in my mind, where we're trying to keep the vessels full post-op. I've had cases where I've lost hearing the day after surgery, which must be vascular. So I think this is a reasonable option. We have good hearing preservation rates, 80% in our most recent series. And I think these radiographic factors that I've mentioned and I've gone through are important to recognize before you offer the treatment. This is obviously a single surgeon cohort. It needs to be reproduced by other centers. And the final thing that I just want to leave you with is whether you use any approach. And I think the surgeon needs to be facile with the retrosigmoid, a translab, and a middle fossa. Try to preserve the cochlear nerve because we can often put in cochlear nerve implants. And even in cases where you've lost the ABR, the cochlear nerve implant can work in people, in some people. So, and then the real issue too with radiation is, are we radiating the cochlea as well as the nerve, which can be really a fatal problem for hearing, even with a cochlear implant. So I'm not going to spend any more time on that, but try to preserve the cochlear nerve, and we'll use that even now with translab cases. We'll try to keep the cochlear nerve and put a cochlear nerve implant either simultaneously or after surgery down the line. The data is very good. And finally, I'll just show you, I think this case represents a very important case. I guess it won't play. I apologize. It was that giant tumor I was going to show you, but we're running short of time anyways. But I was going to show you the importance of understanding all the approaches to vestibular schwannomas so that you're familiar with the anatomy and you can use whatever approach is the best for that particular tumor. Let me see if I can find that video. I'm happy to answer any questions for you.
Okay, is there any question from panelist?
Yes, if no one is asking a question. Well, I mean, this has been propagated by Professor Sami almost 2 or 3 decades ago, and we used to sort of snicker at him a little bit, but he is right. And I mean, the issue was always people say, well, if you don't have useful hearing, what is it worth preserving it? But actually just hearing the sounds seems to be important. Like you said, it's a quality of life factor. And we should, if we really have a case where we should be able to preserve hearing, we should perhaps, you know, get into the habit of doing it. And I really, I'm very grateful of you bringing back the middle fossa approach, which is has been sort of having had a little bit of, it was neglected probably for most people. My question is, what are you going to say to all the colleagues who just, they get a patient, 35 years old, let's say, has a 1 centimeter tumor, has a CSF cap in the canal. And now, of course, if we want to remove this, we should do hearing preservation. And then they say, well, send it to radiotherapy. What do we have to tell these kind of colleagues who give that kind of advice?
Yeah, I know, I agree with you. I think that this has become the norm in much of the world, as you know, is to just go ahead and radiate the small tumors. So the importance, I think, is that, like, we don't offer treatment for incidental tumors at all. We just watch. But
right.
if you radiate that tumor, you are committing them to hearing loss, and that's what you need to remember. Now, say, well, that's not such a big deal, but it is a safety issue. It's localization of sound, as you mentioned and you emphasized. So I just think it's an evolution of our thinking about these tumors, in that we should be more cognizant of trying to preserve hearing, just like we've done with smell, for instance, you know. And I think it's a safety issue with smell as well, just like it's a safety issue with sound. And so I do think that, I think if more people thought about this and were familiar with the approaches, it would be better. Now, you can do the same thing as, and Professor Sami, as you know, doesn't use a middle fossa, he uses a retrosig. The advantage of the middle fossa is that it gets you out to the end of the canal easier, and you can see this end of the canal. The disadvantage of the middle fossa is that you have to manipulate the facial nerve more because it's lying on top of the tumor. And so that's the downside. But if you look at my series, the facial nerve is not the issue. I think we had 94 or 96% grade House-Brackman 1 or 2 face. So, I mean, I don't think that's the major issue. I think really it's trying to get the tumor out properly and preserve the hearing. So I think we're all learning. This is an evolution. And I offer it to people to think about this as a way of preserving quality of life. That's all. And as I said, this is only a minority of the patients that we do with acoustics.
Yeah,
I'm just
absolutely.
Yeah.
So in your criteria, you actually mentioned that you would not like to see the tumor protruding more than 1 centimeter into the cistern. But you could get out through the middle fossa approach, just like through the translab, you can get a bigger tumor out, but then it's not really a candidate for hearing preservation. If that's what you're saying, right?
Well, I'm saying, yeah, it's harder to get the tumor. So when you come to middle fossa, what I look for is where the tumor is coming out of the vestibular nerve. And it's harder to see that interface through the middle fossa when the tumor is bigger. Okay, that's the problem. And so what I like to do, and Fukushima was the one that talked about this initially. There's a V that's present. You go down to the medial aspect of where the tumor is arising from the nerves, and you find the interface after you've removed the gut of the tumor and debulk the tumor, and then you can bring the capsule up from the medial side to the lateral side. And that interface is difficult to see when the tumor's more in the cistern. It's just a longer reach and you don't have the same view. You're looking down the tumor.
What about those patties that you use? Can we just use ordinary cotton or?
Yeah, you can. The only advantage of those patties, they're really thin. And what we're using, I'm using them to just peel the arachnoid down, and they're actually retractors. I need to write a technical note. So you put the patties around the tumor, you bring them underneath the tumor, and it lifts up the tumor and protects the brainstem as well. So when you're using your CUSA, you don't go through and you don't hit the brainstem or the facial nerve. So for bigger tumors, I use it as a dissection device and a retractor.
Well, thank you very much. It's an excellent presentation, and I hope we will hear more from you, and we can convince all our colleagues to get back into acoustic surgery in
That's the key. That's the
seriousness. But you know, we get all these discussions now that some of my colleagues they're even thinking of buying a gamma knife, and it has its applications, but perhaps not benign tumors if we can avoid this.
Right. Exactly.
Okay.
Thank you.
Thank you very much.
Thanks, John. Thanks, Professor Sameh.
Thank you. Thank you, William.
Thanks a lot, Professor Kodel, for this excellent presentation. And now we will shift to next speaker, Professor Zelda. Please start sharing your screen. Thank you.
Thank you very much for the very kind invitation. It's always a pleasure to be here and amongst this wonderful panel of speakers and great audience. So thank you. And I'm just going to check if you see my screen well and hear me okay.
Yes, perfect.
Thank you. So we are going to talk about today about the cavernous sinus, and especially what are the specific relationships with the pituitary gland and how we can apply that to the surgery. And the most recent indication, especially for pituitary adenomas that are functioning pituitary adenomas. So just to look at what we already know, when we take out these big tumors, we're used to seeing, the anatomy from this point of view, where we have peeled the cavernous sinus and we have all this anatomy of the optic nerves, optic hiatus, the carotid artery. And this is, our classical transcranial view of the region around the cavernous sinus for resection of these big tumors. And so then we studied the anatomy, very complex anatomy that we are familiar with, and the relationship of the cavernous sinus, the orbital apex, and the orbit, and all these anatomy and the relationship of after we take out the clinoid through the optic strut to the lateral optic carotid recess that we see through the endoscopic approach, that gives access to the cavernous, to the sphenoid sinus, and therefore we've learned the anatomy the other way around. And also an access to the cavernous sinus through the orbit, through a lateral contotomy, or a eyelid approach with lateral extension, where we can see that we have access through the superior orbital fissure all the way through the greater wing of the sphenoid, and even using the endoscope laterally in the orbit through the superior orbital fissure, the optic nerve, the anterior clinoid, and also the cavernous sinus. This is the inferior aspect of the cavernous sinus. That's V1. That's the middle fossa, V2 and V3. So we really have different ways to get into the cavernous sinus. And of course, one of them is the endoscopic endonasal approach. And the advantage is that we have, the carotid, the pituitary gland, and then the carotid, and the nerves are lateral to the carotid, and that's a main advantage. So what are the two aspects that we're going to discuss about in this talk are, the transcavernous approaches to get through other areas of the anatomy, and with pituitary transposition very briefly, but specifically, I'm going to talk about the proper approaches to the cavernous sinus, and in particular, how we can safely remove the medial wall of the cavernous sinus, and what are the attachments and the vascular relationships that are extremely important for a safe resection. So if we look at the cavernous sinus from above, this is the classical anatomical view from our lab of the optic nerve, the carotid artery, and the diaphragm of the sella, with the roof of the cavernous sinus just below the supraclinoid carotid, and the relationship that we know of the third nerve. And this is the interclinoid fold, the posterior petroclinoid and anterior petroclinoid fold. And we can see the protrusion of the anterior clinoid and the posterior clinoid. We do not see the middle clinoid that is at that level inferiorly. And just paying attention, when we remove the anterior clinoid, we can see all the way, this is the carotid oculomotor membrane, and this is just inferior to the clinoid. When we remove the anterior clinoid, if we are stimulating if we are monitoring the third cranial nerve, we can find constantly stimulation just after removing the anterior clinoid, and we see the oculomotor nerve just coming and piercing the roof of the cavernous sinus, and by transparency, just under the carotid oculomotor membrane, we can see it right there going towards the orbit, and the carotid just medial to the nerve. And this is going to be important to remember this anatomical relationship for from an endoscopic endonasal view. The interclinoid ligament between the anterior clinoid and posterior clinoid is variable in density and strength, and that is a very important landmark for the oculomotor nerve that is just lateral to it, and we are going to see that from an endoscopic perspective. Once we remove and we lateralize, we open the roof of the cavernous sinus and we lateralize the oculomotor nerve, then we get into the cavernous sinus with its venous channels. And what we can see when we remove the contents of the venous contents of the cavernous sinus, represented by the latex injection here, we see some of the ligaments right away that come from the pituitary gland and wrap around the carotid artery in a superior branch and an inferior branch. And the superior branch of this ligament wraps around the carotid and attaches to the third nerve right here. We've opened that already. And then there's an inferior branch that wraps around the carotid and attaches loosely towards the sixth cranial nerve. So these are two important relationships as far as ligaments of the gland in the cavernous sinus. And also we have to pay attention to the inferior hypophyseal artery, that is this branch here. The meningohypophyseal trunk is very variable. We see one of the variations right here, where we see that as an independent trunk with the dorsal artery as well. And this is something that we need to really pay attention to when we are removing the medial wall of the cavernous sinus. Sometimes it requires coagulation of these little vessels, sometimes it doesn't. So if we look at superiorly at the dissection on the other side, if we look carefully, there's another ligament that is variable, that not only there's the anterior ligament that, as I said, on the right side of this specimen wraps around the carotid, but there's another posterior ligament that is related to the posterior band of the carotid and the horizontal segment of the cavernous carotid that also has a confluence around the sixth cranial nerve as it comes through the cavernous sinus. And another inferior ligament that is related to the inferior hypophyseal artery. And so these anatomical relationships are extremely important. And now looking at the right cavernous sinus from a medial to lateral dissection, this is the hypophyseal artery, and we have the anterior band and posterior band of the cavernous carotid. And we have the sixth cranial nerve all the way exposed here on the third nerve. And V1 is going to be just in the wall, just lateral to the sixth nerve right here. We can see the inferolateral trunk there coming from around the anterior band of the carotid artery. And that's going to be a very important relationship for safety of these procedures. This is another view after removal of the pituitary gland, where we see, coming out the inferior hypophyseal artery from the meningohypophyseal trunk. And we can see the different compartments of the cavernous sinus from an endonasal point of view, and there are different classifications. We just think that it makes sense to call them the anterior compartment versus superior compartment. And this is a beautiful work of Dr. Fernandez Miranda about this, just in between the two bands of the carotid. And there's an inferior compartment where we can find the inferolateral trunk, and then a posterior compartment where also and through these compartments, the pituitary tumors very frequently extend through and towards the cavernous sinus, either pushing the medial wall or invading the medial wall of the cavernous sinus. So if we remove the carotid artery, we can definitely see the vessels coming from the cavernous carotid, the inferolateral trunk that we know is related to the inferior aspect of the anterior band of the carotid artery. And here we have a nice view of the third nerve, the sixth cranial nerve, with the sympathetic branch here, and V1 is going to be just in the wall, just laterally, and this is V2 that comes into view. So beautiful paper from some of the Roton Fellows as well, and Dr. Rivas, where we can see a beautiful representation and very schematic of the walls of the cavernous sinus, which is essential to understand really the medial wall of the cavernous sinus resection. So we see the periosteal layer that covers the carotid artery and the pituitary gland, and the medial wall of the cavernous sinus is no other than part of the meningeal layer that really involves and surrounds the pituitary gland. So it's really the layer that faces, the only dural layer that faces the cavernous sinus, that is densely attached to the pituitary capsule, but it's a different layer and is loosely attached to the carotid, but the ligaments of the gland are going to be key in dissecting and resecting this medial wall. So this is a picture, an anatomical dissection showing the pituitary gland and the cavernous carotid on both sides. And this is going to be completely covered by this layer of this periosteal layer. So here in the pituitary gland, we know that we have a periosteal layer here in the anterior and inferior aspects, but there's another layer underneath that is surrounding completely the pituitary gland that in this aspect medially facing the cavernous sinus is forming what we call the medial wall of the cavernous sinus. So if we incise the dura here, we're going to go through 2 layers of dura. Well, whereas if we incise the dura here or the dura over the carotid, we are only going through 1 layer of dura mater. And that's very important to understand our approaches to or through the cavernous sinus. So here on the right side, we have the pituitary gland and the carotid artery. So now we shifted towards opening instead of performing when we want to go. And now I'm going to show the pituitary transposition that has been well described. But what we do instead of performing, starting by an incision here through just the 1 layer of the dura, we incise here. There's an inferior intercavernous sinus that is very constant, and there's an anterior, also called superior intercavernous sinus here, and they both connect one cavernous sinus with the contralateral cavernous sinus. So we open just the superficial layer of the dura here, and we get a 90-degree feather knife that I'll show how it looks like. You may be familiar with it. We can safely open in midline and get into the intercavernous space and just follow it towards the cavernous sinus and really open it in a nice and safer, potentially safer way, rather than having sharp opening just besides the carotid artery. So we open sharply here, and then we get a 90-degree feather knife that has a very gentle tip, which is not sharp, and I'll show that how that looks like. But when we open the wall of this dura of the cavernous sinus, then we can see the inferior hypophyseal artery coagulate and divide it, and then we get nice access to the posterior clinoids where they can, and the dorsum where they can be removed. And this is the 3rd cranial nerve, an interclinoid. We have to detach the posterior clinoid from the interclinoid ligament and remove in that way the dorsum and the posterior clinoids. And then we can open the dura and we see the 3rd cranial nerve and PCOM, and the interpedunculaire system is cistern is right there. This is the classic view of the cavernous sinus contents going towards the superior orbital fissure with the 3rd nerve, the 6th nerve, and V1, and the bends of the carotid artery. So this is what I was describing as the technique to open in a potentially safer way the cavernous sinus. And the key is to find the inferior intercavernous sinus, and you can see it's just below the bulge in between the anterior and wall and the floor of the sella. So you open with a sharp knife, and then you get a 90-degree feather knife that has, and that is this device. So we open here. So this device is a feather knife that Dr. Paul Gardner designed that is really gentle at the tip. So it does not cut at the tip, but it cuts on this surface. So by traction, you cut the dura and you avoid any sharp object around or knife around the carotid artery. So this is a case in which a patient had a history of lymphoma, and this image in the cavernous sinus, and we needed a biopsy, ended up being just a meningioma, as was one of the differential diagnoses, but we open in midline. So this is a sharp knife in midline. This is the paraclival carotid. And then after opening with the feather knife, we were able to get an appropriate tissue diagnosis. So if we look at so this is an oblique cut of showing this anatomy. This is the left cavernous sinus seen from the anterior aspect. So this is the anterior band of the carotid and the posterior band. And here what we've done is to remove the pituitary gland, just keeping the medial wall of the cavernous sinus. So we see this is really a very thin, translucent piece of tissue that really separates the pituitary gland from the cavernous sinus. So this is what we call the medial wall of the cavernous sinus. We're going to go through in detail all the ligaments of the gland that sometimes we have to divide, sometimes not all of them, but to get to a nice dissection, a deep dissection of the medial wall of the cavernous sinus. So again, this is the same picture of the dural wall, the periosteal layer of the pituitary and the cavernous sinus. And then we open in midline and we go through with a feather knife to open the proper cavernous sinus. This is the inferior intercavernous sinus, again, gives a great access to the cavernous sinus. And here we can see folded, this is the periosteal layer, and we can start to see this is the medial wall of the cavernous sinus. So it's really just the dura that surrounds the pituitary gland facing the carotid artery. So there are many variations of this, and you're going to see these are ligaments that are attached to the medial wall of the cavernous sinus. And in some specimens, even some sites are different than others. So here on the right side, we see very thick ligaments, but on the left side, these ligaments are very thin or a lot thinner than here. So we've preserved just this square periosteal layer. We've removed the rest of the periosteal layer covering the cavernous sinus and the pituitary gland. And this is the meningeal layer all around the pituitary gland. So the medial wall of the cavernous sinus is this thin, translucent, very thin piece of dura that is covering the pituitary gland in this area. So this is another specimen, different configurations. But what we can see is that if we remember the previous image that we talked about, this is in another specimen. We can see many variations of these ligaments, but this is the right cavernous sinus from an endoscopic perspective. So we have an inferior ligament that is not as constant, but is very thin and really goes to the periosteum of the paraclival carotid. Then we have another main ligament, which is superficial, meaning anterior, and was also studied by Dr. Fernandez Miranda as well. And we see two different branches, one that wraps around the anterior band of the carotid and is confluent on the sixth cranial nerve, and the superior aspect of it that wraps around the carotid artery and goes towards the third cranial nerve. So this is an important landmark, and this is in continuation with the medial aspect of the inferior dural ring, which is incomplete in this area. In this specimen, concretely, we had a carotidoclinoid ring, which is the ossified bridge of the carotidoclinoid ligament. And what that is a bridge of bone or a ligament in between the anterior clinoid and the middle clinoid. If we remember, the middle clinoid is really located at the upper part of the C shape of the carotid artery. So in this specimen, it's quite inconstant to find, but it's not very rare. We find that in preoperative CT scans, we can see that quite clearly when the patients have a carotidoclinoid ring. Equally important to know that for either an anterior clinoidectomy through a transcranial approach or middle clinoidectomy through an endoscopic endonasal approach. This is a posterior ligament, so we are going deeper in the ligaments of the gland that also goes behind the carotid, mostly related to the posterior band, and goes laterally and also joins the oculomotor nerve and the sixth cranial nerve right here. So this is another view of this posterior or deeper ligament that has an inferior confluence here towards around the carotid and towards the sixth cranial nerve. And we can start to see the inferior hypophyseal artery and how this is inferior to this posterior ligament. Quite often, we also find an inferior hypophyseal ligament or a ligament that is closely related to the inferior hypophyseal artery. So very important to know this attachment when we are removing the medial wall of the cavernous sinus. If the tumor goes and faces this area posteriorly, we may need to divide, coagulate this artery, and also we're going to have to divide this small ligament. So if we look at the superior attachment and this ligament that wraps around and continues in the same plane as the inferior dural ring, the medial aspect of it. In continuation posteriorly, we can see the interclinoid ligament, and this is the ligament that we saw earlier between the anterior and the posterior clinoid processes. So it's variable in strength, it's variable in thickness, and sometimes we can see that very nicely, and sometimes it's difficult to see. So these are examples of few examples of tumors where we can see that this tumor really expanded in between the upper and lower aspect of the band of the carotid artery, between that space in between the anterior and posterior bands. And this is the postoperative after resection. So this is a patient who was many times operated, a couple of times operated, silent corticotrophous adenoma, and we can see that the tumors many times if they are larger, they just invade the medial wall of the cavernous sinus and certainly make that quite either quite thin, or they just go through that and there's no medial wall that we can really see. Here there was an incomplete medial wall that we could find, and was a lot of it was pushed laterally, and then we also found a tumor on the cavernous sinus on the left side. So this is how that again, third time reoperation, a new patient to us, but certainly had a couple of procedures. But we can see here, so this is the diaphragm of the cella actually, and we can see the carotid and the tumor. We already removed tumor from here. This is the posterior compartment, the anterior band of the carotid, the posterior band of the carotid, and this is part of the medial wall of the cavernous sinus. The tumor has invaded this aspect and opened directly through the cavernous sinus, also has invaded the posterior aspect of the medial wall of the cavernous sinus. This is going to the other side, a little bit of a CSF leak here, but we can see, removal of part of the medial wall of the cavernous sinus, and here through the procedure, kind of removing, part of the tumor here, and then nearly the end of the procedure with the carotid exposed. This is the postoperative view, and we give gamma knife to the right cavernous sinus, small residual. And just getting to the end of the talk, I want to show, this is a video of the dissection. Sometimes I find it's difficult to fully understand the complexity of the dural layers and the ligaments of the gland. So this is, again, in this specimen, we have a corticoclinoid ring, and this is how we open get access to the cavernous sinus. So we sharply divide those ligaments. So these are the ligaments, and this is the periosteal layer. So we see these ligaments that wrap around the carotid and have a confluence in the third, and this is the sixth nerve. This is the posterior ligament or deeper ligament. This is the part that is facing the oculomotor nerve and the sixth cranial nerve. We see the inferior hypophyseal artery, and we see the superior branch of this anterior ligament that has a confluence around the third nerve. And once we remove that, we can see that the inferior hypophyseal artery is related to the inferior aspect of the dorsum and the posterior band of the carotid. If we incise just this is the third cranial nerve, and this is the posterior clinoid. So just to open and to see exactly what where we are intradurally, just lateral. So this is a very small PCOM, and this is the third cranial nerve that has been completely dissected. And this is the area where we just opened the dura. This is the other side, where this is our opening of the dura, just reflecting the periosteal layer. And these are the ligaments, and this is starts to be the medial wall of the cavernous sinus. So in this case, the ligaments are very thick. Again, it's really variable, can vary from very thin ligaments to very thick, like in this case. So we know that they're going to be attached to the carotid, surrounding the carotid, and then going towards the nerves. Again, inferior hypophyseal artery, the posterior, a posterior ligament, the anterior ligament, showing its relationship with the carotid. So when we divide that ligament, those two ligaments, this is the posterior one. We can see also that the relationship with the lateral aspect of the carotid, and here this continuation of the ligaments is related to the inferolateral trunk. So when tumors go around the carotid and we are gently displacing the carotid, we have to be very careful not to abolish that little branch coming off the carotid. This is a better view of the third cranial nerve, just lateral to the carotid. And this is a view, again, a larger intradural view with the carotid bifurcation here. And then this is the optic tract and the perforating arteries around it. So this is the window that we have just posterior through the cavernous sinus. So this is a 65-year-old with acromegaly. So and a small tumor around the very touching the carotid artery, but we didn't think that there was much of an invasion of the cavernous sinus in this case. Most likely we expect the medial wall to be pushed, but certainly we have to remove the medial wall that is around, or better say the meningeal layer that is surrounding the tumor, to make sure that we get as much of a surgical likelihood of surgical cure as possible. So in this case, what we do, we find that it's difficult sometimes to find the medial wall of the cavernous sinus after resection of the tumor, because often the cavernous sinus may be collapsed and the wall tends to be more attached to the carotid artery. So for that reason, what we end up doing is opening. So this is the opening midline, and this is the feather knife. And we just went intercavernous in the inferior intercavernous sinus. And these are the ligaments of the gland. And this is opening the periosteal layer. We put some hemostatic gel thrombin powder. And this is just getting into the resection of the tumor as usual, with dissection and usually gentle dissection and suction. So this is as usual. The only difference right now is that we have referenced the cavernous sinus before resection of the tumor. So here this is the medial wall of the cavernous sinus, and we want to remove also part of the inferior aspect of this meningeal layer because the tumor is attached to that. So between, careful dissection and sharply dissecting that as we feel is safer, is a very thin layer of tissue. It's not as thick as the dura. So this is the part of the medial wall that is really facing the tumor. And this is what we need to remove. In this case, we usually get, so it's very, very thin. So we usually get this as a separate specimen. And in this case, this patient did not have invasion. It was -4 tumor. We sent specimen from the medial wall. We sent specimen from the floor. We did not think we needed to go in this case to coagulate and divide the inferior hypophyseal artery. And we just recently got her labs back after surgery. And she is in remission with normal IGF-1 and GH levels. So this is, the area that we've been talking about, and all different complex and variable ligaments around the gland. And I just wanted to thank very much the organizers and for the privilege to be here, and also invite you to the upcoming skull-based course at the Mayo Rochester. Thank you. I'll take any questions.
Thanks a lot, Professor Silda, for this excellent presentation and new concepts and specimens that you have showed us. Professor Woodley, I see you starting to question.
Well, I don't know. Nobody else is saying anything. But actually, Maria, we met I think in New Orleans. I don't know whether you remember. I'm very happy to see that. Yeah, I'm very happy to see that you've gotten quite famous now, and
I don't know about
got all these titles and really very, very nice. So, but what you're describing is really a very specialized area, this technique of displacing the pituitary, which has been around for five years or something. So it is really useful in acromegaly, just because they are the ones that really need a radical resection, is it? Is there any other sort of, what do you really clinically, where can you apply this type of...
And I thank you for the question. So it's really for functional tumors, especially, Cushing's, acromegaly, and also like many times now we are seeing more and more people who don't either don't respond to prolactin, or they have adverse effects. To cabergoline, or they have adverse effects for prolactinomas, and we are operating some of these tumors again. And the Stanford and the Pittsburgh group have shown that really makes a difference in resection, whether you are radical with that, and have shown quite good evidence for invasion of these walls. So anything that we can do to cure these patients. And I also get a small microshaver, the Nicomyriad, to kind of remove a little bit of the parenchyma of the gland that is just in the surface, in the intersurface of the tumors, to kind of achieve a more radical resection.
Well, we should name one of these ligaments after you then, Maria's ligament.
No, I don't think so.
Thank you. That was all.
Thank you.
Is there any other question? Thanks a lot, Professor Zelda, for excellent presentation and discussion. Thank you.
Thank you very much.
And now we will reach the end of first day of Brain Day, 7th EWNC Academy anniversary. And we will meet you again tomorrow, 1 p.m. Cairo, to start another journey with Spine Day. Have fun. Thank you.
Hey, Sam, what do you think? It went well, huh? What do you think, Sam?
Fabulous. Fabulous. It was great. That
Well, you know, I know it takes a lot of organizing. I really appreciate what you've done. It's a lot of work, and people, I think, realize how much it is you do. So, okay, we look forward to tomorrow, and we'll see you tomorrow, same time.
Okay. Thank you, Dr. Woodley, for discussion all the day.
Yeah, and Martin, you are an ace. Thanks a lot. We need to hire
Oh,
you.
well, I just, you have to entertain people a little bit as well, because these sessions are quite long. And I noticed that some of the more famous speakers do not attend all of it. But anyhow,
Well, it's
I'm
good
not
to have
that
you.
famous. So that's okay.
Yeah, you're an asset.
Bye,
to
Maria.
have.
Bye,
You're an
bye.
asset. Okay, see you tomorrow.
Bye. Great to see you all. Thank
See
you.
you tomorrow.